Hello, hello, hello. How do you check? Maral, please Maral. Kaya hindi ko
May basic lang. May basic lang. Check, check. Check, check.
Check, check. Okay, thank you. Yeah, that's fine.
Hello. Check.
check check this check this is check. Check this is check.
ஹலோ ஹலோ ஓகே ஆடியோ செக் ஹைட் ஜாஸ்தி இருக்கா ஆ ஹலோ ஹலோ ஹலோ
Good morning. I'm very excited to welcome you all to the first national conference.
This is the ALFED score, or the Acute Liver Failure Early Dynamic Score, which again is another useful scoring system in non-paracetamol liver failure. The King's College criteria, all of those of us who are MR-Chem aspirants would be quite familiar with this. This is used to prognosticate patients for the need for liver transplant in those with paracetamol-induced liver injury. We commonly hear about the Child-Pugh score and the MELD scores for liver disease. These are not used for ALF. That is because the Child-Pugh score only looks at chronic liver disease mortality, and the MELD score predicts survival after TIPS procedure, both of which are associated with cirrhosis and are not coming under ALF category. So those are the scoring systems. Coming to the clinical considerations in ALF. So in India especially, we have hepatitis E being the most common viral etiology. Other etiologies are hepatitis A, hepatitis B, or even CMV. In the West, and increasingly in India, paracetamol is an ever-increasing etiology for liver disease. And our country being endemic for tuberculosis, a lot of patients come with ATT-induced acute liver failure as well, along with other drugs which may be mixed into illicit over-the-counter drugs, may also cause ALF as well. Alcohol, we know, is a very common cause of ALF. And shock liver in the case of sepsis, ischemic liver, HELP syndrome, heat stroke, and in the West, Wilson's disease are all common causes of ALF, aside from the idiopathic causes. The signs and symptoms, the three main ones are abdominal pain, jaundice, and altered behavior, according to the guidance which I put on the board. The guidance here, or the grading here, is very similar to hepatic encephalopathy seen in CLD. We would look for asterexis, we look for change in sleep pattern, and increasing levels of obtundation as the patient presents. So way back in 2013, this is a picture taken from the NAJEM. Way back in 2013, they realized that ALF is not restricted to just the liver. It is a multi-system disease which can affect everything from the brain to the blood to the adrenal glands to the kidney to the immune system. It affects almost everything. So the treatment of ALF does, since it's a multi-system disorder, it requires a multi-system approach to treatment as well. When we send our blood panel for patients with suspected or confirmed ALF, we would look for an elevated INR of more than 1.5, signifying coagulopathy. We would look for marked raise in liver enzymes and transaminitis, sometimes in the thousands. OT and PT could go into the thousands. We would look for venous hyperammonemia and arterial hyperlactatemia. We'd also look for other metabolic dysfunctions like hypoglycemia and a dilutional hyponatremia. So with all this put together, how do we as ED physicians manage a patient with ALF? Like everything, we take an ABCDE approach. The airway and breathing, we would intubate the patient if they are obtunded and the airway needs stabilization. But the challenge here is most of the drugs which we use for intubation are actually metabolized in the liver. So that could actually cause even further liver damage and prolong the effect of sedative drugs. So two drugs which have been found to be useful here are propofol and cisatracurium. Propofol does have significant extrahepatic metabolization and is liver safe. Cisatracurium is metabolized by the Hoffman reaction, which is independent of any organ system. So these two drugs can be used for intubating these patients. We would also like to avoid NIV as it may worsen the ICP and worsen encephalopathy. It could be dangerous in patients with decreased sensorium. So for circulatory management, we would use NS instead of ringolactate or Hartmann's. This is because balanced salt solutions contain lactate, which will not be metabolized in a failed liver. You would not want to worsen metabolic acidosis by giving the patient more lactate. You would give early noradrenaline as the shock and liver dysfunction is primarily distributive instead of septic. You would maintain a reasonable map for cerebral and renal perfusion. You could consider steroids due to adrenal dysfunction secondary to ALF. We would keep the patient head elevated to prevent raises in ICP. We'd use propofol and fentanyl infusions for sedation, maintain normocapnia and give lactulose to prevent further hepatic encephalopathy, and you would correct sodium and sugars as required. Now there was an interesting discussion about N-acetylcysteine being used for paracetamol-induced liver dysfunction. We know that that's a standard of care. However, a meta-analysis by Lee in 2016 actually showed that N-acetylcysteine could be used for all cases of ALF, not just paracetamol-induced cases. So NAC should be given for all cases of ALF regardless of etiology. We would prevent hypothermia. We would consider vitamin K OD, although it may take some time to get into effect. We'd give mechanical DVD prophylaxis by compression stockings, and we should avoid blood products unless clinically indicated. In other words, unless there's bleeding. This is the NAC regimen, which I think all of us are familiar with, so I'm not going to go too much into detail. We would aim to give the patient 300 mg per kg of NAC in 20 hours. And of course, the differential diagnoses which have to be considered are acute cirrhosis, preeclampsia versus eclampsia, a shocked liver in the case of sepsis or multi-organ dysfunction syndrome, and an autoimmune hepatitis. There is some discussion about hepatorenal and hepatopulmonary syndromes, which I will not go into detail here, as they are associated with chronic liver disease, not ALF. In conclusion, ALF is a rapidly progressive multi-system disease. It has a very high morbidity and mortality unless picked up fast. ED recognition and management is paramount. That early management is what's going to keep the patient alive till the patient reaches the ICU. And as always, our bread and butter is ABCDE. We should maintain ABCD for these patients as well. Thank you.
Thank you, Dr. Sandeep. This topic was much essential for the EM. Rightly said, well spoken about this. I now next welcome the next speaker, Dr. Rahul, who would be talking us regarding the resuscitation of cardiac arrest victim with pacemaker in situ.
Good morning, everyone. My topic is on resuscitation of cardiac arrest victim with pacemaker in situ. Now, first when I got this topic, first what I did is, for learning objectives, I asked the residents what they know and what doubts they have. And the first questions that I came across is, first one is causes of pacemaker dysfunction in the ED. Then, can we give CPR to a patient with pacemaker? And the next was whether we can give defibrillation to a patient with pacemaker, and the potential problems after defibrillation, and also regarding the steps of resuscitation, whether it is successful or unsuccessful. First one, a brief discussion on pacemaker. First one is a pacemaker. Pacemaker is a device that signals the heart to beat when the heartbeat is too low or irregular. Next is, it serves to maintain or restore the myocardial depolarization and maintain the adequate cardiac output. And now regarding the components. The components of the pacemaker mainly include the pacemaker pulse generator, then electronic circuitry for sensing as well as pacing, and then we have a lead system which connects the pulse generator to the electrodes. And this is the one which stimulates the myocardium. And lastly, it is the lithium ion cells. Now, recent advance is a leadless pacemaker, which you can see as an receiver electrode there. And in this, there will be a co-implant, which will be only sensing, and there will be a transmitter, which will give ultrasonic waves, which will be, these ultrasonic waves will be converted to electrical waves, and this will stimulate the heart. This is the leadless pacemaker system now. So this is pacemaker code, which everybody will be knowing. The first, from this coding, we can know about the chamber paced, whether it is single chamber paced or double chamber, and also regarding the sensing, whether it is single chambered or double chamber, then response to sensing, whether it is triggered, inhibited, or dual. And there are anti-tachycardia functions as well as rate modulation functions, but the most important is actually chamber paced, sensed, and response to sensing. So from this ECG, you can see the first one is atrial pacing, where you can see the sensing and as well as sensing, after which a P wave is there. And in ventricular pacing, you can see the pacing is there, as after which a QRS wave is formed. And now moving to the topics. First of all is the pacemaker malfunctions, due to which this resuscitation is important. And first is mainly structural malfunctions. This is mainly due to the component failure. Next is the functional malfunction, which is first one is the failure to sense. The pacemaker won't be sensing the cardiac impulse. Then failure to pace as well as failure to capture. And in this, the failure to capture means the pacemaker will stimulate the ventricle, but no ventricular depolarization is seen as per. So now coming to the topic per se, resuscitation in patients with pacemaker. So first one is how to identify a patient with pacemaker in EMD. In outside countries, as well as in India, when a patient is having any medical device, he will be given an alert card, which in ED, since the patient is coming unconscious, it is not appropriate to ask them. But how we identify a pacemaker is a good inspection of the chest will reveal it. How? Because most commonly it is pacemaker generator is attached to the left side of the chest, just beneath the clavicle. Next is the right side of the chest beneath the clavicle as well as in the abdomen. So these are pictures where you can see the pulse generator, which is kept subcutaneously. And now regarding resuscitation protocol, we actually we have to follow the BLS guidelines itself. We have to first identify when we recognize a cardiac arrest, we have to see for scene safety, call for help. We can even perform CPR in the center of the chest in the lower 1/3 of the sternum, and that too high quality CPR should be performed in these patients, and we should not worry about anything regarding the pacemaker placement being changed. So now regarding the defibrillation, the external defibrillation at recommended strength can be safely performed in all the patients with pacemaker, and that too normal positioning of the defibrillation pads can be done. That is because the pacemaker is most commonly kept on the left side of the chest beneath the clavicle. You can easily keep the pads on their right side just beneath the clavicle as well as on the apex of the heart. The only thing is that the pads should be kept 8 to 10 centimeter away from the pulse generator so that electromagnetic interference won't happen. And alternatively, you can also keep the pads anterior posteriorly, as you can see in the picture. Next is all the patients who are successfully resuscitated. All these patients, for these patients, actually the placement of the pacemaker should be checked after resuscitation, and for that a chest radiograph need to be done to ensure the positioning of the pacing catheter. And in the X-ray, you can see the pulse generator, the leads, as well as the atrial and the ventricular electrodes also. So after resuscitation, sometimes there won't be immediate return of the pacing. This doesn't mean that the pacemaker, it is due to pacemaker malfunction. It can be mainly due to the global myocardial ischemia and also those due to the increased pacing threshold. Next is temporary pacing if needed can be given for these patients. And also since we have kept the pads beforehand, we can give transcutaneous pacing through these anterior and posteriorly kept pads itself. And in any attempt of transvenous pacing is usually not necessary because it will unlikely to be successful because it is not under fluoroscopic guidance, and this may also dislodge the permanent catheter. And if you are doing a transvenous approach through the neck, these patients might be having a chronic venous thrombosis which can get dislodged even though it is asymptomatic in these patients. And if you are going for a femoral vein approach, then it will be difficult because the permanent implanted catheter may prevent the entry into the right ventricle. Now, next is the problems after defibrillation. Mostly the pacemaker inhibition due to reversion to noise mode. That means there will be a refractory asynchronous mode due to which continuous atrial as well as ventricular pacing will be done. And next is reprogramming. Due to the defibrillation done over the pulse generator, there can be a deletion or reprogramming of the pulse generator. Then there can be circuit damage as well as the myocardial damage can be done, which will happen adjacent to the lead tip as the current is transmitting via the electrode to the myocardium. Next is in case of resuscitation failure, I wanted to emphasize on the removal of the pacemaker. Why? Because these pacemakers always have a battery backup which can burst during a cremation process. That is the first thing. Second thing is donation of the pacemaker, and mostly the pulse generator can be done. Nowadays it is done in India also. And also through this, from this pacemaker, almost 80% of the cases you can retrieve the data. And what we should know is that in US and UK, almost 25% of the pacemakers are donated after the patient dies. And in UK and US, they have a central registry which has been, they have started in the late 1990s, which is actually controlled by the FDA. And they are having proper registration of the pacemakers, the name of the people who are having the pacemaker implant, whether the implant is working or not, and also whether the implant is donated or not. All these registries are there in outside countries. But in India actually, out of all the South Asian countries, India has the most number of pacemaker implants. And India is having in 2017, it was almost 20,000 pacemakers implantation per year. But now, the last year data shows that it is almost 30,000 pacemaker implantation. But in worldwide, only 3 million is done, out of which 30,000 is in India. So in July 2021, under the Central Drug Authority of India, they have come across a new organization called the Central Drug Standard Control Organization, which is headed by the Drug Controller General of India. And under this, all the medical devices as well as the pacemaker, the repair, everything is controlled by them only. And here we can see they have enough registration data of ventricular bypass devices, the implant pacemaker generator, the pacemaker repair, even the pacemaker repair and replacement, the pacemaker lead adapter, and even the transcutaneous cardiac pacemaker should be certified under CDSCO. So this in summary. I have discussed about the causes of pacemaker dysfunction in ED, then about whether we can give CPR or not, whether we can give defibrillation or not, and also about the combined help after the successful resuscitation. There should be a combined help of cardiologist, pacemaker technician, and proper follow-up should be done. And regarding I wanted to emphasize on CDSCO and also for promotion of donation of the pacemakers. This is my reference. Thank you.
Hello. So thank you so much, and I invite the next speaker on the stage, Dr. Ashray, who would be speaking on low probability acute coronary syndrome. Dr. Ashray, please.
Very good morning to esteemed faculties and the delegates of the conference. I'm Dr. Ashray V from St. John's Medical College, Bangalore. My topic is low probability acute coronary syndromes, and I chose this topic because I myself, during residency and even as a faculty or a consultant, sometimes I'm boggled by this fact that we do have a lot of patients with a lot of risk factors for acute coronary syndrome, but initially when they present, they may not have anything suggestive of it. So how do we manage and dispose such patients safely to avoid any adverse cardiac events? Right. So I'd like to start off with a brief outline. So I'll be going through the following headings. That's an introduction, history and clinical features, diagnosis and management, risk assessment, disposition, follow-up, how to improve outcomes in our respective ERs, and also a brief summary. So as we know, chest pain is one of the leading presenting complaints to the emergency department, with about 7 to 8 million visits annually. And the evaluation of chest pain amounts to almost $5.5 billion in terms of cost of evaluation and treatment. Of these, 2 out of 10 people who present with chest pain actually have a cardiovascular cause for it. And now we move on to low probability ACS. So it's defined as patients who present with history of chest pain, suggestive of a myocardial ischemia kind of etiology with a normal ECG and initially normal cardiac biomarkers. So 5 to 7% of such patients can have a major adverse cardiac event at 30 days. So we have to be very cautious about them, make sure that they're disposed safely, which we'll be going about as I go through. And less than half of these patients actually require admission, remaining can be safely discharged. So history and clinical features, I think all of us are familiar that there is no single history that can either include or exclude an acute coronary syndrome. We definitely need to have a high index of suspicion. And a study done by Dr. Desmond and Dr. Amal Mattu in 2017 and their colleagues found that these are the symptoms which have high sensitivity and specificity. Basically, sensitivity being localization of pain, acute onset of pain, high specificity being pain radiating to the shoulder, arms, neck or jaw, dyspnea, diaphoresis, vomiting, hypotension and palpitations. So the diagnosis and management is actually quite simple. The first most important investigation to be done on arrival to the emergency department is an ECG, and a single ECG may not be accurate enough to rule out a low probability acute coronary syndrome. So an ECG along with a point of care cardiac biomarker will help us achieve a better specificity in diagnosing low probability ACS. So apart from the regular ST elevations or ST segment depressions that we see as a part of ST-MI or NST-MI, these are a few important ECG findings that we cannot afford to miss in the emergency department. So something known as the De-Winter syndrome, then a Wellen sign A-B, hyperacute T waves, which may be the initial presenting feature on an ECG, and a Garbosa criteria 1, 2 and 3, and also a shark fin pattern, which is very important. So in the setting of an ACS, do we also have to consider right bundle branch blocks? Well, a study done showed that 6 to 10% of patients who present with chest pain and a new onset RBBB may actually have an acute coronary syndrome. And a word of caution about new onset arrhythmias should also trigger a high index of suspicion. So cardiac biomarkers are now one of the most important diagnostic tests that we probably can do to identify ACS at an early stage. It should be done at all patients who are at high risk and also with suspected ACS. And the current recommended biomarker is a cardiac troponin. It could be a troponin I or a troponin T. And the current era which we are in right now is of high sensitivity troponins, which help us detect within 3 hours of onset of symptoms. And along, of course, with history and with ECG findings, it helps us achieve a better diagnosis of low probability ACS. So this is just a brief, this is a slide just showing the brief history of how evolution of management of chest pain and probably low probability ACS has come. From the 1960s, it was only based on ECG and history of chest pain. And then the early biomarkers like CKMB and lactate dehydrogenase, myoglobin. Then troponins came up in the early 1990s, and post 2010 we are now performing high sensitivity troponin Is, which have reliable values at 3 hours after symptom onset. So interpreting troponin results also is a challenge probably in the emergency department, because most patients do present with multiple comorbidities, and there could be other factors which can cause a falsely elevated troponin value. So especially patients who come with chronic kidney disease may have a falsely elevated troponin value because of decreased elimination of troponins. In terms of cardiac etiology, the other 3 differentials that we would consider would be myocarditis, chronic heart failure, and of course myocardial infarction. So this is just a graph which is on the left of the slide, which is showing the serial levels of troponin, and for myocarditis it would be a steep rise and a fall, chronic heart failure slightly a high normal value, and of course myocardial infarction a rise and then a plateau. So the next important, or I'd say cornerstone in managing low probability ACS is of course risk assessment, and as per the latest 2022 American College of Cardiology expert guidelines for chest pain management in emergency department, the 2 recommended scores are heart score and ED acute coronary syndrome score, and these are easily available and easily usable bedside decision making tools. So the heart score, I think all of us are quite familiar with this, has the following history, ECG, age, risk factors and troponins, and the scores are between 0 to 3 would quantify a low risk, 4 to 6 would be a moderate risk, and greater than 7 would constitute a high risk with the respective risk for adverse cardiac events. So since it classifies the patients into 3 risk categories, it makes it much easier for us in terms of disposition. The EDACS is probably a newer score which was developed somewhere in 2014 by Dr. Tan and his colleagues. And a score of 0 to 15 as per the EDACS score is low risk and the patient can be safely discharged home. A patient with a score of more than 16 is non-low risk and definitely requires admission and observation. So a study done by Dr. Dustin and colleagues found that the EDACS score is better than heart score when compared in identifying low risk acute coronary syndromes. So the next important roadblock, or I'd say probably the dilemma that we would have is probably the disposition of such patients. So low risk patients can be safely discharged home. Moderate or intermediate would require further evaluation, and high risk require observation in a coronary care unit. So for low risk patients, this is the clinical decision pathway. If the patient presents within 3 hours of onset with normal troponin I, then we can safely rule out, and they have low risk as per any of the scoring systems, they can be discharged home and ask for outpatient follow-up. Whereas a patient who is having a high normal or troponin level up to 99th percentile has to be shifted to an observational zone and retested with cardiac troponin and an ECG after 3 hours. So if their change in troponin value is less than 3 nanograms per liter, they can be discharged home, categorized as low risk. And if it's more than 3 nanograms per liter, they will be moved to a high risk stratification. So the next important patients whom we can't afford to miss are the intermediate risk patients who would be there in the emergency department for a longer duration of time, require repeat testing. So at this point of time, we would have to retest them and then assess if they require any other coronary, non-invasive coronary imaging or testing. Right? So once we have patients with intermediate risk, so how do we decide which type of testing is adequate for them? So patients who have normal renal profile, who have had previous CT angiography with no calcium deposition in the coronaries can be, who have been no absence of severe coronary calcification can go for a CT angiography, which is the recommended investigation. Whereas if they have a high calcium score on CT angio, they will have to be subjected to stress testing, like a stress echo or a treadmill test. Non-invasive testing, currently the recommended test is coronary CT angiography, since it's an accurate and non-invasive method. It helps in identifying obstructive as well as non-obstructive coronary artery disease, and a patient with less than 50% stenosis can be discharged home with probably a prescription for statins and aspirin. And with more than 50% stenosis, definitely would require further evaluation and testing. So these are just this is just a slide showing the other types of testing that can be done for identifying the coronary status. Transthoracic echo, which is quite easily available, may have a decreased sensitivity because of high inter-observer variability. A stress or a treadmill test may be difficult for people with joint problems or you have poor physical fitness in general to perform. And we have also what is known as single photon emission computed tomography. So again, with the SPECT and a cardiac MRI, I understand that the availability in many centers may be an issue, and also the higher cost of per test for them. So the next important thing is a follow-up. So if we have a low-risk patient, we would definitely probably discharge them and ask them to consult a cardiologist or a physician within 14 days for, again, repeat risk assessment and stratification. Intermediate risk patient can, after discharge, we'll have to follow up again within 7 days. And more often than not, we might have patients who are coming back repeatedly with chest pain and who have had prior testing or imaging done. Such patients, if they have a previous CT angio report which was normal, it's as good for the next 2 years. And those who have a prior stress testing report is valid for about 1 year. So the final pathway, just a summary of what all we have discussed. So as soon as the patient comes into the ER, the first thing to do would be a 12-lead ECG, then apply, of course, a clinical decision pathway and then troponins. Categorize them as low, intermediate, and high risk, and then appropriately follow the disposition that we have discussed already. So how do we improve outcomes in the emergency department? Having a high index of suspicion. When in doubt, to use both the risk scoring systems and see which patient, we'd probably categorize we'll give them the higher score which is for them. Having chest pain units, dedicated zones in the emergency department, which would help us, prompt us to get repeated testing done for such patients and also effective monitoring, and also make a plan for non-invasive testing from the emergency department for such patients. This is a brief summary of the things that I've just discussed. These are my references. Thank you. I would like to thank AME conference organizers and the esteemed faculty, and also my department for encouraging me and also supporting us and covering the floor when I'm here out to present. Thank you.
Thank you, Dr. Ashray. Dr. Ashray has also worked with me, so I know how good as a person and how skilled as an emergency physician he is. I definitely know that. Thank you so much. And I always say that when he lifted his arms to reach Bangalore, St. John's, I was always like, Ashray, come back initially. Ma'am knows that. So going ahead, I invite Dr. Keyur Shah for his next talk, please. The session is on the recent advances in trauma, newer concepts of trauma resuscitation.
Good morning. I'm Dr. Keyur. I work as an assistant professor at Pramukh Swami Medical College. It's at Anand, Gujarat, and I'm in charge of the emergency medicine department. My topic for the day is newer concept of trauma resuscitation. Now, as we all know, trauma is the bread and butter, but it's the 8th leading cause of death in India. It is the largest cause of death between 5 to 29 years of age. Annually, about 1.5 lakh people die due to trauma. About 4.5 to 5 lakh people are injured annually. The thing is, it is preventable. Government is doing its job. We are doing our job. But what else we can do? This is our main concern. First, we want to know that how much we have covered since the time. So most of the researches were during the World War, and let's see how we move ahead. I have divided my topic into 3, that is pre-hospital, then during hospital, and how we use the gadgets and the artificial technology. We all are aware about the main physiology of the hemorrhagic trauma patients, and majorly the lethal triad, that is the acidosis, the hypothermia, and coagulopathy. So first starting, initially during the World Wars, what they used to think is first shift the patient to casualty. That was the main aim. Then thanks to Dr. R. Adam Cowley, who had shown us that the golden hour is the most important thing. Later on, we understood that there is a trimodal distribution of trauma death, in which there is an immediate death, there is an early death, and there is a late death. Immediate death, we cannot do anything much, but early death is what they were focusing on. Then we understood that, okay, the golden hour is largely the pre-hospital event, and that is where they started focusing on. They made ambulance with emergency medical services, and now what we ended up is air ambulance with 3-person team. The newer concept is platinum hour, which is within 10 minutes from the incident to the start of the treatment. So that is the main aim what we have to achieve. The second problem is the blood transfusion. Of course, during the World War, they started learning about how to store the blood. They used to give whole blood, but then they understood that there are blood. Because of the whole blood, there were issues related to infection, to the ARDS, and antigenicity. Of course, during 1940s, they were not aware about the grouping and all. So they changed from the whole blood concept to the crystalloids. From the crystalloids, they understood that, okay, we need to limit it to 1 liter and permissive hypotension. And then they thought, okay, fluid is only to make pasta. What patient needs is blood. So they started with pre-hospital PRBCs. Stent didn't help. It showed that the same mortality rate. Then they made Riboa. that is occlusion of the aorta. Again, it didn't help much because those areas where we can compress directly, that is the best. Only for the truncal areas, or I would say as hip fractures, only in such areas we have the benefit. Then lastly, the pragmatic rule which have come, it has shown about what we are using currently as a blood transfusion, massive blood transfusion, from 1:1:2 to 1:1:1. Here again the problem is when to start. So we give 3 Paxils, then we realize, okay, this needs massive blood transfusion, then we give platelets, then we give FFP. It takes time. So that was still there. Then thanks to CRASH 2, which talk about the tranexamic acid, which has reduced the mortality. CRASH 3, it showed that the tranexamic acid is also very well used for the traumatic brain injury. And now lately the trial which shows that the pre-hospital care, in that if we give tranexamic acid intramuscular, has a better benefit. Now, during Afghanistan and Iran war, they understood that whole blood is the better. So we are back to whole blood, but we are aware about the antigen levels, we are aware about the benefits, like they have more platelets, they have more coagulation, clotting factors, so it is a better product. Coagulation as a triad, we are aware. The issue was, they initially thought it is because of the fluids. Later on they understood that no, it is the injury per se which is causing the coagulopathy. They brought Rotam. Over here they understood that it is not the clot, it is the formation and the strength of the clot. But it is cumbersome. Not many are aware. Not many can be put in the emergency medicine department as point of care. So that was it. Now lately they have changed from the lethal triad to lethal diamond. The 4th factor is the calcium. So as we all are aware about the acidosis, hypothermia and coagulopathy in the lethal triad, the 4th one is the hypocalcemia. And when patient is bleeding, they lose calcium. Plus when we give massive blood transfusion, we are again causing decrease in the calcium. So until and unless we do not cover this area, we are again into that circle. Lately they also understood that in the trauma what we need to know, okay, if it's a shock, it is majorly the thorax or the abdominal or pelvis. But the vasoreactive heads, they have shown that 13% of the code red hypotensive patients had only an isolated traumatic brain injury, which is in the contrast to the ATLS teaching that isolated traumatic brain injury does not cause shock. Here is the future. So the future majorly depends upon the EMS. It's the early pre-hospital care, that's what I could say. So, and plus it is preventable. What we want is how far we can do that. We cannot avoid accidents, but we can do it by knowing it, how frequently it is. So thanks to artificial intelligence, it helps us to know the capacity and the logistic. With the help of this, it was done in the Hungary. Over there, they noted that about 3,000 patients and they covered with 40 million kilometers per year. They got a data. In that data, they understood that, okay, which area of the place has a lot of massive road traffic accidents. And based on that, they do not say that, okay, tomorrow at this place we will have a road traffic accident, but they can predict based on the statistical probabilities. Then there is also a software company, Hexagon, which also gives the operational data and recognizes the major events if it is going to occur sooner. This helps basically the trauma team to be ready so that we can treat patients early. Then there are apps which are streaming in the emergency medicine care. 80% of the medical errors are due to communications. So now they are developing a lot of apps so that we reduce this. Like what we said, that we need not to mug all the protocols. Everything can be done from the mobile phone. MedCal is one of the app which we are still using it. Here Pulsara was a based in the Montana in the US, and with the help, they created a HIPAA complaint platform. So this basically helps us by connecting with the emergency medicine service, the ambulance services, to the hospital, and which gives us an idea that within how many minutes we are going to receive a patient. If sometimes required, we can even see the patient, and we can also get ECGs from it, so that we do a faster job. And it has been shown that with the help of HIPAA and the Pulsara, about 30% of the time has been decreased for the treatment. Then there is an app which is Swiss City in the Hungary again, which is a potentially life-saving method. Again, this is a good app which basically alerts the volunteers with a 500-meter of accident location, and if there is any accident or any such incident, they alert that area, so the volunteers who are free, they can come to the place, due to which, like in CPR, more the better people, so the ratio of ROSC has also increased. And this data they had collected, and it had shown that because of those places where they were using this app, there were more people who were coming to help the patient, and which had a better success in the CPR. Even the American Heart Associations have come with a full code pro. Then there is an RX, which helps about the common medical emergency scenarios. Then there are video games. Simulations, of course it works well, but then we cannot carry everywhere. We need a big place. We need mannequins. So they have made video games which teaches us how to, those are case based, like this level EX had started with intubation. It helps with where we are making an error and how we can reduce it. Then there are portable point of care diagnostic. We know ECG, lab tests, ultrasonography, those are giant machines in the past. Nowadays we carry it on our phone. We do it. Earlier during COVID, one lead of ECG was like really a boom. Nowadays we are getting wireless 12 lead ECG, which is equivalent what we do it in our emergency department. There are imaging that is called as infra scanner, which can be used for traumatic brain injury patients. And then there are medical drones. Of course, we used it during COVID to give kits, but here we can give AED, and we can even see the patients. Transportations has been really easy. So our main recent advances will be only in the pre-hospital care, and we are focusing more towards the platinum minute, which is the 10 minutes. So what we want is the sooner we do something, the better it is for the patient. We cannot avoid it, but we have to be faster. Of course, the emergency services of the future looks more data-based, efficiently streamed, and quicker than ever before, while considering the limitations of caregiver and ensuring the need of the patient. Hopefully, within a few years, there will be a lower waiting time in the emergency department. Thank you.
So thank you to Dr. Sahana, Dr. Sandeep, Dr. Rahul, Dr. Ashray, and Dr. Keyur. I hand over the mics to our esteemed judges to put their words of wisdom. They have heard these people, and
Excellent presentation by all of them, the young faculty, Dr. Sahana. You know, in the US, we have a lot of litigations, and we have guidelines, but the guidelines also are important. Certain times we have to follow the guidelines, but you know, but for example, if say you have to ask history of allergy to medication, you know, like if somebody is allergic to penicillin and the physician did not ask the history and the patient develops anaphylaxis and dies, you know, then, you know, so in that case, we had to follow the guidelines, you know, but certain times, you know, the guidelines are guidelines because patients may not conform to the specific guideline. So we have to individualize treatment in many cases. So, and there are different places. Like in New Zealand, what they do is it doesn't go to the lawyers. So what happens is what the patient has suffered, whatever injury has happened, the compensation will be given by the government, and it will go to an expert team of doctors, and they will see what the physician has done. They will evaluate whether it is medically appropriate or not, and then based on that they will recommend more continuing medical education, and that's where the New Zealand is there. But in US, the lawyers, money is involved, so they want to try to sue if there is any negligence and all those things. That is other thing. Next.
Sir.
One second.
Yes.
Next, Dr. Sandeep, he has seen the acute liver failure. Was also excellent presentation, and in US we have this paracetamol poisoning is the #1 cause of acute liver failure. And it was an excellent presentation with the scoring tools and all those things. And Dr. Rahul, the chest pain, pacemaker, also excellent presentation. And most important thing is we have to see where the lead is, and we have to put the pad like 8 centimeters away from that. That is a very important point. That's what is important. And actually, low risk chest pain, that is the commonest, patient. A lot of patients come with risk factors and chest pain. But what I see is, you have to have, the most important thing is the history and plus the experience of the clinician. When you look at it, they are sweating and they are, that something is wrong, and you cannot just ignore that. So the scoring systems are okay, but your own clinical judgment is very important for this. And Dr. yeah, recent management of trauma is very good presentation again. We use whole blood nowadays in our emergency department. We use whole blood because 1:1:1 is like difficult because the fresh frozen plasma thawing itself takes like 20-30 minutes, and whole blood has everything, all the factors, platelets and all those things. So if it is available, that's what we give. O negative blood we just start. And most important thing is also minimize crystalloids as much as possible, and don't forget the calcium. That's very important. And we use Pulsera. Pulsera is very good because the moment the patient is seen by the EMS, they put all their vital signs, their medications. So whether the patient is on anticoagulant, what medication, what allergies, when like for stroke patients, when last known normal, what was their blood sugar, everything is put, even before they come to the emergency department, everything is there. So think is quick. So like for giving TPA for acute stroke or all those, lot of information is available, so that you don't have to repeatedly ask the patient, or the relative might take some time to come. And so it really helps with acute stroke, ST elevation MI and other cases, getting all those details and things like that. Thank you for the excellent presentation.
Thank you so much, sir. Sir, while...
First of all, I think I congratulate all 5 of you. Good presentations, and I think the content was also relevant. But I think that being seniors in this field, and Professor Einstein is probably much more attuned to it, time management is something you should take care of, okay? Because most of the time went a little bit overboard. So that's not to discourage you from anything, because this is the way we also started, I think. I'm sure you recall, in our younger days, all of us didn't stick to time and took a lot of this thing away from it. Content was good, very good. And I think we need to look forward, because as the science of resuscitation, trauma, and all is an ever-evolving science. It's quite unfortunate that, that worldwide people have woken up to this particular issue as industrialization has progressed. There have been more accidents, more mishaps. But the science of resuscitation and trauma has lagged far behind. It is only now, that is the last 3 or 4 decades, that people are realizing, and we heard the last lecture, very relevant, and congratulations for a good presentation. And that we went around for whole blood, went the entire sequence, and then turned back to the same. So that's where humanity is. We learn to de-learn. And trauma and resuscitation is like that, even emergency care to quite an extent. We first de-learn, and then again relearn, and then come back the same. So that's the irony of it. It is what it is, as I put forward. And I think point of care, the second thing I want to talk to you about is point of care. Now, point of care is ever evolving. We, my institute, we used Rotem upfront. We used upfront as far as snake bites are concerned. And we used it in viperine snake bites, coagulopathy, and we found that your standard whole blood clotting time in viperine animation is very, very fallacious. You miss about 1/5 of patients who might actually need antivenin, and that's very important as far as snake bites are concerned, because these are the people who will end up with bleeding, acute renal failure, and maybe long-term complications that are relevant to viperine bites. So, as technology advances, I understand, I may be a little off here, that these point-of-care devices, as far as coagulation is concerned, you know, there's an iteration of sonoclot that has come in, that is being tested in the field as far as, you know, the war areas where US is lending out its overreach programs to different areas in Europe, and they are testing it on viperine and Asia. Unfortunately, nothing is going on as far as Northeast Asia is concerned, Southeast Asia, sorry. So, as the time evolves, you may be having a point-of-care system at the bedside. We've seen TROP-Ts, we've seen your tests for infectious diseases, for malaria, for your scrub typhus, and for all these things. They are available now, point-of-care ELISA, and all have been tested thoroughly. So, always look forward to it. It is not a never-ending science. It's a science which is continuing to progress, and textbooks will change over a period of time. I'm sure what all you're learning now, 10 years down or 15 years down the line, when you're sitting in this front row and we are long past our prime, you will be reiterating something which is totally different. Okay? So be up to date. Unfortunately, most of you have picked up medicine, me included, and it's an ever learning. Learning never stops. It always will continue till the time you retire or superannuate. Even after that, it continues. My father he was a doctor. He retired, and even at the age of 91, he's called upon to certain conferences to mediate sessions and all. So that's what it is. I look at that, and I see a long road ahead, but it is an interesting science nevertheless. So once more, with these words, I hand over back to the organizers, and all 5 of you can pat yourselves in the back. It was a really tough decision, at least for me, to make out, because all of you are pretty good. So we'll see where Sir and I can come along the way.
Thank you so much. I hand over the mic now to Dr. Sahana. She'll be helping me in running this hall sessions further. Please understand, young faculty talks will happen in this room only. So if there are young faculty talks scheduled in the hall downstairs, they have to come back here, number one. The paper presentation, 6 minutes. Paper presentation, 6 minutes. And they'll stop the slides. Please call upon the...
I call upon the judges, Dr. Ashok Kumar and Dr. Rahul Isis, to please take the front seats for the next panel. I call upon the first speaker, Dr. Sabah Ali.
I'll start. Yeah, a very good morning. This is Dr. Sabah Ali. I'm a resident from Amrita Hospital, Kochi. And with great delight, I would like to present my topic for today, Perfusion Index, which is a novel emergency medicine room clinical tool. And I'll be using this perfusion index in order to predict the need of blood transfusion in patients who present to ED with bleeding. So as we all know, the most prevalent cause of shock and one of the leading factors of patient mortality is hemorrhage. Now, tissue perfusion, it's an essential component in patients that presents with hemorrhage for evaluation and resuscitation of it. And peripheral perfusion index, it's a non-invasive, rapid, easily obtainable measurement of peripheral perfusion, which can be obtained bedside by placing a pulse oximetry at a particular monitoring site like a fingertip or earlobes. So even though peripheral perfusion index, it cannot just indicate hypovolemia alone, but it reveals the changes in peripheral perfusion, and that's what my whole article is about. It displays the ratio of pulsatile blood flow to the non-pulsatile blood flow. Basically, the infrared rays that gets absorbed, the quantity of this is used by the machine to get this perfusion index. And as we can see, that's the pulse oximeter meter, and the PI there, the one that's expressed in percentage, is the perfusion index. So the purpose of my study, like I mentioned earlier, is to use this perfusion index and figure out whether it can predict the need for blood transfusion in those that present to ED with hemorrhage. And my secondary objective was to compare this index with different stages of hypovolemic shock. Now, this was conducted in emergency department in Amrita, and in a duration of about 2 years. It was a prospective observational study, and all the patients who were aged between 18 to 80 years were included in this study, regardless of the causes of their hemorrhage. Pregnant women, those in cardiac arrest, and those who do not give consent were excluded. My sample size was about 60, and the basic demography of the patient, including the vital signs, mental status, urine output, and the etiology of the bleeding was noted, and they were categorized according to the stage of hypovolemic shock. And perfusion index was also noted. Now, my indication for blood transfusion was less than 7 gram per deciliter of hemoglobin, but those with CAD and ongoing bleed or any hemodynamic instability, 10 was our cutoff. So the categorical and numerical variables were expressed using the percentage and mean and standard deviation respectively. So this was my statistical analysis. Chi-square test was used to test the statistical significance, and ROC curve was used in order to find out the ideal cutoff. And the p-value of less than 0.05 was considered to be statistically significant. So what we observed is that 65 was the median age, with 68.3% being males, and half of the causes of hemorrhage was due to upper GI bleed, 27 was due to trauma, and only 3 of them ended up with hematological causes for hemorrhage. Now, 40 of them, making up 66.7%, had a perfusion index of less than 1, while those with perfusion index greater than 1 made up 33.3% of our population. And 68.3 underwent blood transfusions, whereas 31.7 did not. So this is the representation of perfusion index with that of blood transfusion. As we can see, less than 1% of perfusion index received blood transfusion. So this was when we compared the perfusion index with different stages of hypovolemic shock. And as we can see that those with more than perfusion index of those with more than 1 were pretty stable, and those with less than 1 had greater severity of hypovolemic shock. So the area of under the curve was also statistically significant, with 0.97 being the area under the curve, with a sensitivity of 92.6 and a diagnostic accuracy of 91.67%. So as we can see, this is the ROC curve, and like I mentioned, the area under the curve is 0.97. These were the diagnostic measures with sensitivity of 92.6 and specificity of 89.47, with that being statistically significant. So the main purpose of my study is that the outcome of the low transcutaneous measurement of peripheral perfusion index, it's an indirect indicator of hypovolemia, and as we all know, the trauma, there's a concept of golden hour. So when time is ticking, we need to act fast, and which is why that's where the perfusion index comes into handy. All we need to do is to just place the probe. We see PI on the pulse oximetry, and if it is less than 1, we know that this patient is going to has hypovolemia, and we can predict the need for blood transfusion, so we can act fast and have an early intervention, which will result in better outcome. There have been many studies that have been conducted with perfusion index, and a very similar study was conducted even in Turkey, but in India, this has been the very first study. There's this other professor by name Hassanan, even he used peripheral perfusion index, and he, in his study, stated that PI can decrease with hypotension. And in fact, there's this other study which also suggests that any sudden drop in perfusion index can be an early indicator for worsening of the patient's condition in terms of hypovolemia. So these were the limitations, as we only had about 60 subjects, and this has to be conducted in a bigger population, and a lot of other factors also, alter perfusion index. But having said that, I still, the perfusion index can still be utilized for shock classification, and also as a very easily and rapidly non-invasive tool to figure out whether the patient will require blood transfusion or not within the first 24 hours. Thank you. These would be my references.
No. We call upon our next speaker, Dr. Himanshi Bait.
It's a question, 4 minutes of a question answers. Sorry. 6 minutes are for presentation, and because there are paper presentation, 4 minutes are for questions. Please stay back for questions.
Any questions? Yes. One second.
Any hemorrhagic shock patient, you transfuse, right? So why do you need this perfusion index? This is before they develop hypovolemic shock, or?
No, sir, the concept is when the patient presents to the ER, just like how we take into consideration the vital signs and all the other parameters, there's something called as a revised trauma score, which there are many other scores and systems that give a prediction. Perfusion index is also one of the entity that I was trying to put forth, that it also has to be taken into consideration because it has a very good sensitivity, and it predicts the need for blood transfusion, or it indicates basically hypovolemia early. So blood investigations will take a while, can be altered. So perfusion index is also one of the entity that can be used. And it's easily available, it's rapid, and can be obtained bedside. So the patient comes into the ED, we do not really take perfusion index into the picture. So this article was all about taking that, incorporating that in our regular scores. Yeah, sir, as I said, perfusion index can be altered with hypothermia if the patient is in stress, anxiety, but to a larger extent, it can be altered. Perfusion index can be altered, but if a patient has lesser perfusion index, like lesser than 1, it can go up to like 14, 15, 20, so but lesser it is, that it means to say that, patient is more hypotensive, more hypovolemic, so early intervention can be done.
I have a question and a suggestion for you. Do you happen to have any comparison of shock index with this perfusion index?
That was my other study, sir. I have done that. Yeah.
As far as your objective is concerned.
Yes,
because
sir.
shock index has got a considerable amount of background to it. And iterations are coming in the diastolic shock index, modified shock index, both of them. So how do they compare as far as this particular?
So as far as that shock index, there are many other indices on that. Shock index is there, modified shock index and age shock index, out of which the age shock index has been proven to be better than the other two shock indexes. As per the other studies, this is comparable, and in fact, in some of the studies, perfusion index has shown to have like better sensitivity than the traditional shock index, which just takes into consideration the heart rate and the systolic blood pressure. So in fact, the study that was done in Turkey showed that perfusion index had better accuracy than serum lactate levels also. So since it's like rapidly available and it is better than the other indices, this has to be like, incorporated into the systems. They used 387 patients. Yeah. Thank you.
Yeah, thank you, Doctor. We call upon our next speaker, Dr. Himanshi. We'll have our next presenter, Dr. Harismita, who will be presenting her presentation.
Good morning all. Myself Dr. Harismita, third year postgraduate in the Department of Emergency Medicine, Vaidehi Institute, Bangalore. Today I am presenting a study where we use rapid emergency medicine score as a triaging and also a prognostic tool for 30-day mortality outcome in non-surgical patients presenting to ER. So coming to introduction, rapid emergency medicine score, it is used to predict in-hospital mortality in non-surgical patients presenting to ER. It helps in assessing critically ill patients, where helps in treatment of treating the critically ill patients aggressively. The REM score, it is calculated using vital parameters like age and mean arterial pressure, the heart rate, the respiratory rate, the peripheral oxygen saturation, and the GCS. Coming to the age, where the REM score, the least score being when the age is less than 45 years, the least score being 0, and when the age is more than 74 years, the score being +6. And when coming to mean arterial pressure, the highest score being the more than 159 or less than or equal to 49, that is +4, and the least score being 70 to 109. Next, coming to heart rate, the highest score being more than 179 beats per minute or less than or equal to 39, and the least score being 70 to 109, that is 0. And coming to respiratory rate, the highest score being more than 49, that is +4, or less than or equal to 5, that is +4, and the least score is 12 to 24, that is 0. And the GCS less than 5, where the score is +4, and the GCS more than 13, the REM score is 0. And coming to peripheral oxygen saturation, less than 75%, it is +4, and more than 89%, it is 0. The objectives of this study, the primary objective, it is to predict to triage the patients, and the secondary objective, it is to predict the 30-day mortality outcome. The materials and methods, there were 100 patients presenting to ER with non-surgical causes was taken up, and the study design, it is a prospective study. The place of study, it is Vaidehi Institute of Medical Sciences and Research Center. And the duration of study, it is 1 and 2 years. The inclusion criteria, the age being more than 16 years and up to 75 years was taken for the study, and all medical emergencies presenting to ER. The exclusion criteria being less than 16 years and patients with cardiac arrest and pregnancy patients and trauma patients were not taken into the study. The methodology, the 100 patients underwent the study and the REM scoring was used to do the triaging, whereas REM score less than 3 were triaged into green zone and REM score between 3 to 9 was triaged into yellow zone and more than or equal to 10 was triaged into red zone. Whereas REM score more than 3 was analyzed as high-risk patients and was treated aggressively, and the patient's outcome was followed up at the end of 30 days. Coming to statistical analysis, the software used was SPSS 19 and the significance is assessed at 5% level of significance. Coming to results, coming to the demographic representation of the result, this is a bar diagram representing where most of the patients presented between 26 to 35 years, like where the scoring will come around 0, and most of them were male patients when compared to female patients. Next, coming to a bar diagram representing mean arterial pressure, most of the patients, like out of 100 patients, 82 patients were between mean arterial pressure of 70 to 109, where it comes to 0. And most of the patients, 50 to 69, where the REM score will be +2. 12 patients out of 100 were there. And next, coming to bar diagram representing the heart rate, like most of the patients' heart rate was between 70 to 109, whose REM score was 0. Next, coming to respiratory rate, out of 100, 74 patients was between 12 to 24, and the REM score was 0 for them. And bar diagram representing peripheral oxygen saturation, where out of 100, 77 patients oxygen saturation was more than 89% and the REM score for them was 0. Coming to GCS, out of 100, there were 79 patients more than 13, so the REM score was 0 for them. Next, coming to out of the study 100 people, there were most of the 68 patients was less than 3, where they was characterized as low risk and was triaged to green zone. Out of 100, 20 patients was REM score between 3 to 9 and was triaged to yellow zone, and more than 10, 12 patients was more than or equal to 10 and was triaged to red zone. Coming to discussion, there was a study done by Olson et al. Where REM score was compared with the RAP score and was REM score was a better predictor in hospital mortality than RAPS. Then next, coming to a study done by Godecker et al. In 2005 between REMS and RAPS, and was scoring system was calculated to predict in-hospital mortality and showed REMS was better than RAPS scoring. And next study done by Bulu et al. Conducted a study in Turkey using REMS and mu score on all patients presenting to ER and showed REMS was superior to MUS in predicting mortality. And there was a study done by Remle P et al. Showed that half of the EMS patients had an initial pre-hospital REMS of 5 or lower, and who had a REM score of 5 or lower were discharged from the ED. Coming to a discussion, conclusion, the REM score is better for predicting mortality, and the treatment can be done by ER physicians. These are my references.
Questions?
So in the results, nothing regarding the mortality, 30 days mortality of the patient was mentioned, no?
Out of, there were 12 patients whose REM score was more than 10, sir, out of which 11 patients have expired.
Have expired.
This score looks complex and too big. And how much time it takes to calculate this score?
It will take initial 10 minutes when patient presenting to ER, initially 10 minutes, because it has only the vital parameters, which can be assessed by initial ER physician or the pre-hospital before transporting. Also, the EMS technicians can assess the vitals and they can do the scoring system so that the treatment can be planned accordingly.
Any further questions? No. Okay. We call upon our next speaker, Dr. Himanshi Bed.
Very good morning to everyone present here. I am Dr. Himanshi Bed, Senior Resident at the Department of Emergency Medicine at AIIMS Rishikesh. My topic for today is POCUS as initial diagnostic tool in acute onset dyspnea patients in the emergency department, a diagnostic accuracy study. Dyspnea is one of the most common presentations in the emergency department with a wide range of disorders in the spectrum, some of which are life-threatening and require prompt action. Most patients of dyspnea are managed following the integrated approach of history-taking, physical examination and investigations. Now, the traditional methods of investigations, especially the radiological ones, can be time-consuming, depend upon the availability of resources, and they have a risk of exposure to radiation. Ultrasound has been emerging as a bedside tool because of the advantages that it can be incorporated immediately at the bedside, hence save time. There is no risk of radiation exposure, and it has proven effective in evaluation different clinical settings like the ICU. Emergency physicians have been performing POCUS since 1990, and lung ultrasound and echocardiography individually have shown efficiency in identifying individual causes of dyspnea. However, there is no integrated ultrasound protocol as the initial diagnostic tool for acute dyspnea patients in the emergency department. Hence, we conducted this study to see the utilization of point-of-care ultrasound in patients with acute dyspnea. Our objectives were to determine the diagnostic accuracy of POCUS with a final composite diagnosis and to test for any benefit in time compared to the traditional methods. So this study was an observational study conducted over a period of 1 year in the emergency department of AIIMS Rishikesh. We included all patients who presented with acute dyspnea with an age more than 18 years, while individuals referred with a known diagnosis, patients who had dyspnea due to traumatic cause or were pregnant were excluded from our study. The study flow was when patients presented with acute dyspnea met inclusion criteria and gave consent, time was recorded at the time of presentation, and these patients were evaluated by initial emergency physicians in the traditional way. The necessary investigations were ordered. Meanwhile, the POCUS study investigators were informed, and they did a point-of-care ultrasound on a preformed decided format. They knew about the clinical profile of the patients but were blinded to the investigations of the patient. They reached a POCUS diagnosis. Here again time was recorded. Then an ED diagnosis was formed on the basis of all traditional methods, and finally this diagnosis was reviewed by 2 emergency physicians, the consultants, who had access to all the patient details, and a final composite diagnosis was made. Finally, 237 patients were analyzed. The statistical methods used were sensitivity specificity analysis for diagnostic accuracy. Kappa statistics was used to see the concordance between POCUS and final composite diagnosis, and pair t-test was used to compare the time benefit. We saw the following results. We had patients ranging from the age of 18 to 82 with a median age of 53 years. We had 40% females and 60% males. Now, about 43.9% of our patients did not have any other previous known comorbidities. The various lung and cardiac ultrasound variables are listed in this slide. The most common ones that we saw in the lung ultrasound included irregular pleura, pleural shredding, and diffuse B-lines. In cardiac, we found the most common decreased ejection fraction and left ventricular hypertrophy. The most common diagnosis that we found in our patient group was pneumonia, out of which final diagnosis of pneumonia was made in 188 patients, out of which POCUS diagnosed 167. We had a sensitivity of 85 and specificity of 87.7 in these patients. Other diagnoses which were common were acute pulmonary edema, followed by pleural effusion, LV dysfunction, ARDS. Detailed diagnostic and accuracy can be seen in this slide. We found that sensitivity was maximum for patients with pleural effusion, pericardial effusion, pulmonary embolism, and pneumothorax. Specificity was overall high in all the patients. Accuracy for our most common diagnosis, which was pneumonia, was 86.06%, while maximum accuracy was seen in diagnosing pulmonary embolism and pneumothorax, along with pericardial effusion. The concordance for POCUS with final composite diagnosis, overall it was good, 0.668. It was optimal for acute pulmonary edema, pleural effusion, pulmonary embolism, and pneumothorax, while it was poor for patients with AECOPD, asthma, or ARDS. We saw that the time taken for making a POCUS diagnosis, median was 15.6, while that for an ED diagnosis using traditional methods was 169.8 minutes, which was statistically significant with a p-value of less than 0.001. We saw that the overall concordance in our study was good. It was comparable to a study done in Europe by Zanobetti et al. In more than 2,000 patients, which was 0.711. And the Indian study, Gattikonda et al. In 100 patients found a higher concordance with POCUS and final composite diagnosis. There was statistically significant reduction in time to formulate diagnosis, which was comparable to two studies, Zanobetti et al. And Gaber et al. However, the exact time was different for different settings. Our conclusion was that POCUS was highly sensitive for diagnosing pneumonia, acute pulmonary edema, and pleural effusion, with high specificity for all differentials. Overall high accuracy and good concordance was seen. Statistically significant time reduction was seen to formulate a diagnosis. So it is a promising initial diagnostic tool for ED evaluation. Having said that, our study was not short of limitations. Some limitations include small sample size, uneven distribution of differentials. Part of our study was done during the COVID pandemic, and USG is a subjective interpretation. So we recommend, we would suggest for future we could incorporate a larger sample size, use inter-relator variability when we are assessing ultrasound, and come up with a better sample size to apply it to the local group. Thank you.
Any questions? If there are no further questions, we'll move on to the next speaker. May I call upon Dr. Binu Bright for the next session? I think we have a technical error there. Can we call upon Dr. Shrikar Yadav for the next session? Dr. Shrikar Yadav.
Good morning, one and all. I am Dr. Shrikar Yadav, studying a second year PG residency in PES Institute of Medical Sciences, Kuppam. Today I am going to discuss about influence of body mass index on the severity of injuries and the region of the body affected in motor vehicle accidents. Introduction. Obesity is a growing problem in the modern world, and motor vehicle accidents and obesity are the most common causes of morbidity and mortality in the modern world. And obesity and overweight are calculated using a BMI, body mass index. Body mass index is calculated using weight in kgs by height in meters square. And the need of the study is to determine the relationship between the body mass index and the pattern and the severity of injuries after motor vehicle collision. This will enable us search for a specific injuries in specific group of body mass index. Methods and materials. This is a prospective study. All the adult patients presenting to the emergency will be assessed for severity of injuries using injury severity index, and abbreviated injury severity score is used to quantify injuries in different regions of the body. Patients' height and weight are estimated based on a set of standard formulas. BMI is calculated as per the height and weight. Patients will be divided into two groups based on the BMI, namely BMI greater than 25 and BMI less than 25. Details of mechanism injury will be noted and grouped as high speed versus low speed accidents and simple versus dangerous mechanisms of injuries and head-on collisions versus rear-end collisions versus side impacts. Different parameters are compared between the groups and tabulated and tested for statistical significance. Injury severity score. Here we consider the regions of the body involved in the accidents such as the head and neck and injuries to the head and neck such as cerebral contusions. And the AS score is a 3 for a cerebral contusion, and if the face region is involved and if there is no injury, we will consider AS as 0, and if the chest is involved, if there is a flail chest, we will consider AS as 4, and if abdomen is involved, minor contusion of the liver and complex rupture of the spleen, we will consider it as 2 and 5, and extremities are involved. If there is a fractured femur and fractured long bones, we will consider it as 3, and there are external no injuries, we will consider AS as 0. Injury severity score is used by squaring the top 3, and AS score for minor injuries we will consider it as 1, and for moderate it will consider it as 2, for serious it will consider it as 3, and severe 4, critical 5, and survival is 6. And IAS 1 to 8 is considered as minor, 9 to 5 is considered as moderate, 16 to 24 is considered as serious, and 25 to 49 it is considered as severe, and 50 to 74 it is considered as critical, and 75 is maximum. And estimating the height from the Davis span. Davis span is calculated by measuring the distance from the middle of the sternal notch to the tip of the middle finger, left arm if possible, and check the patient's arm is horizontal and in line with the shoulders. Calculate stature from the formula below. In females, the height is calculated in centimeters using demispan, 1.35 into demispan in centimeters plus 60.1, and in males it is calculated as height in centimeters equal to 1.40 into demispan in centimeters plus 57.8. Estimation of the weight from the height, waist and hip circumferences. In males, weight equal to 137.432 plus body height in centimeters into 0.60035 plus waist circumference into 0.785 plus hip circumference into 0.392. And in females, weight equal to 110.924 plus body weight in centimeters into 0.4053 plus waist circumference in centimeters into 0.325 plus hip circumference into 0.836. The results. A total of 101 patients have been examined during the study period. Most common region of the body involved was head and neck, that is 32 cases, and another 21 cases have head and neck associated with an extremity injuries. Maximum IAS score was 34 and a minimum was around 4. Most of the cases have mild to moderate severity of injuries with an IAS score of ranging from 5 to 10. Minimum BMI was 18 and a maximum BMI was around 37. 62 patients had a BMI of less than 25 and 39 patients had BMI greater than 25. Patients with BMI greater than 25 had an average injury severity score of 10 plus 10.23 plus or minus 3.53, and patients with BMI greater than 25 had an average injury severity score of 14.15 plus or minus 5.93. The two-tailed p-value for statistically significant difference between the two groups is less than 0.001, and by conventional criteria, this difference is considered to be extremely significant. In discussion, in this study, body injuries were associated with overall BMI. Obesity has been associated with the severity of injuries. Overweight is considered as a risk factor for cardiac arrest, acute respiratory distress syndrome, pulmonary embolism, deep vein thrombosis, and unplanned intubations. In a study conducted, obesity was known to increase the risk of the death after the traumatic brain injury, and the BMI was greater than 35 was an independent predictor of the traumatic brain injury induced hospital mortality. In this study, it shows a positive relationship between the obesity and the AIS higher than 2 and 3 and ISS index. In this study, it seems that overweight does not increase the likelihood of the injury, but it affects the severity of the injuries. Obesity has an inverse relationship with the internal organ injuries and a direct relationship with the external organ injuries. Conclusion. Based on the results of the study, a conclusion can be drawn that an increase in BMI can lead to more severe injuries in victims of road traffic accidents. Although BMI seems to contribute to increased severity of injuries, other chances like mechanism of injuries and the safety measures at the time of accident should also be considered. And these are my references. Thank you.
Any questions?
Why did you why did you calculate the height of the patient according to the demispan calculation? You could have taken length of the patient.
So because in most of the road traffic accident cases might be long bone injuries and the patient cannot be able to stand. So we calculated the patient in supine position only with the help of demispan calculations.
And how did you calculate the weight of the patient?
Weight of the patient, mostly we will ask the previous weight of the patient, recent calculations. The patient no, we have taken only known patients into consideration.
Looks like there are no questions being raised by the audience. I wonder why. So I just thought I'll break the monotony where only one person or two people are asking the questions. I know many of you are doing this for the sake of completing a requirement. So therefore, what you have done is you have taken things from your write-up which you have had and you have put it up. Please remember, this is a presentation. You are given actually 6 minutes. You need to rehearse before you come. I've been observing that many of the slides are also not really of the best quality. You need to really go through these things very well because you are taking part in an event which spells out and defines how you're going to become speakers at the end of your student career, and soon you'll be faculty. And if you're already junior faculty, you need to make sure that you do your slides well enough to convince your students that you know what you're talking about. So I've been observing right from the beginning that there have been, and I'm a person who calls a spade, or an idli as an idli, not as a rice cake. So slides are not of the best quality. And secondly, you also need to make sure that your presentations are more defined and more, not just repeating or just taking verbatim from your dissertation presentations, because I saw the last speaker, I'm telling you very frankly, okay, I'm not mincing any words. The last speaker said, if you look at it, is supposed to be so. That is what he wrote as a draft proposal for his dissertation, which he has taken verbatim from that. So he's gone from that to what has already been done. And of course, there is one particular paper which requires my appreciation, which I did not do at that time because I'd just come in, I didn't really hear the other part of it, but it was by Dr. Baid, I think. You did your paper. That was actually a very good paper, very well presented, on time. So you do have my compliments for that. So I would really like all of you to take part in the discussions, ask questions. That way you're going to keep your mind thinking, analyzing. That's important. You're not just listening. You are actively participating. One question let me ask you, now that I've spoken about something, I should ask a question. The gentleman who just spoke about the ISS, yeah, thanks. Tell me one thing, how long did you take to calculate ISS for your patients? 10 to 15 minutes you don't need at all because you have an app. Nobody calculates ISS. If you're doing it regularly in your department and getting to know what it is, you just punch in the numbers. It should not take more than 30 seconds. So be more realistic when we do these things, because scoring systems is easy to write papers, but it's a different ball game trying to implement it in the department.
Thank you, sir, for your insight into the young minds. We call upon our next speaker, Dr. Binu Bright.
So very good morning, everyone. I'm Dr. Binu Bright, MD Resident from Amrita Institute of Medical Sciences. Today I'm going to discuss about a case study which we did in our institution. There is a diagnostic accuracy of non-contact infrared thermometer. So basically it is actually a study in which we compared different types of thermometers which we commonly use in our department and just to see which one is actually better. So let's go. So basically, as we all know, fever is a very common symptom which comes to our ED, and there are different types of thermometers which are commonly used in our department. So a few years ago, mercury in glass was the most commonly available one and the most commonly used one, and at some point was considered to be the gold standard. But slowly it paid way to newer varieties like digital thermometers, which are common in the current usage. But recently, as the COVID pandemic came in, we started using a newer variety of thermometer more frequently. That is the infrared non-contact thermometer. The biggest advantage was that actually there is no need for direct patient contact, and we can actually check the temperature of a lot of people in like a very short span of time. So this started becoming like a common device, especially in screening areas, whether it is hospital, other institutions like airports or even shopping malls and all that. So as the pandemic progressed, this device became a ubiquitous device for temperature measurement. And the thing is actually the pandemic is slowly like leaving its way out, but the thing is a number of institutions started thinking about using this device actually as an alternative for the commonly used digital thermometers in ED and other departments, where we can actually get a quick like measurement of temperature. So in our department also we had like a discussion regarding that, because actually a lot of institutions have invested in infrared thermometers actually as a device for temperature measurement. So we were thinking about why not use this, actually continue using this as a temperature measurement device in our department, because actually it is much more easy to use, non-contact, much more patient compliance is there. So considering that aspect, we did a study. So the main thing is actually it has got a good, like a really good triage value, because it is non-contact, high patient compliance, everything is there, but the accuracy is the problem. So we did a prospective observational study in about 210 patients who were consenting from both genders, from a wide age group from 16 years of age to 92 years of age, who presented to the ED in Amrita Institute of Medical Sciences with complaints of or without complaints of fever. So, and the study was conducted during the period of Jan to June 2022. So along with the clinical data, we also collected other data like the vital signs, and along with that, the temperature was measured using 3 devices, that is mercury in glass, infrared, and also the commonly used digital thermometers. And all this was simultaneously measured like within a short span of like 5 minutes or so in the same patient. And the mercury in glass, as we know, it is placed in the axilla, and we measure, keep it for about 2 minutes and record the temperature. And the digital thermometer, which usually keeps a beep, like sounds a beep once the temperature is recorded. And the infrared, we keep about 5 centimeters away from our forehead or the wrist, and you record the temperature. So when the results came, we had about an age group of 16 to 92 years of age, and 210 subjects were there, and in that 53% were male and 47% were females. And only 20.5% were actually having the symptoms of fever, and other were presented with other complaints like vomiting, diarrhea, cough, and all that. And 52% had 2 or more comorbidities, and remaining had less comorbidities, and 14% had no comorbidities. So the thing we found out is that actually when we compared the results, almost the digital and mercury in glass thermometer were recording almost similar temperature. And the one important thing is actually they are also able to record hypothermia. So they were able to record hypothermia, normothermia, and when comparing to the findings of hyperthermia, they are almost comparable. But when it comes to non-contact infrared thermometer, the accuracy was actually almost much lower. So when they were able to detect about 97% of hypothermia, the infrared thermometer will actually record as 85% to be normal. So about a 20% of almost discrepancy was there in the recorded measures. So the discussion is that actually nowadays this kind of thermometers and even other newer varieties are actually coming, like skin strip thermometers and even skin contact thermometers are coming in use. So the thing is actually, even though we commonly use different kinds of thermometers in the clinical practice, there aren't much studies. When we did the literature study, like literature review, we couldn't find much studies comparing this different kinds of thermometers. So even though different kinds of thermometers have different purposes in our clinical practice, like direct skin contact we can use in neonates, tympanic we can use in pediatrics, then we can use non-contact in case of pandemic and triad situations. You need to do further more studies to properly assess the accuracy of each of these devices, because almost all of them have good specificity, but the sensitivity is actually much different. So this is one of actually from the literature review, we could find that this is one of the first studies actually ever did comparing all these three devices in a wide group, like from pediatric to geriatric. And even though they don't differ in their specificity, the sensitivity is actually much different when we go through the results. So our conclusion is actually that even if the pandemic goes away, if you're considering to implement a non-contact infrared thermometer as a device in our clinical ED practice, this actually we should do a bit more cautious about that, because so far from the results of the previous studies and also from what we got, it is not as close to good as the one which is commonly using these days. That's all. Thank you.
Yeah, hi, sorry. Just wanted to inquire about the nature of the thermometer you guys used, because during the COVID pandemic, I think a lot of hospitals were trying this out, including ours. And similar to what you finally concluded, we had actually started checking ours, but then on comparison, we found out that it was not as sensitive. Can I know whether yours was an industrial IR thermometer, or was it actually patented for healthcare? Because there were some medical companies who were coming out with these thermometers, but we bought a generic one, which we found out much later was used in factories and all. Is that what you guys used?
The one that we used were actually intended mainly for this clinical practice only.
It was for clinical practice.
Yeah.
Okay, so we were actually using one which was an industrial one, and we found it was not sensitive at all. But it's interesting to see that even the clinically approved ones, which I think are more expensive and much more sensitive than the other ones, even the clinical ones were not as sensitive. So when there was such a discrepancy in findings, I was thinking perhaps you all would have used the generic ones as well. But obviously you've used the actual ones. So digital is still the way to go, in other words.
So when we went through the clinical literature, what we could find is actually the ambient lighting and even the temperature around the area where we are recording the temperature.
It all plays a part, yes.
Yeah, they all plays factor like this.
Thank you.
Thank you.
I've been sort of involved with the Ministry of Health and Family Welfare for the Government of India. And an interesting finding that we had during the COVID screening in the airports was that people were aware that it was checking on the outside skin temperature. So generally when you get off an aircraft, you first go to the toilet. You go to the loo, wash your face, wash your hands really well in cold water, and you come back. And you pass through without a problem. So therefore this was shown, and then that's when they started discontinuing usage of this in the airports. Because the whole concept is that we want to check the core temperature. So that's the reason why we're going close to the axilla and we're not putting the mercury thermometer on the forehead. Because we don't want to know what the external temperature is, we want to know what the core body temperature is. That's what truly reflects fever. So therefore the whole concept now is being looked at whether it was something which was too early to be put into screening.
Thank you, sir. Any more questions?
Thank you.
Thank you. I call
again. With great delight, I'd be presenting another topic of mine, the use of modified stone score in predicting ureteric calculi in those presenting to ED with acute flank pain. So as we all know, one of the most common and most painful urological emergency is ureteric stone. In fact, about 5 to 10% of the Indian population gets affected by ureteric calculi, and the recurrence rate is nearly 50%. The cause of calculi is influenced by a lot of other factors like race, genetics, diet, geography, and Asians have twofold higher prevalence of getting ureteric calculi, which is why it makes all the more important for us to examine the patient, take a thorough history in the light of proper test results, And a lot of institutions, they use CT scan as a gold standard investigation modality to any patient who presents with acute flank vein for obvious reasons. But the cost effectiveness and the radiation exposure of CT scans has been questioned, and younger generation are more prone to radiation exposure, which increases their chances of cancer, which is where scoring systems come into the play. And this is about a modified stone score, which was derived from the original stone score, which we'll be getting to know about a little while later. And scoring systems, they reduce the use of needless imaging, they reduce the hospital stay, and also minimizes the radiation exposure. So this study was originally done by a researcher named Kim, who came up with modified stone score. So all he did was, in the original stone score, there was a parameter called as race, which is underrepresented in Asia, which is why he interchanged race and replaced it with CRP and prior stone history. So that made up modified stone score. Now, the main purpose of this study was to see whether modified stone score was how far and effective was it in Indian population. And it divided the population as low, moderate, and high risk for ureteric calculi. So this was conducted in the ED department of emergency of Amrita Hospital in Kochi, and it included all the patients who presented aged between 18 years, and it was done in the study period of between July 10th and October 10th, and all the patients with a history of trauma, pregnant females, and those with renal transplant and active known cancer and CKD were excluded. And of course, to confirm the diagnosis, CT scan was done. The data which was collected was the demographic information. Along with this, all the parameters which made up modified stone score, like the gender, duration of pain, CRP, hematuria, past history of stone, and in a field of more than 4 RBCs was considered to be significant. Now, this score divided the parameters as low risk, moderate risk, and high risk, with low risk being given points of 0 to 4, 5 to 9 being moderate, and 10 to 16 was the high risk group. This is the comparison between the stone score and modified stone score, and as we can see, the race and nausea and vomiting has been interchanged with past history of stone and CRP of less than 5. So this was to see how to see in Asian population, because race was underrepresented, black race. The statistical analysis, the chi-square test was used to study the statistical significance of the association, and p-value of less than 0.05 was considered to be statistically significant. Now, as we noticed, out of 81 patients, 63 of them had CT proven ureteric calculi, and those with lesser, and as we see further, that 96.1% was the prevalence rate, and most of them fell in the high risk group. And the one in the low risk group did not even have ureteric calculi. So this divided as low risk, moderate risk, and high risk, and as the score kept increasing, the chances for the patient ending up with ureteric calculi also kept increasing. So MSS positive was considered to be those with score of more than 10, and MSS negative was less than 10. And as we can see, ureteric calculi had a prevalence rate of 96.1%. ROC curve was used in order to determine the optimum cutoff, and it was taken to be 10 with a sensitive value of 0.84 and specificity of 0.88. The discussion part, the prevalence which was done in the original study had about 79%, and it included around 700 patients, and R had 96.1%. And in the Turkish population, the recent studies rated from 49 to 84%. The ideal cutoff, even in the original study, was pretty much in sync with R, with the cutoff being about 10, and those having more than 10 was considered to be MSS positive, so they had likelihood of getting a ureteric calculi. But the limitation of this study was that this was only about 81 subjects were used, so it was a limited setting, which is why we need to do it on a larger population in order to measure the external validity of this score, and it was greatly influenced by a lot of other etiologies for ureteric calculi. To conclude, when we interchange race and nausea vomiting with CRP and a prior history of stone, we have higher chances of the patient having urinary calculi, and they can be taken up for CT scan. That's about it. Thank you.
In your scoring system, you have given 6 marks for hematuria and 3 marks for male sex. So stones can happen in females also. So why 3 marks for male sex? And hematuria is not very often and is not very frequent in patients who have stone. Patients, they just present with renal colic, and hematuria is not a common presentation. So that can lead to a very biased.
Thank you for the question, sir. But there's this, in a journal, Global Journal of Research Analysis, a researcher named Sophia and Nalini, when they, according to their study, males were having more prevalence of getting urinary calculi than females, perhaps, which is why he regarded the score for males as 3 and not females weren't considered, because urinary calculi apparently is more prevalent among males than females. As far as hematuria is concerned, possibly because that I'm not.
How many patients who present with renal colic present with hematuria?
Very few, sir.
Any further questions?
I think the hematuria was given score 6 because of its specificity with renal colic. If the patient with renal colic is having hematuria, then the chances of renal stone is very high.
Hello, I am Professor Ranganathan, Professor
Hello,
of
sir.
Surgery from Coimbatore Medical College, retired, and now I'm Karpagam Medical College, professor. And the hematuria in stone is when it is passing down, creating raw area, then it will result in hematuria. A unmobilized stone which causes pain or due to infection may not have hematuria. And moreover, hematuria can take only 40 to 50% only is a stone indicator, because hematuria can be an ordinary urinary infection, concentrated urine, passive concentrated urine. So many umpteen number of causes are there. And moreover, age also you have taken. If a 70 years old male has an hematuria, the cause may be entirely different. They can have loin pain, prostate, urinary infection. So many causes are there. So hematuria with flank, radiating flank to loin pain, and as you said, male, more, you said in European study, but in Indian study also there is a more prevalence of stone in India. So you have to consider age also, the climatic, mainly climatic condition also. For example, in chill climate where they will be passing more urine instead of more sweat. So how much, what is the climatic area, what is the age group, male preponderance, and hematuria to some extent also will help you. This is my personal opinion.
Thank you so
Somebody
much,
can
sir.
add also.
If there are no further questions, then we'll break for a quick tea break. It's 10:42 and we'll be back in 10 minutes now. Thank you. And following this, we'll have a young faculty talk starting with Dr. Himanshi in the same hall. Thank you.
We'll start with the third session of today of Young Faculty Talks. We have judges Dr. Suresh S. David and Dr. Atul Saroj for this session. I would like to invite the first speaker, Dr. Kasturi.
Hi, good morning all. Myself Dr. Kasturi Raja. I'm from Calicut. I'm working as a specialist in emergency medicine in Astra Group in Kerala. Okay. So before going to this section, let me ask a small question. So as an emergency physician, what is the most important challenge which we face in our daily life in our ED? Is it a trauma? Is it an MI or a stroke or lots of other emergencies? Yes, definitely yes. But in these situations, sometimes we may get a very rare case where we get stuck at times. How to proceed? What are the tests which we have to offer for the patient? Which specialty we have to inform? Okay, so let me go to a very rare case which I have encountered in my ED a month ago. And one more thing, this case before coming, I got a lot of calls from our head of the department of our head HOD in ICU and our director also. So I was also very keen, what is that case? So I just want to bring this case in front of a very big platform in front of you. So hemophagocytic lymphohistiocyte, it's a rare but life-threatening emergency. Let's see how it works out. So this is a case scenario. We got a 24-year-old female who just had a hypothyroidism who was taking on an L-Troxin. So she presented to ED with a complaint of high-grade fever, headache, vomiting and loose stools for last 3 days. Quite normal presentation in every ED. Maybe we may get 10 to 20 cases a day with the same complaint if it is a very busy ED. So, but after that, the history was like complaints of irritable behavior from today evening. With this small complaint, why the patient should go for irritability? History of she had a history of return from Bangalore a week ago. But no other complaints, no history, no any negative history. And initially she was admitted in a local hospital for the same, and she was diagnosed with pancytopenia and referred to a hospital. Okay, pancytopenia, that case can be any malignancy, or it can be any other blood dyscrasia. And LMB was 2 weeks ago. But primary survey, nothing positive I could find. Airway was patent and protected, breathing was spontaneous with good air entry in bilateral, saturations were quite normal with 96%, and circulations were very well, 110 per minute of pulse rate with 110/70 of BP, and all peripheral pulses were quite normal. And GCS was 15, she was giving me the complaint, and her GRBS was quite normal, 94 with pupils of good 2 mm reacting. And exposure was, I couldn't find any rashes, no external injury. But when I was talking to the patient, immediately she became irritable, she was like drowsy. Then again she became into quite consciousness. Really telling, I was thinking she was just mimicking, she was hyperventilating even. ABG was also taken, which was quite normal. And secondary survey also, nothing positive I could find from this. She had a fever, headache, vomiting, and loose stools. And maybe she had a travel from Bangalore. Some food poisoning can be a reason, we were thinking. And she's not allergic to any medication, just on L-Troxin. And last meal was just 3 hours ago, and she had just a history of travel from Bangalore a week ago. Head to foot examination, everything were normal, conscious. Her higher mental function were with normal limit. Power were good, 5 in all 4 limbs with no hypotonia. Reflexes were normal. Sensory were normal, and cerebellar was also normal. But I couldn't assess the gait, but she was not cooperating for walking. She was telling, ma'am, I couldn't walk, I'm very tired. And respiratory system wise, only positive finding which I could get is like a very minimal basal crepitations. Apart from all things were quite normal. Cardiovascular, quite normal. Abdomen, she was having a mild distension with left hypochondriac tenderness, but no guarding or rigidity. So what else we'll do in ED? We'll do the basic bedside test in ED. ABG was taken, just a very mild metabolic acidosis with bicarb of 20 and pH of 7.3. ECG was sinus tachy with heart rate of, rhythm of like 110. POCUS IVC was collapsed, she was a bit dehydrated. LV was good, no RWMA, bilateral B lines were present. Chest X-ray, only very minimal diffuse infiltrates were present. And course in the hospital. So what we did, we just informed the internal medicine consultant who was on call, admitted in MD ICU. But I was following up, what was this case? We couldn't diagnose anything from ED, just like an LRT or acute G we were keeping in an MD ICU. On second day, she started to deteriorate, and sensorium got worsened. She was started on inotropes and endotracheal intubation, and next day she was on mechanical ventilator. CCT was done because of the pain as well as abdominal distension, which showed like bilateral iliacus muscle venous ooze, and so as hematoma, gallbladder edema, fluid collection with colon edema. But USG was done on the same day evening when she presented, which was quite normal from outside hospital. And third day, she deteriorated again very badly. She developed pancreatitis and was found to have elevated serial elevation of troponin I, and ferritin, fibrinogen, triglycerides showed an increasing trend, which we had definitely not sent from ED. She developed non-oliguric AKI the next day. And fourth day, in spite of all the effort, at midnight, her vitals crashed. Saturation BP was not recordable. She went into brady and finally into a VT and cardiac arrest. Ultimately, she succumbed to the illness and expired in spite of all the effort. So to tell this case, what were the DDs which we had was like in the my mind was like it can be any malignancy. Pancytopenia was there definitely. The counts were like HB of 3.5 initially with WBC of 280 and platelet of 13,000. So next day or after 1 or 2 days from IC only we got a diagnosis for this patient. It was a ultimate case of HLH. Hemophagocytic lymphohistiocytosis. It's an aggressive and life-threatening syndrome of excessive immune activation. It most commonly affects infants, usually less than 18 months, but is also observed in children and adults of all age group. HLH can occur as a familial or a sporadic disorder and can be triggered by events that disrupt immune hematosis. Infection is a common trigger for this, and most commonly EBV, Epstein-Barr virus. Pathophysiology is like excessive inflammation and tissue destruction due to abnormal tissue activation. There will be hyperinflammatory and dysregulated immune system, and that will lead to the three of the following pathogenesis like macrophage, NK cells, and cytotoxic lymphocytes. What happened to them? Macrophages will become activated and they secrete excessive cytokines leading to organ failure. And NK cells are like natural killer cells which we have, and they get damaged and they infect the macrophages. And cytotoxic lymphocytes, activated B cell lymphocytes, macrophages are foreign antigens and they activate more of CD8. Genetics wise, HLH 2004 study, this is the only criteria where we can find out HLH. All the criteria were there for my patient. Fever was there, splenomegaly, bicytopenia, triglyceridemia and hyperfibrinogenemia, which were like thousands. Hemophagocytosis, ferritin and absent or low CD count. Labs were positive. DDs were these things. And clinically, the diagnosis after made, we have to treat her. But for her, before we start the treatment, she succumbed to death. Etoposide is a drug of choice, and hydrocortisone intrathecal methotrexate can be also administered. Supportive treatment can be infused. And these are the clinical markers are like daily ferritin we have to start off, and long-term cure is like we have to do a stem cell transplantation. So HLH is only rare until you know it's diagnosed. Thank you.
Any questions?
So what does this diagnosis turn out to be? What triggered this HLH in this particular patient?
Sorry, sir?
What triggered the HLH in this patient? HLH always has a trigger.
Yes, sir. So we were thinking maybe any viral infection can be a triggering force. But we were about to study genetic study, but that couldn't happen. So we are thinking it can be any kind of sporadic infections only.
I think genetic study more rational would be if there's a familial trend of some sort.
Yeah.
It's not a very uncommon condition.
Yeah.
Emergency medicine residence training as far as my hospital and PGI Chandigarh is concerned, this is the first one we consider.
Okay.
Any dengue patients coming in with thrombocytopenia, there is one scope that it could be hemophagocytic syndrome, and it's proven also. There have been studies, MD studies done that hemophagocytic syndrome is responsible. Typhoid, malaria, Epstein-Barr, we have seen Epstein-Barr, but not as common, often an autopsy diagnosis, because my institute is very forthcoming as far as autopsy is concerned. So as far as Indian continent is concerned, I think we should be Epstein-Barr upfront, you should be considering the other infection. There is an infection-associated hemophagocytosis, there is a malignancy-related hemophagocytosis, and so on and so forth, and one which is genetically, out of which the genetically one is more common in infants, in children, childhood, pediatric age group. Adults, we mostly see is infection. And etoposide is a drug you will not use as far as infection in hemophagocytosis is concerned. You use dexamethasone and you use IVIG, in intravenous immunoglobulin. Dexamethasone is only used where the hemophagocytosis, despite treatment, is not responding. Okay, and mostly these will be people who are very, very sick. There are two variants. There is a neurological variant and there is a cardiac variant. The neurological and cardiac variants are both quite deadly, and the fatality rate in both of these is quite high. But as far as the tropical disease related, scrub typhus and leptospirosis, or typhoid and malaria and dengue, they are not as bad as the other ones. If you have a trigger which is a malignancy, these are probably some of the ones who will not survive. Like you have a smoldering lymphoma or a smoldering leukemia, and that goes on in malignancy, then the mortality rate is quite high.
In this situation, for her, all the infection forms were negative. We have ruled out everything. So maybe some genetic only may be the cause. Thank you.
As sir said, it is actually not really very rare. It is very common when you see patient who's crashing, who's presented with some viral illness. We have seen it very frequently. Patient presenting with pancytopenia. So what you should do is get a TG level and ferritin and think about HLH. Keep it in mind, and as sir said, usually if it is infection, we usually treat it with IVIG.
I think you have come down already. Doesn't matter. I must compliment you on the way that you started off. It was really nice, and you sort of put yourself at ease and put everybody else at ease. That was good. It's good for me to know about this, because I don't think we as emergency physicians will be making a diagnosis, because I think even you took 3 days to make this diagnosis. I guess in areas where it's endemic and more common, or you're more aware, you get to know, but I could not gather how you made the diagnosis. Was it based on bone marrow that you did, or was it on?
All the markers were positive. Ferritin were highly elevated.
So it is actually. Think of that, okay. So that's good. Basically, it's a diagnosis which you do by exclusion of everything else, which is common, especially in our parts of the country. But obviously, up in the north, I guess it's more common. So, which is good. Now, a comment on your slides. Okay. One is you need to mention as to how the diagnosis was made. That's important. In your presentation, I could not gather as to how you finally made the diagnosis on day 3. Okay. Your fonts are too small. I could not read, and some of your slides are very busy. So, and there is a lot of space, because I am telling you is you are basically an emergency physician. You work in Aster Medicity in the emergency department. So, and you will be teaching your residents. So make sure that your font size is good so that they'll be able to see better. Okay.
Just a small comment, as I said, everything should not be read from the slide. Okay? Slide should be minimum 5 lines with 5 words in each line. That should be, otherwise it is a good presentation.
Thank you. I call upon our next speaker, Dr. Himanshi Bed.
A very good morning to everyone present here. I am Dr. Himanshi Bed. Today's topic is methemoglobinemia in ED. Before we move forward with the topic, I would like to discuss one case that we came across in the night shift. This was probably the first case that we had seen of methemoglobinemia. A 35-year-old male patient was brought to the ED with an history of consumption of 200 to 250 ml of ink remover under the influence of alcohol approximately 8 hours prior to presentation. He was hypoxic, which was refractory to supplemental oxygen. Patient was tachypneic, there were right infra-axillary crepitations. Patient was tachycardic, his GCS was E4, V4, M6. Patient was cyanotic, and his blood gas showed severe metabolic acidosis with a PaO2 value of 110. So this was the first case, and we suspected methemoglobinemia in this patient because of the following. Exposure to methemoglobinemia inducer, there was a possibility because of the ink remover intake. Patient had refractory hypoxemia, and there was a cyanosis along with a saturation gap. And on blood gas analysis, when we had drawn the sample, the patient's blood was brown. The common agents involved in producing methemoglobinemia include local anesthetics, benzocaine, dapsone, aniline derivatives, nitrates and nitrites, quinones, sulfonamides, and when a patient has been in a fire. In our patient, when we got a look at the bottle, we found that it was because of aniline dye derivatives that our patient had methemoglobinemia. The clinical features of these patients depend upon impaired oxygen carrying capacity and delivery, the absolute levels, rate of production and elimination of methemoglobin. And we have to keep in mind that if patient has corresponding anemia, they have a less severe presentation. However, the patient is critically more ill in these cases. So, according to methemoglobin levels, the clinical presentations are seen in the patient. We suspected that our patient was probably in a range of 50 to 70% because our patient had a altered sensorium, he had metabolic acidosis, patient was tachypneic. The main reason why we were suspecting patient to have methemoglobinemia was because of the presence of the saturation gap. Patient's pulse oximetry showed a saturation of 86%, while his ABG PO2 was 110. So the difference is because SpO2 is measured by pulse oximetry, where light absorbance at the wavelengths of 660 and 940 is taken for oxyhemoglobin and deoxyhemoglobin. Methemoglobinemia absorbs both these wavelengths, and thereby it causes a discrepancy in the reading. And we found that there was a saturation gap in our patient, and thereby we were thinking this patient could have methemoglobinemia. In situations where we are suspecting and we have the modality of measuring co-oximetry, that should be done to get the exact levels of methemoglobin. Another aspect in diagnostic testing is bedside estimation. This tool has still not been validated. A study was done with in vitro levels, and a bedside tool was made. This study has been, this particular bedside testing has been incorporated only once in Sri Lanka, and they saw that a reduction of 10, from a mortality of 10 to 3% in patients who had a herbicide-induced methemoglobinemia. However, there is scope for further validation, as we can use it in bedside condition, and when we didn't have co-oximetry for our patient, then also. The major management pillars include resuscitation, withdrawal of the drug, antidotal therapy, while keeping in mind special circumstances. So the methylene blue is considered the main antidote for managing these patients. It acts by reducing, oxidizing NADPH to NADP and converting methemoglobin to hemoglobin. We considered empirical therapy for our patient because there was a highly suggestive clinical scenario and our patient was critically ill. Otherwise, if we have levels, we should consider therapy for patients who are symptomatic irrespective of the methemoglobin levels, or those who have methemoglobin level of more than 30%. Methylene blue, if after initiation we do not see a response within 30 to 60 minutes, then we should consider and evaluate for other causes of oxidative stress, other possibilities. We could consider decontamination of gut and skin cleansing at this point, and additional doses are also to be considered if the patient has methemoglobinemia. However, we need to keep these adverse effects in mind. Methemoglobinemia infusion could be extremely painful. It could cause paradoxical methemoglobinemia. There may be bluish-green discoloration of urine which causes dysuria, and in ED we have to consider the possibility of serotonin syndrome, because some patients may have psychiatric disorders and may be on these medications. So we have to keep that in mind while giving methylene blue. Two special circumstances which I would like to mention here is the presence of G6PD deficiency in a patient. Here the role of methylene blue is controversial. If we do not know the patient has G6PD per se, then we have to it is better to analyze the risk benefit and consider giving methylene blue. Another is dapsone-induced methemoglobinemia. We come across a lot of patients who are having HIV, leprosy, who are on dapsone treatment. So in this case, we have to keep in mind that dapsone has a longer half-life and it produces metabolites which increases the duration of methemoglobinemia. So here, in addition to methylene blue, cimetidine should be considered, which is a competitive antagonist. The other treatment modalities include exchange transfusion, hyperbaric oxygen, and ascorbic acid, but the role of each of them are still not properly evaluated. Our patient was managed along the same guidelines. The patient improved within 1 hour and was shifted to ICU, provided supportive care there, extubated in the very next day, and discharged after psychiatric evaluation on the 3rd day. For us, this was a success story and a patient went smiling back. So I wanted to share this patient with all of you. Thank you.
Any questions? Actually, shouldn't run out of time. They have started at countdown at 6. Young faculty talk is for 10 minutes.
So are they timing correctly or not?
No, I'll tell them.
Because based on that, we're putting the bar.
Yeah, only this talk.
Very good diagnosis and treated very well.
Thank you,
I
sir.
just wanted to make a comment. This is methemoglobinemia is abnormal hemoglobin which has abnormal where the heme is converted into ferric. And remember, ferric is always hysteric. And the thing is, the pulse oximeter doesn't work. You need a co-oximetry,
Yes, sir.
which you didn't use. So you need a co-oximetry, and if you diagnose it right on time and you give methylene blue, results are most of the times rewarding.
So we didn't have co-oximetry right at that time. That's why we couldn't actually measure the levels.
Actually, if you have a keen sense of observation, as you had, you recorded the gap between the ABG and the
Yes,
pulse
sir.
oximeter, that's a very good clue. And co-oximeters are no big deal. Nowadays, all equipment that you get, they have co-oximetry, sulfahemoglobin also, as well as methemoglobin. It's very important in pediatric care, as I understand. They do it very frequently.
Yes.
I'm just a little bit, the printer's ink, it's normally nitrobenzene, which is the printer's ink that does whatever cases that have been recorded. Here it is the eraser.
Yes, sir. That is why we were not sure at the first point.
Okay.
Because they said ink remover.
I think you should also consider the fact that people coming in with poisoning often don't report the proper
Yes,
thing,
sir.
what they've actually consumed, just for fear of medical legal issues.
Yes,
So
sir.
they
For
will-
this patient, it was the wife who was working in a printing industry and she had brought in that ink remover to use as nail polish remover at her place. That is how this patient consumed this substance. So later the bottle was brought to us and then there we found.
Okay. Anyone hall wants to ask questions? Exchange transfusion is a good modality. It's not been evaluated.
Yes, sir.
Another thing
Theoretical benefit
the
only.
hall might realize is that in critical care and emergency medicine is not the place to do a randomized double-blind placebo-controlled trials because it is unethical. So you're going to be having collections of cases which some researcher has very carefully gathered and published, and the numbers may not be too high as compared to regular surgery or medicine, where numbers go up to 500, 600. That's why you find emergency and critical care literature with numbers that are far less than what actually the alpha may be, the calculation, statistically calculation may be. So you will never have that. You only have to collect these cases and see what happened after you gave them the methylene blue.
What is the anion gap of this patient?
Sir, anion gap for this patient was normal.
Okay, actually, especially in toxicology practice,
Yes,
whenever patient with a high metabolic acidosis coming in emergency, it should be
Anion gap.
considered because
Yes, sir.
other toxins who can present it with high anion gap are any,
Yes,
you
sir.
know, which
High
are-
anion gap metabolic acidosis, the
Which are-
toxins, methanol, toxic alcohols can present with then isoniazid, iron,
and the propyl
metformin.
propranolol glycol poisoning
Yes.
can also present with.
Yes, sir.
Thank you.
Thank you, sir.
We call upon our next speaker, Dr. Anjula.
A very good morning to all. I'm Dr. Anchala Jalil, right now working as a senior resident in Dhanlakshmi Srinivasan Medical College, Trichy. My topic for presentation today is crashing obese patients in ED. So the obese patient whose condition is unstable, rapidly changing and requiring emergent resuscitation. They present a unique challenge even for the most skilled emergency physicians. The challenges lie not only in managing and treating them, but also in providing dignity and respect. The challenges and the critical components in the resuscitation arise due to changes in anatomy, cardiopulmonary reserve, metabolic demand, ventilation, circulation, and pharmacokinetics predominantly. So I would like to say that an obese patient is not just a bigger adult, and it is imperative that we are familiar with the pearls and pitfalls while dealing with such patients in order to minimize morbidity and mortality. And I would like to say that the challenges we face is so numerous and it is beyond the scope of a 10-minute talk, but I'll try my best to cover the most important topics. So first, alterations in the respiratory system. Because of the excess cervical adipose tissue, they have increased neck circumference, which limits neck extension, pharyngeal airway narrowing, anatomical landmarks are obscured, along with the loss of neuronal compensation when we use sedation. All this can lead to higher chances of upper airway collapse. And physiologically, they have a decreased respiratory reserve but increased metabolic demand. They also have increased airway pressures, increased intra-abdominal pressures. They are at a higher risk of aspiration. They are difficult to ventilate with bag mask, and they have a shorter safe apnea time. All these together will lead to a rapid onset of hypoxemia during rapid sequence intubation, which can eventually lead to a peri-intubation cardiac arrest. So I recommend that it's wise for us to consider each and every intubation of an obese patient as a difficult intubation, and adequate preparation is of paramount importance. The following mnemonic can be used: bigram mnemonic while dealing with the airway of obese individuals. By time. We should increase FiO2 and recruit as much lung as possible. The normal face mask and bag mask ventilation are found to be insufficient, and whenever clinically feasible, we should make use of non-invasive positive pressure ventilation, preferably CPAP, and at pressures of 10 centimeters of water, which is shown to decrease atelectasis, increase oxygenation, and increase the safe apnea time. And ideally, it should be maintained for at least 5 minutes duration if clinically feasible. The use of high-flow nasal oxygen devices prior to RSI, the evidence supporting their use is limited as of now. And we should optimize medical therapy, resuscitate before you intubate. And if everything fails, a supraglottic airway can provide an alternate bridge to a definitive airway. And from bigram, I is indication for intubation. We should consider whether you really need to intubate now, or you have time to optimize the patient first and to make other technical arrangements ready and get help. The most experienced physician should be the first to attempt intubation. There is no ego or hurt in calling for help in such difficult situations. And ramp. This positioning is very important, because we should align the patient in such a way that their external auditory meatus comes in line with the suprasternal notch. This can be achieved by using towels, multiple towels, and commercially available products. Also, we can use reverse Trendelenburg position to weight the pannus off the chest. And this can be done if the other hemodynamic parameters, hypotension, and all are ruled out. So this proper reverse Trendelenburg positioning will help in decreasing the air trapping, atelectasis, and improve oxygen saturation. And apneic oxygenation using nasal cannulas are recommended. Use of minimal drugs, pre-oxygenate with NIV as already said, and many literatures recommend against using paralysis in most critically obese patients, because we can encounter a cannot oxygenate, cannot intubate situation. And whenever possible, awake intubation using video laryngoscopy is preferred. and plan for failure and post-intubation care. There is high likelihood of failure, and we should be ready with all our advanced airway equipments and surgical airways. And video laryngoscope, gum elastic bougie, supraglottic airway devices can help. And the surgical airways are also going to be challenging, and I would like to recommend this laryngeal handshake technique for identifying cricothyroid membrane during cricothyrotomy, and cut a large vertical incision rather than first attempting to identify the cricothyroid membrane through the adipose tissue. This is because of the distorted anatomy due to excess adipose tissue deposition. Breathing and mechanical ventilation, considering their physiological alterations and rapid onset of hypoxemia, a few changes has to be made in the ventilatory settings. Regarding the mode, to date no superiority of one mode over the other. Some prefer pressure control ventilation because a decelerating waveform may improve the distribution of airflow to the alveoli. Tidal volume 6 to 8 ml per kg of ideal body weight. This is to prevent ventilator-induced lung injury. Always remember, a large chest wall doesn't mean that there is large lung. Respiratory rate, because of the increased metabolic demand, the normal baseline respiratory rate is 15 to 21 per minute, and it should be set like that unless other problems are there. And PEEP should be set at a higher side. A PEEP of 10 centimeters may be needed initially. In settings of expiratory flow limitation, auto PEEP buildup may be there. In such cases, extrinsic PEEP should be set at 2/3 of intrinsic PEEP. Now circulation. Hypertension is the norm. This is because an increase in body weight about 10 kg above the advised body weight can result in systolic blood pressure increase by 3 mmHg and diastolic by 2.3. Also, the narrow BP curve will overestimate the BP. So whenever a critically ill obese patient is normotensive, we should be worried. Presence of an occult shock may be there. Bedside index shock index may be of help to identify such occult shock, and we should consider early invasive hemodynamic monitoring methods, like consider going early for an arterial line. ECGs also can be misleading. Low voltage complexes can be present due to increased adiposity. Disability, again, is assessment is very difficult. Their pain perception is deceptive. More chances of missed injuries in trauma. Exposure again is difficult. Log rolling is difficult. More manpower is needed, and the necessary equipments to accommodate such a big patient should be made ready in the ED. Getting vascular access, very big nightmare. Peripheral intravenous cannulation is often difficult. We should make use of ultrasound in such scenarios and consider going early in for a central line cannulation. This again will be very challenging because it is difficult to put the patient in a required position for central line cannulation, distorted anatomy. In all these scenarios, we should make use of ultrasound as much as possible. And regarding pharmacotherapy, most of all the dosing recommendations are for non-obese population, and they are extrapolated to obese individuals. This can lead to underdosing, can lead to treatment failure. Overdosing can result in toxicity. So the most commonly used drugs in ED, those which are lipophilic, they should be given based on total body weight because there is rapid distribution in the peripheral tissues. Whereas hydrophilic drugs, the volume of distribution is lower. We should give it based on ideal body weight. We all know how to calculate an ideal body weight. So commonly used drug based on total body weight are succinylcholine, rocuronium, etomidate, and ideal body weights are steroids, digoxin, atracurium, fentanyl, midazolam, etc. CPR, regarding CPR, there is not much changes. It is same like ACLS guidelines, but it is difficult and requires extra effort, and it will be tiring, and we may have to change the CPR doing staff 2 minutes, every 2 minutes, or mostly earlier. Defibrillation hands-off electrodes are preferred because it is difficult to reach the paddles across the large chest and to keep the operator's body from touching the body of the patient. There are a lot more challenges in trauma, limitation in X-rays, fast, size limitations of CT machines, placement of chest tubes, increased risk of decubitus ulcers, thrombotic risk, sepsis management, nutritional factors, the use of standard assistive equipments, and of course, pediatric obese population. All these things, I believe it is beyond the scope of a 10 minutes given to me. I'm really sorry for that, but I would recommend more reading on such topics. So I would like to conclude the management of obese patients differ particularly and critically in areas of pre-hospital stabilization, airway management and hemodynamic support. Even after initial resuscitation, they face higher rate of complications and mortality which requires special attention. Thank you. Any questions?
I think the things have been reiterated. I'll just say a couple of slides, your fonts were not very clear. I think probably they've been taken a snapshot from a PDF without adequate this thing. So you should be aware about copyright issues as well, because this might raise, it's not a problem as far as India is concerned, but if you go to the West, there's a lot of issues involved. So always attempt to make your own this thing, and with AI, artificial intelligence coming in, it's not a big deal. You can visit only ChatGPT websites and they'll do it for you for free without any of this. I think there is a method for intubating them. Rapid sequence intubation is what anesthetists practice. And for emergency physicians, it is usually where the situation is more chaotic. It's a delayed sequence intubation. You wait for stabilization, you wait to get the SATs up, you wait for oxygenation, you wait to get the patient in the proper size trolley or bed for these obese people, and then you do. Whether you need to use drugs for getting the patient into that state, or you need a supraglottic airway, that is an individualized decision depending from patient to patient and the parameters that are rolling in. Like you attach a monitor and you see hypertension, what do you do? Like you see a patient desaturate, then you go for airways and all. And I think even in India, supraglottic airways are the way to go. But I am not sure whether you find an adequate size airway in a very tall and obese. Like from the area I'm in, Punjab, you have these 6 foot 7 inches, and they've got huge, these tongues, massive tongues and all that. So in that case, I think the size of the airway, the supraglottic is not tailored to that individual anatomy. So these are some of the challenges that you face, and each hospital will have to devise one way or the other. Maybe early video laryngoscopes again, but in a busy emergency department, how frequently can you? There will be a lot of breakage and there will be a lot of use and the sterilization period.
Definitely, sir. Depending on the patient's clinical condition, we decide on whether to go for rapid sequence intubation, delayed sequence or drug-assisted intubation. It's all individual based, sir. But recently, I would like to share that 2 days back, I had a patient with who is around 200 kg body weight, who presented with pneumonia. Frankly, our hospital bed was not enough to accommodate the patient. All we could do was we stabilized him, his respiratory distress, and we referred him to a setting where a CT scan could be taken, because we tried a clinical examination was not, we could not auscultate properly, we could hardly hear the breath sounds. POCUS again was ineffective, we couldn't get a proper idea. Then X-ray was out of role there, and we tried to shift him to CT, again it was not possible. So we stabilized him, his airway breathing circulation was stabilized, and we referred him to Trichy, where we made sure that he can be shifted for a CT, and ICU setup was there to accommodate such a big patient, sir. And he was hardly 27-year-old.
Could he fit into the gantry? That's the issue. 200 kilos would be huge. You can't even get him into the gantry of the CT scan.
We couldn't do, sir. We tried in our hospital, we couldn't do. We asked in Trichy Pixel Scan, they said they can do it there. So we shifted him there, sir. We shifted to Apollo.
And the other thing, I think people in emergency medicine are quite scared of ketamine. I don't know why. It's a wonderful drug.
No, we liberally
You should use it liberal.
Sir.
You should use it much more liberally as compared to this.
Okay, sir.
Because I understand there was an anesthetic issues and all, but now it's no longer a major issue.
We use it liberally, sir, provided we have an additional benefit of preserving the respiratory drive. So in our hospital, we liberally use
ketamine doesn't interfere with respiratory rate or blood pressure much.
No, depending on the...
and bolus doses in care is not an issue.
Okay,
even with
sir.
RAISE ICP, they've used it in aeromedical support,
Yes,
and they use it in trauma patients,
Yes,
traumatic brain injury, being transported to hospital. They use ketamine for
Yes,
stabilization. Individual doses will not have a problem. The problem here is RAISE ICP, glaucoma and all that. That is the problem for a prolonged use, for the ICU use, in infusional use. Bolus doses don't create any problems, that the infusion does.
Okay, sir. Thank you, sir.
No, you go ahead, please. Just one suggestion that if you are seeing obese patient, then you should put your own patient's snap instead of borrowing from outside. You just take consent from them Another one, you should put references from where you have taken your content. Okay. Otherwise, this is a very new challenges coming for emergency physicians, because every hospital is seeing a lot of obese patients, especially early obesities, children with obese, and we need to harpen our skills for intubating and managing IV lines in these patients.
Thank you, sir.
That was a very challenging topic that you took up, to look at the crashing obese patient. Because with the given time of 10 minutes, if I were in your position, I would have requested that please give me only airway and ventilatory management. Because the entire pathophysiology you will have to do in detail. So that's very, very difficult, but I am really impressed that you are able to wind up on time without sitting there in limbo. The presentation was good, all was well. Just one comment that I had was, it's a compliment actually to you that you talked about the difficulties that you've had with the particular patient. So what I would suggest to you is, in future, when you take up such topics to discuss, talk about some of the experiences that you've had because you work in a setup where you come across a lot of obese patients. So pick up one particular topic, just a subsection of a topic, especially if it's a short talk, and describe the experiences that you went through, because that's more realistic. Otherwise, it's more of a textbook kind of a thing.
Yes, sir.
Okay.
Definitely.
Well done otherwise.
Thank you, sir. Thank you.
We call upon our next speaker, Dr. Aditya.
Vertigo. It's a kind of wordplay. What exactly I mean by vertical vertigo is the vertical nystagmus usually seen in the central causes of vertigo. So these are the contents which I'm going to go through today. Let's see some of the internationally accepted definitions of vestibular syndromes. Firstly, the dizziness. It's a sensation of disturbed or impaired spatial orientation without a false or distorted sense of motion. So pre-syncope is impending loss of consciousness, syncope being the actual loss of consciousness which is transient. Coming to vertigo, it's a sensation of self-motion when no self-motion is actually present, or a distorted self-motion during an otherwise normal head movement. As you all know, nystagmus is nothing but an involuntary rhythmic shaking or wobbling of the eyes. We have majorly three types of nystagmus, namely the horizontal nystagmus, be it from the left to right or right to left, or the vertical nystagmus, upbeat or a downbeat, and torsional nystagmus, which has horizontal and vertical components to it. So the traditional approach to the acute dizziness, based mainly on the type of dizziness, is most often misleading, or to say we will miss on the dangerous causes of the dizziness. So what I am going to do today is rely on this study which has been published in 2015, given the reference there. It's titled Titrate. So it has majorly 5 components to it, namely the triage. As you all know, based on the clinical signs and the vitals, we triage the patient appropriately. And timing and trigger, this we'll get from the history, bedside careful history. So with the timing, we'll get to know whether it is acute or chronic or episodic. With the triggers, we'll get to know whether there is any trigger present, be it a positional variation or exposure to any drug or toxins. So based on that, tailor-made targeted exam should be conducted to confirm our diagnosis. If needed, an appropriate test to confirm the diagnosis, such as the laboratory test or the neuroimaging. As I was explaining, based on the timing and trigger, whether the trigger is present or not, all acute dizziness can be put into these 4 syndromes, namely the triggered episodic vestibular syndrome and spontaneous episodic vestibular syndrome. So in the triggered episodic vestibular syndrome, we all know BPPV. So it is in the triggered episodic vestibular syndrome. In a spontaneous episodic vestibular syndrome, our cardiac arrhythmias or TAAs will come. And in the triggered acute vestibular syndrome, we have our post-exposure as content-specific post-exposure acute vestibular syndromes like the traumatic brain injury-induced dizziness or any exposure to the toxins or overdose of anti-epileptic drugs. In a spontaneous acute vestibular syndrome, we have our stroke, which is a very dangerous cause. We should not miss on that. As you can see here, the episodic vestibular syndrome, be it triggered or spontaneous, can again be traced based on our targeted history and examination into the emergent, which is in red, or urgent, which is in yellow, and less urgent things in the green. So in this category, we have Dix-Hallpike test being positive with the atypical nystagmus. A typical nystagmus for Dix-Hallpike, when we think of posterior canal, is the upbeat torsional. But when it is not that, then we have to go for atypical nystagmus. And then we should think of posterior fossa, masses, and we should go for neuroimaging. And if in case of atypical history with ABCD2 score of more than 3, then we have to certainly go for neuroimaging, and if it is negative, go for further workup of other medical causes. In acute vestibular syndrome, as I explained before, the emergent causes being when the hinge is central, we have to go for neuroimaging to rule in or rule out the strokes. So this is a similar approach called as ATTEST, the components being associated symptoms, timing, triggers, and examination signs and testing, just like I explained the titrate study. Coming to the individual syndromes, the triggered episodic vestibular syndrome, in that we have benign and dangerous causes. In the benign ones, the benign paroxysmal positional vertigo and the orthostatic hypotension. With the benign BPPV, we will get to know with the history. And if we do the Dix-Hallpike, it will be positive, and we have typical nystagmus as I explained before, and then we have to go for Epley's maneuver for the correction. If it is orthostatic hypotension, again we can pick it up with the postural PP measurements. So the dangerous ones being the central paroxysmal positional vertigo, which closely mimics the BPPV. But when you look at the nystagmus is atypical. This is when we should be careful, and we should go for neuroimaging to rule out the posterior fossa tumors. And other orthostatic hypotension which are dangerous are acute blood losses. So this can be easily picked up with the history and the laboratory test which we do initially. So what are the safe to go features in this category when there is no pain, auditory neurologic symptoms or syncope, and patient being asymptomatic at rest, and peripheral type of nystagmus, and a positive response to repositioning maneuvers. Coming to the next syndrome, that is spontaneous episodic vestibular syndrome, we again have benign and dangerous, but this cannot be triggered on the bedside, hence we have to rely more on the history part. So the dangerous ones here are TIA, SIH, in the cerebrovascular events, and in cardiorespiratory we have our arrhythmias and even the pulmonary embolism, hypoglycemia, and transient or intermittent exposure to the carbon monoxide can also mimic this syndrome. So what are the safe to go features in this category? No cardiorespiratory symptoms or syncope being present, no diplopia, dysarthria, dysphagia, dysphonia or dysmetria, and no papilledema, Horner syndrome, and cranial nerve signs. If more than or equal to 5 spells over more than 2 years of strong or long past history of dizziness episodes are present, then it goes more towards vestibular migraine again. APCD2 risk score less than or equal to 3, again it's safe to go feature in this syndrome. So another syndrome we are going to see is triggered acute vestibular syndrome. In this we have, as I was explaining before, traumatic brain injury and the drug intoxications. If it is traumatic brain injury, imaging will be CT or CT angio based on our history. If we are suspecting whiplash and vertebral basilar dissection, then we have to go for CTA. Then in drug intoxication, we have to go for detoxication. Next syndrome is spontaneous acute vestibular syndrome. In that we have 2 close mimics, that is vestibular neuritis and stroke. I hope we all know about hinge plus. So these are the components which are mentioned on the left side. And if it is the thing which has mentioned below the stroke, the typical ones being the bidirectional nystagmus and a new onset of hearing loss with a vertical eye movement in the cover and uncover test, that is a test of skew. So what are the safe to go features in this? Maximum 1 prodromal spell less than 48 hours before onset. This is usually seen in the vestibular neuritis, and no excessive vomiting or gait disorder being present, and patient can unassistedly stand or walk. and hinge plus being peripheral. We have a good mnemonic for that. That is SEND. SE is for straight eyes. When we do the cover and uncover test, the eyes remain straight and no new deafness will be present. And head impulse misses. That means that there is a catch-up saccade. And one directional nystagmus, that is unidirectional nystagmus, not the bidirectional one which we usually see in stroke. And when you look at the otic and then the mastoid, the examination will be healthy otic and mastoid examination. So let's look at some features of the nystagmus. Mainly the posterior canal BPPV, the test we use to trigger the spontaneous nystagmus is Dix-Hallpike, and the nystagmus lasts for 5 to 30 seconds, usually upbeat torsional, and it varies on rising, the direction varies on arising. And when you look at central paroxysmal positional vertigo, any positional movement can trigger that nystagmus, and it will usually last from 5 to 60 seconds. And the direction, again, it's not specific, variation also, it's not specific. And as I was explaining before, in case of stroke, the direction can be any again, but very typical of stroke is the vertical nystagmus, which is not seen in any other conditions. And it can be bidirectional, unlike we seen in the vestibular neuritis, that is the direction is fixed. So, a 42-year-old male, known case of hypertension, complains of worsening of ongoing dizziness on arising. Worsening of ongoing dizziness on arising. So, can you raise your hands whoever think this is going more towards the peripheral vertigo with the history? It's very limited history, I know. Any calls for peripheral vertigo here? No response? Okay, who thinks it's central vertigo? Okay. Very good. So let's see the answer. So there is a popular myth which says that whenever the dizziness worsens on the position change, it goes more towards peripheral vertigo, but it's not. If there is a baseline dizziness going on, and if it getting worsened, then we have to go more towards the central vertigo, and then we have to work for it. We should be a little careful in ruling out the dangerous mimics. So what are the take-home message in this? Algorithmic approach is always superior to the traditional, just based on the type of the dizziness approach, and always try to rule out the dangerous causes before ruling in the benign ones. Around 20% of the strokes are missed with the early DW MRI within 24 to 48 hours. So delayed 3 to 7 days of onset, DW MRI has to be planned to confirm the diagnosis. And the type of nystagmus rather than the presence or absence of it should be taken into consideration. And vertical nystagmus is almost always seen in the central cause of vertigo. These are my references. Thank you for the opportunity. Thank you for listening. Floor is open for discussion.
Dr. Aditya, good presentation. Your slides are okay. Just the case that you have kept in last, if you just keep in the first slide and give the audience chance that they have to answer in the end, then it will be more interesting. Okay. Other is just if you can practically tell 1 or 2 slides, you can practically show the changes of eye changes, or you can put a video also, small video, then it will be a better for audience.
Yes, I'll do that.
Otherwise it's good content and better.
And it's good that you have it as interactive. You asked, although there was no interaction, at least you made an honest attempt. That was good.
Thank you.
Thank you so much.
We have a next speaker, Dr. Prashant.
Good afternoon, everyone. This is Dr. Prashant, working as a junior consultant, Department of Emergency Medicine, Sundara Medical Foundation, Chennai. It's my immense pleasure to have a talk on this forum titled Trans Care and ER Physician Challenge. So the content of my talk includes introduction regarding the third gender health issues and difficulty in obtaining healthcare facilities, the risk factors seen with the third genders, the case we seen in our department, what my department doing differently to take care of this third gender, and finally the conclusion. So we know that transgender individuals face significant difficulties in obtaining high quality, compassionate medical care, most of which are attributed to inadequate provider knowledge. So my presentation aims to review the guidelines to ensure transgender care, including a review of relevant terminology and a few interactive tips and basics in medical and hormonal treatment and adverse events. And also the following case discussion and the review of literature also seeks to improve the practice of emergency physicians who are inexperienced in this arena. We know that third gender people have the following risk factors, like they are more likely to attempt suicide, their HIV infection rates are higher than the national average, there are higher rates of drug abuse, sexual assault and domestic violences, and also they are in a poverty and unemployed. The case scenario, yeah, we got a 32-year-old female. She was brought to our emergency department with a complaint of unilateral leg pain of 2 days duration. She got evaluated in the emergency department. Surprisingly, she turned out to be a third gender because the ultrasound showed a prostate gland. Later, she got diagnosed to have a left proximal vein DVT. For this, she was admitted in our emergency and she was treated with anticoagulant and compressive stockings. Later, she moved to the ward and she got discharged in an OPD basis. So what my department doing differently to take care of these third genders. So we came up with an approach to take care of these transgenders, so-called the transcare sheet, just like a trauma sheet. It has 4 components. First one is that the key questions, then we ask a sexual history and patient-centered physical examination, and finally the investigation. So this is a snap of the transcare sheet which we developed and we modified and we followed in our emergency department. Then we have a gender neutral restrooms next to the emergency department. And we assign patients to hospital rooms based on their self-identified gender, and the nursing staff should be educated on the way of care for this third gender. And we promoting our services by displaying the trans-positive materials in the department, and finally we collecting the feedback forms and proper documentation and referral if needed. So this is an important part of my talk. This is a transcare sheet which we following in our department. So the first part of the transcare sheet has key questions. We have 8 questions. First is the name and pronouns they prefer, the sex they assigned at birth, how would they like to describe their gender, and some questions related to their sexual health and the sexual activity. And also they ask any changes in their appearances, are they taking any exogenous hormones, or they had any or thought of having any surgeries to align their body, and finally they experience any physical, sexual or emotional violences recently. The second part of the transcare sheet is that sexual history. First we'll ask whether they are sexually active, if so what mode of sex they are practicing, whether an insertional or receptive, how many partners they have recently, are they following a safe sex, or also any protection against pregnancy and sexually transmitted diseases. And finally, before sending to a radiograph, we'll just do a pregnancy, suppose if they are ovulating. The third part of the transcare sheet is the patient-centered physical examination. This is a very sensitive area, so before doing an examination, we always ask for a chaperone if they wish for. The first thing is that we look for the genitourinary examination. In that, we clearly look for a clitoral enlargement or vaginal dryness, suppose if they are on any masculinizing hormones. The second part of patient-centered examination is that any evidence of feminizing procedures like breast augmentation and its implant risk, any bottom surgeries like penectomy, orchidectomy, vaginoplasty, and facial feminization like any alteration done to their jaw, chin, cheeks, forehead, any tracheal shave, and finally any silicone-free injection they adopted. The third part of the patient-centered physical examination is that any evidence of, just like feminizing, any masculinizing procedures, mainly manisculptures, hysterectomy, phalloplasty, the new penis implant, or the scrotoplasty. Once we do all the three part, finally the investigation part. In investigation, suppose if they were on any feminizing hormone, particularly if they are on estrogen and progesterone, they are more likely to get DVT and pulmonary embolism. So we ask a D-dimer, chest X-ray, if needed, CTPA. Second is if they are on anti-androgens, they are more likely to get hyperkalemia and prolactinoma. So we ask a baseline ECG, serum potassium and serum prolactin level. So then regarding the documentation, instead of normal way of documentation, we document as A30. Suppose in our patients, instead of a normal way of documentation, we wrote as 32-year-old gender queer patient. She was assigned male at birth, but she pronounced as she, presented with so-and-so complaint, just like in our case, like unilateral leg pain of 2 days duration. Once we do a documentation, disposition, usually they need a multidisciplinary team, particularly endocrinology, if needed, plastic, gynec, urology, and psychologists. They wish for means we'll plan for social services team, and finally we'll refer to Rajiv Gandhi General Hospital, suppose they're not affordable to a private care sector where the government runs a third gender clinic every Friday. Then we started collecting the feedback form. In that feedback form, we asked 3 questions majorly. First, whether they avoided going to ED or not. If so, what is the reason? Then if they visited ED, the doctor has refused to see them, or they use any insulting languages, or they refused to discuss or address their concern, or they told that they are not really a trans, or refused to examine their body parts. And finally, whether the third gender has tried to educate the emergency care provider, what is their actual concern or the problem is. These are 3 feedback questions. And to conclude, we know that transgender adult experiencing unwelcoming healthcare environments, non-affirming healthcare professional and institutional practices, most of them are inhibit the delivery of gender-affirming care. So this leads to widespread adversity and some barriers. So the integration of gender-affirming approaches in healthcare requires a standardized guidelines. This has been started implementing in many hospitals, including our hospital too. Finally, I thank my department for this opportunity to deliver a talk in this forum. And my personal suggestion is that when we MBBS revision of MBBS curriculum should deal or talk about some aspect of transgenders' health and issues. And regarding the insurance, most of the time insurance will be covered for all the thing, but these third genders, they have find difficulty in doing sex reassignment surgeries and hormonal treatment considering their cost factor. So prevention of insurance companies regarding this should be considered, and also a counseling center should be opened before they going for sex reassignment surgeries and the hormonal treatment before and after doing the procedures. And finally, some regular counseling and follow-up is needed. Then only we can provide a good health for these third gender people. Okay, that's the end of my topic. If you have any other questions, I'm ready to. Yeah, please, sir. So far, you may ask, are you seeing so much third gender people? We have seen only 2 patients hardly last 3-4 years. I did my PG as well as I'm continuing there. So far, we see only 2 patients. But we want to prepare for everything. So I selected this topic and want to discuss. Yes.
Thank you, Ravindran. Excellent presentation. I'm feeling really glad that you brought this topic up. So this and the one about the obese patients are something which, again, we as emergency physicians, we need to be aware of this, be prepared for it, and have protocols. And you've already started the journey of putting in a protocol. Having had experience working in the West with a lot of this category of patients, whether it is mega obese or transgender or homosexual or whatever it may be, one of the things we came across significantly was we need to be trained, which you've already started with your nursing staff. So as emergency physicians, as a front door of any hospital, we need to be very aware of how their expectations are. Yes. And many a times, they're also manipulative. So we shouldn't be judgmental, but we shouldn't fall into this kind of vicious journey of them taking more and more services just because they are this or that category. So being human, being non-judgmental and caring for these patients while not getting into trouble is a very important point. And I think you expressed it really well through your presentation. Thank you so much.
In our patient also, when we started evaluating and when we discussed about the investigation, she preferred a one person to discuss about all the investigation because she don't want to discuss the result to the other people. She came with the 3 friends, but she want to discuss the result with only one person. So that confidentiality should be maintained, and whoever they believe, we should discuss with them. And at the same time, we want to know what their relation should be.
Good topic that you have chosen for sensitizing emergency physicians and all this.
Thank you, sir.
Just one suggestion that your main focus is on your slide. Please look in the audience also and try to talk with the audience.
Sure, sir.
Other issue, if it is better if you can include the pharmacodynamic and pharmacokinetics of the drugs, common drugs that are we using in emergency for especially transgender people. Is there any changes of dose and other things? That also need to be.
Yeah, when we ask them, most of them saying they used to take medicine from the pharmacy. They used to say the complaint, they don't visit ED at all most of the time unless it's very dire emergency, like any bleeding. When they met with trauma, they used to come to emergency. Most of the time, normal abdominal pain or a headache or fever, they try to take medicine from the over-the-counter medication. They don't visit doctors at all because they don't know how to tell their complaints. That's the basic thing.
That was a very good and an original content that you took up for presentation. Just keep in mind that, when there is a competition, time management is one of the criteria.
Okay, sir.
So therefore, whatever you had to say, you need to make sure that you include it within your presentation.
Fine,
because you did have the time if you had managed a little bit. But what happened was, beyond that, you went on to speak for another 2 minutes, which unfortunately is not good.
Okay, sir.
Okay, in a competition I'm talking about in general. I mean, your performance on the whole was very good, except that you had no eye contact and too much material with the slides.
Okay.
You know it all because you've had the exposure, so therefore it should not be a problem. You know your patients, you know what you're going to talk. So reduce the language on the slides and let the language come from you.
Okay, sir. Taken, sir. This is my first talk here.
No, that's good.
Thank you, sir.
You've done well.
Thank you, sir.
Okay.
We call upon our next speaker, Dr. Raja Kantham.
Good afternoon. Myself, Raj Kantham, working as a senior resident from SRM Medical College. So today we are going to see on what is the role of thrombolysis in cardiac arrest. So in this topic, we are going to see about the introduction, what is the role, about some evidences, and what is the clue to diagnosis, and some case report and summarizing it. So as we all know, so there are multiple reversible causes for cardiac arrest. So as we know, there is a 5H and 5Ts. So that is hypovolemia, hypoxia, hyperkalemia, hypokalemia and hydrogen excess and hypothermia. The T's includes the tension pneumothorax, cardiac tamponade, thrombosis and pulmonary embolism and toxins. Among these, it was found that 70% of patients, the most common cause being is acute myocardial infarction and pulmonary embolism. So, what is the clue to diagnose? When in ER, when we receive a patient with ongoing cardiac arrest, it's being challenging for us to find the exact cause for cardiac arrest. So, mainly we will be all focusing on resuscitation part only. But simultaneously, we have to evaluate what could be the probable cause for the ongoing arrest. So what I faced is diagnosing the pulmonary embolism is being a major challenge. So these are the few points which included supporting for the pulmonary embolism. So depending upon the clinical history. So whether the patient is bedridden or a patient had any recent surgical history and then any hypercoagulable state, and patient is taking any drug history, we have to ask for the drug history. On physical examination, like we have to see for the unilateral or bilateral limb swelling. So the other thing also like ECG findings. So ECG findings like it's not, it includes like S wave in the lead 1 and Q and T3, T wave in the lead 3. The other point is point of care ultrasound, which demonstrate for, we have to see for the lower limb vein for any occlusions and right heart thrombi, and then increased pulmonary artery or ventricular pressures, and right ventricular going for dilatation, tricuspid regurgitation and interventricular septal deviation. So this is the echo finding. In this we can see in the first image you can see that the right free ventricle going for akinesia, which is sparing the apex, which is known as an meconal sign. The second image echo finding shows the D-shaped septum. Apart from this, there is a many severity score. If you suspect, with the help of the history, if you are suspecting a DVT, we can go for checking the probability with the help of an well scoring. The other scoring is simplified pulmonary embolism severity index, which included the age, history of any cancer history, any cardiopulmonary problem, along with systolic BP, which is less than 90, the heart rate which is more than 110, and then the saturation which is less than 90%. So among all these findings, and if the scoring is more than +1, this indicates there is a high risk for pulmonary embolism. With all these features, we can able to just have a clue for the pulmonary embolism as an event. So if you are suspected with a pulmonary embolism, what could be the treatment? So this is mainly used in case of a cardiac arrest, the two drugs which were given as tenecteplase and alteplase. Tenecteplase is a single IV bolus dose which was given according to the weight based. So meanwhile, when you are continuing CPR along with all the supportive findings, if you are suspecting towards the pulmonary embolism, we can go with these drugs. That is with the help of the weight of the estimated body weight, less than 60 kg you can give up to 30 mg of tenecteplase, 60 to 70 is 35 mg of tenecteplase, 70 to 80 mg, 80 kg, 40 mg of tenecteplase, and then 80 to 90 kg, 45 mg to the max of 50 mg of tenecteplase can be given. In case of an alteplase, the dose is 50 mg IV bolus, which is given for about 1 to 2 minutes, and we have to continue the CPR. If we are not able to see any improvement, again the second bolus can be given. Before that, we saw about what are the supportive clue findings along with the drugs. But really, does it plays a role in clinical settings? So we are going to see into many research topics, what does it mean and what is the usage of this drug and what are the outcomes. So I have taken a few research topics which they spoke on the survival rate, neurological outcomes, what and all investigation they have done, and along with the bleeding manifestations. Let's see into evidences. That is in the first study, that is the Pippert study, which is pulseless electrical activity in a pulmonary embolism patient who was treated with thrombolysis. In this, what happens, prospectively they compare the case. The patient who had a cardiac arrest, the investigations were made with an echo and along with an D-dimer values. They calculated the onset of the cardiac arrest and the time between the administration of an alteplase. The administration time was about 6.5 minutes, and they also prospectively followed the patient and they measured about the 3 months of a survival rate, which was about 87%. In this study, they have said that if there is a rapid administration of an alteplase with the confirmed diagnosis of pulmonary embolism, there is some improvement in the outcome and survival rate of the patient. In TROICA trial, that is thrombolysis during resuscitation for out of hospital cardiac arrest. This what happened, the patient who has experienced the out of hospital cardiac arrest, they selected the patient and they started immediately on thrombolizing, giving a thrombolizing agent. So those patients who have revived those who have attained ROS, they were followed up. But they were not able to find any differences between the case and with the placebo trial. They compared the 30-day survival rate, which was about 14% with the case, and then the secondly, there was in the ROS, there was not much difference in the study. So Javelin study, in the study what happens is they compared between the out of hospital cardiac arrest. This, as said previously, the same thing was taken in the study also. Out of hospital cardiac arrest patient was chosen, and then the thrombolytic agent was given. In this, the 30-day survival rate was survived in this, and after that the patient was followed up whether they had any pulmonary embolism or not. Those who had a pulmonary embolism was compared with the placebo. That is, the placebo include only the heparin, and then the study group involved tenecteplase along with heparin was given. So in this, there was 16% of improvement present in the case, and in placebo only 6%. But the neurological outcome was same in the study. So about the investigation, the right heart strain pattern in cardiac arrest. So in this, the two study was compared. In one study, they saw the right ventricular strain pattern with the help of an ECG. So they saw the RVS pattern via the ECG and progressive RV depolarization delay in V1. And they followed up these patients whether they had a pulmonary embolism or not. So it included that most of the patient had a pulmonary embolism findings. In the other thing, they found the right ventricular strain pattern. So in this, like around 200 patients were taken, in which the right ventricular strain pattern was present in most of the pulmonary embolism cases. So we saw about what are the finding the clues and what are these studies are telling about the thrombolysis. So does thrombolysis really cure the full reverses the patient condition? So let's see the advantage. So mainly, if you thrombolyze, doesn't mean that it fully resolves the clot. It just improves the perfusion, and it decreases the recurrence, and they have seen that the decrease in death and hemodynamic stability have been improved in PITTO trial. That is pulmonary embolism with intermediate risk of an thrombolysis. So, and they also see that improved functional outcome was unproven in case of a top cohort trial. So what are the disadvantages? So we saw like many studies. In that studies, the other additional points was bleeding manifestation. They also saw the intracerebral hemorrhage, and improvement was overall the same in many of the study, and the main point is being an increase in cost. So this cost value is being challenging in ER, because when the patient is going in a cardiac arrest and we can't able to convince the patient, already they are devastated and in a breaking situation. That time when we suspect and we ask them to buy a injection cost of 40,000, I guess. So they are really devastated and they are asking for the assurance, but we are in a difficult situation to provide some assurance in that situation. So, and then according to AHA guidelines, like they said, like more than CPR that is continuing more than 10 minutes being a relative contraindication. But I went through one case report with in this 48 years old female who went in surgery, went for a sudden cardiac arrest. So with all the blood, CPR was continued, and with all the blood investigation, they found that pulmonary embolism being a cause. So what they did, even after 90 minutes of aggressive CPR, they injected an alteplase of 50 mg IV stat. So the patient immediately had a hemodynamic improvement and good neurological output. So I like to summarize that it doesn't completely clear the clot, it just reduces the size of the clot and improves the reperfusion. Still we need more evidences to carry out this in our ER. These are my references. Thank you. Any questions?
Yeah, good afternoon, doctor. So, just wanted to ask about the various trials you put up where they out of hospital cardiac arrest thrombolysis. How did they diagnose P in those patients if it's out of hospital?
They did not diagnose her. So randomly what they did is, they just compared the patient. Those who are out of hospital cardiac arrest, right, they randomly just gave the drugs alone. So and then they compared the outcome, how is the ROSC and about the neurological outcome. But I think it's practically impossible to do it. But in few of the study, they just compared the out of hospital, and after the receiving a ROSC, they compared with the evidence of pulmonary embolism was done.
So, if I'm understanding this right, a patient was brought in pulseless to the ED, and they just gave the thrombolytic agent along with CPR without confirming diagnosis.
Yeah, without confirming the diagnosis.
And did they specify?
And after that, if the patient attained a ROSC, they just after that they were doing whether the patient had an pulmonary embolism or not.
Oh, so retrospectively they diagnosed it. Right. Did they specify which thrombolytic agent they used? Because we went to tenecteplase, alteplase. Did they specify which one they gave?
Mainly they used in most of the study they mainly used alteplase.
Alteplase.
Yeah.
As a single bolus.
Yeah, single bolus 50 mg.
Okay. Just wanted to confirm that. Thanks.
Thank you.
Just what is your topic?
Thrombolysis in cardiac arrest, sir.
So you have discussed only pulmonary thromboembolism.
Yes, because as compared acute myocardial infarction versus pulmonary embolism. Acute myocardial infarction with the help of an ECG also we can help to diagnose and we can take over the thrombolysis. But in case of pulmonary embolism, it's like a double thinking. How we have to do, I don't think so, because till now in the clinical practice I never saw thrombolizing a patient during a CPATLI. Only 2 cases I have seen in my setup. Okay. So I found this is being a major challenge for all the emergency physicians, that too mainly during the breaking situation, we can't go and tell the patient even after finding a cause being a challenging thing, and if we also find the cause we have to convince the patient attenders. And
that is good thing, but we have to respect the medico-legal aspect of these things also. So should highlight the contraindication at least one slide, because you are doing blind thrombolysis without confirming a diagnosis. And if there is a gross contraindication that you have missed and you have thrombolysis, then it can be sometime medico-legal problem. So that should be highlighted also.
Yeah, sure, sir.
Rajkantam, I can see that you're full of knowledge. In fact, it'll be nice for you to come and work in my department. I need people like you.
Yeah, surely, sir.
But what I'm trying to tell you is, see, you have so much of information, but your topic which you have chosen is too broad. When you are presenting for 10 minutes, if I were in your position, what I would do is, my lecture would be on contemporary evidence-based literature on thrombolysis in pulmonary embolism. Did you understand?
Yes, sir.
So then what happens is you become focused. You're not going to talk about anything else. Now what happened was you started off with, everything to put into perspective, trying to squeeze everything in. So that makes it very difficult. So this is generally for all of you young people. When you're choosing topics, especially when there is a time constraint, try to be very precise, and your title should say it all. That way you don't have to have this introduction, etc., etc. You can dive in straight into your topic, go into the details that you wish to part with, so that you are imparting the knowledge which you have accrued specifically for a focused particular subject. So that's what you need to choose. The second thing is what I wanted to tell you is that when you are putting up so much of literature and so many studies, you should put up the reference then and there. Not at the end saying, these are my references, Chuck, thank you. So I only saw that, the slide was full. I didn't even see how many slides. What I would like to see is when you say you are discussing a particular trial, you should put the reference there. Why do I want to see it? For 2 reasons. One, I want to see whether it's a contemporary study or whether was it done in 2004. Second, if I can remember it, I will go back and go and read about it. So therefore, when you're putting up the study, which you're discussing, you discuss so well and you're so knowledgeable, you need to put it up right there so that, there are a lot of people who take photographs immediately. If I want to do a study, now what I will do is I'll take my phone, take a picture. So I'm just giving you some tips because you're all starting out now. It's not only for you, it's for the benefit of everybody else. Okay? Well
Surely,
done.
sir, for next time. Thank you, sir.
So thank you, sir. We end the session of the judges. We'll have a switchover of the judges here. So I call upon our next judge, Dr. No, ma'am will sit there, sir. So please sit, sir. They'll sit down.
We're going to discuss outside.
Okay. Dr. Shakuntala, ma'am, and Dr. Atul will be the judge for the next 5 sessions. Sorry, Dr. Taha Hussain. I'm starting from here. Soumya, this person is done. From Soumya. So we have our next speaker, Dr. Soumya Datta.
Good morning, everyone. Myself, Dr. Soumya Subra Datta, Senior Resident, PDCC Toxicology Fellow at Department of Emergency Medicine in Ames, Rishikesh. And my topic of presentation is cardiac arrest in poisoned patients. So cardiac arrest in a poisoned patient with presenting to ED may be due to the direct effect of the toxin, metabolic abnormalities caused by the toxin effect, and the associated injuries caused due to road traffic accident or fall, sustaining injuries, that is after the intoxication. The standard resuscitation maneuvers of BLS, SCLS, and also the ATLS should be initiated as early as possible because not only the toxin but the trauma may also cause the death of such patients. High quality CPR is the most important intervention, and prolonged CPR should be considered in toxicological patients. Specific antidotes may be considered if it is a known toxin or drug during CPR, but it shouldn't delay the components of the CPR. So these are the list of common agents causing cardiac arrest. Out of these, in my day-to-day practice in ED, I get to come across tricyclic antidepressants, then calcium channel blockers and beta blockers, drugs of abuse like opioids and cocaine, cardiac glycoside like digoxin, and pesticides, organophosphate, and snake bites. These are a list from Tintinelli showing the potential intervention antidotes that can be used in patients with cardiac arrest. Digoxin fragmented antibodies for digoxin toxicity, atropine for organophosphate, anti-snake venom for snake bites, sodium bicarbonate for sodium channel blocker or white complex tachycardias, high-dose insulin for calcium channel and beta blockers. For local anesthetic agent and lipophilic cardiotoxin, we can go for IV lipid emulsion, and extracorporeal maneuvers like cardiac pacing, intra-aortic balloon pump, and ECMO can also be used. So starting with opioid overdoses result in cardiopulmonary arrest due to decreased respiration and lack of airway patency. The mainstay of care is to support the airway and breathing and recognizing the offending agent so that we can use the antidote for naloxone. During cardiac arrest, providing the high quality CPR is of primary focus, and naloxone can be administered along with standard ACLS care, but it should not delay the CPR. This is the AHA guideline for healthcare providers in case of suspected opioid poisoning cardiac arrest. So in this, they also emphasize that first thing is to do is check for pulse and then activate the emergency medical service or call for help. Standard resuscitative measures should take priority along with the CPR and AED attachment and using AED, and then only consider naloxone whenever it is feasible, but don't delay the CPR. The dose of naloxone, 0.04 milligram for breathing spontaneously and suspected chronic opioid use patient, stat, 0.4 milligram for opioid naive patients, and if the patient is apneic or cyanotic, then 2 milligram IV stat. Repeated doses should be considered every 2 to 3 minutes until the patient recovers and takes spontaneous respiration, or a maximum of 10 milligram dose has been given. In case of sodium channel blocker toxicity, this TCA, cocaine, flecainide, and citalopram, they can cause hypotension, dysrhythmias, and death or by blockade of cardiac sodium channels. The standard therapy, as also recommended by AHA guidelines, consists of serum alkalization by use of sodium bicarbonate boluses. Magnesium sulfate can act as an adjunct to bicarbonate. And there are case reports suggesting that ECMO and IV lipid emulsion can be of use in severe sodium channel blocker toxicity, but there are no controlled human studies available till date. Sodium bicarbonate dose is 1 to 2 milliequivalent per kg IV bolus every 3 to 5 minutes, followed by 150 milliequivalent in 1 liter of dextrose water infusion at twice the maintenance rate up to a target serum pH of more than 7.55. Lidocaine can also be used for refractory dysarrhythmias. Magnesium sulfate can be used. And ECMO, cardiopulmonary bypass, and IV lipid emulsion should be considered in patient with refractory shock or cardiac arrest. There is no evidence to support hemodialysis or hemoperfusion in such patients. For beta blocker toxicity, the initial therapy is high dose insulin with the patients who are not responding to fluids, atropine. Glucagon can be considered, but there are no human studies available till date. Calcium chloride is used as it improves the BP in severely hemodynamically compromised patients. IV lipid emulsion can be used for lipid-soluble beta blockers if ECMO is not readily available in situation of circulatory collapse or cardiac arrest. ECMO should be considered, or IBP should be used whenever available in patients with cardiac arrest. And hemodialysis is not routinely recommended as these beta blockers have high volume of distribution. So hemodialysis will not be effective in these patients. For calcium channel blocker toxicity, also similarly in the lines of beta blocker toxicity, atropine catecholamines, calcium chloride, glucagon, high dose insulin therapy, IV lipid emulsion, and ECMO can be considered. MARS, or membrane absorbent recirculating system, is experimental in this toxicity, which uses high albumin containing dialysate to remove the protein bound toxins from the circulation. A 2017 expert consensus statement recommended that calcium should be used as a first-line treatment for catecholamine refractory shock for calcium channel blocker toxicity, but there is very low certainty of evidence in such patients. It also supports the use of ECMO for refractory shock patient as this drugs for a reversible cause of drug toxicity. Then cocaine toxicity. Cocaine toxicity, cardiovascular adverse effects due to cocaine toxicity may result in dysarrhythmia, hypertension, tachycardia, and coronary artery vasospasm and cardiac contraction delayed. May precipitate acute coronary syndrome and stroke also. In cardiac arrest, there are no evidences to suggest deviation from standard BLS or ACLS care. Specific treatment strategies can be used once the patient ROSC has been achieved, and nearby poison control center or toxicologist should be consulted for specific therapy. The treatment modalities for cocaine-induced hypertension, tachycardia, agitation, or chest discomfort includes benzodiazepines, alpha blockers, calcium channel blockers, and nitroglycerin and morphine. Few systemic reviews suggested that beta-adrenergic blocker use may not be harmful, but propranolol reduces coronary artery blood flow in patient with cocaine exposure, so better we avoid beta blockers. Now, local anesthetic systemic toxicity, patient may present with neurotoxicity or fulminant cardiovascular collapse due to profound inhibition of voltage-gated sodium channels in cell membrane. The most common offending agents are bupivacaine, lignocaine, and ropivacaine. And case reports and systemic reviews have suggested that IV lipid emulsion may be of benefit. But there are still no published RCT studies to compare IV lipid emulsion with standard resuscitative care. Digoxin toxicity. Digoxin toxicity can cause severe bradycardia, AV nodal blockade, life-threatening ventricular arrhythmias. Poisoning from other cardiac glycoside like oleander, foxglove, digitoxin has also similar effects. Prompt treatment with the digoxin-specific antibody fragments should be initiated along with CPR to prevent this cardiac arrest or to control the life-threatening arrhythmias. Atropine can be used as a temporizing measure until the digoxin-specific antibody fragments are available, and prolonged CPR is appropriate for these patients if needed. For digoxin-specific antibody, if we don't know the amount ingested or the serum concentration is not known, then 10 vials IV can be given as a stat medication. Cyanide toxicity. Cyanide poisoning may result from smoke inhalation, industrial exposures, self-poisoning, terrorism, or administration of sodium nitroprusside. The toxicity of cyanide is predominantly due to the blockage of the cellular respiration and ATP production. The symptoms typically occur within minutes. Arrhythmias, apnea, hypotension, bradycardia, seizures, and cardiovascular collapse may be the presenting symptoms. Lactic acidosis is a very sensitive and specific finding in case of cyanide toxicity, and immediate antidotes should be hydroxycobalamin and nitrate should be considered along with 100% oxygen therapy for these patients. Sodium thiosulfate also can be used as it enhances the effectiveness of nitrate by detoxifying the cyanide from the system. Carbon monoxide poisoning. Carbon monoxide poisoning, actually carbon monoxide reduces the ability of hemoglobin to deliver oxygen to the tissues and causes direct cellular damage to the brain and myocardium. The cardiac arrest in carbon monoxide poisoning is almost always fatal, and less severe carbon monoxide poisonings usually result in neurological sequelae. Hyperbaric oxygen therapy in such patients may be helpful. In case of cardiac arrest, we find electrolyte abnormalities in patients of toxicology very commonly. So for hyperkalemia, IV calcium can be used. It also can be used for hypermagnesemia. For hypomagnesemia, IV magnesium is recommended. And for hypokalemic cardiac arrest, the potassium bolus is not recommended as it causes more harm. And the routine use of calcium, sodium bicarbonate or magnesium in case of cardiac arrest without any specific indication is of no benefit as stated by AHA guidelines. And for snake envenomations rarely come in cardiac arrest, they usually present earlier. But if the patient is in cardiac arrest, standard CPR should be applied, ACLS guidelines should be followed. Anti-snake venom along with anti-snake venom hemodynamic support. For coagulopathy patient bleeding we can use FFPs and blood products. Forced alkaline diuresis and hemodialysis can be considered for patient with AKI or pigmented nephropathy in these patients. And for neurotoxic snake bite, mechanical ventilation and atropine neostigmine should be considered. And specifically for crate bite, if it is not responding to atropine and neostigmine, IV calcium should be considered. Thank you.
Any questions? So we'll move on to the next speaker.
Thank you.
Any questions? No. So we'll move on to the next speaker, Dr. Satish.
Good morning to all. I am Dr. S. Satish. I am a consultant emergency physician from Royal Care Super Specialty Hospital. Today I am going to talk about acute limb ischemia. Acute limb ischemia, there is a sudden decrease in the limb perfusion that threatens the limb empty. It needs timely recognition and rapid revascularization methods so that it can be preserved. The most common etiology is the thrombosis. It can occur in both native vessels and in case of bypass grafts. It is mostly occur in the lower limbs and which is insidious in onset. Commonly it occurs in the atherosclerotic vessels in low flow states like congestive cardiac failure, septic shock, etc. and plaque rupture and vascular grafts. If occurs in a normal vessel, we have to evaluate for the hypercoagulable states. The second most common cause is embolism. It also mostly common in the lower limb, that is preferably in the common fibrillar artery. In case of upper limb, it is brachial artery. The most common sources are cardiac sources like atrial fibrillation, post myocardial infarction, mural thrombus, and prosthetic heart valves and vegetation from the wall leaflets. In case of non-cardiac source, aneurysm and atheromatous plaques are the sources. The next causes are trauma. It can be either directly injury to the artery or indirectly through compartment syndrome, and other causes like vasculitis, prolonged vasopressor use, dissection, and iatrogenic. The most common risk factors are smoking and hyperlipidemia, hypertension, diabetes, and hypercoagulability. Coming to pathophysiology, due to the abrupt loss of the blood supply, the tissue hypoperfusion occurs. If it is prolonged, it leads to irreversible damage and cell death. If we timely intervene, the reperfusion occurs. Even reperfusion may cause injury like compartment syndrome, rhabdomyolysis, and metabolic derangements like increased potassium and failure of the calcium channels. The tissue sensitive to ischemia, because the nerves are sensitive, like within 4 to 6 hours, it goes for irreversible damage. In case of muscle, 6 to 8 hours, and for skin, it is around 10 to 12 hours. There are 6 red flag signs like pain, pallor, and pulsinousness. Pain, pallor, and pulsinousness may be absent in complete acute ischemia, but can be present in chronic ischemia. In case of perishing cold, it is an unreliable sign because the ischemic limb takes the ambient temperature. Coming to paresthesia and paralysis, these are the most important findings because it takes significant time because if it is present, it is going for irreversible ischemia. Coming to clinical evaluation, in cases of suspected acute limb ischemia, we have to evaluate the signs, symptoms, motor and sensory assessment, and arterial and venous Doppler signals. Coming with arterial and venous Doppler signals, we have categories into 4 categories according to Rutherford. If both arterial and venous signals are present, it is considered as category 1. It is a viable limb. It has normal motor function and no sensory loss. In case of inaudible arterial and audible venous signals, we have to go for motor assessment test. With slow to intact capillary referral and no limited sensory loss, it is considered as category 2A. It is marginally threatened. If it is decreased capillary refill and the motor and sensory loss is moderately present, it is considered as immediately threatened. In case of inaudible arterial and inaudible venous signals, it is considered as irreversible. There is complete loss of motor and sensory function is present. These are the laboratory investigations used to routinely take, especially like ECG to rule out any AFR for thrombosis and ABG with lactate levels. And in case of muscle lysis, creatine phosphokinase are elevated. And we also use it to assess for the hypercoagulability state like protein C, protein S, etc. Coming to imaging, duplex ultrasound. By ultrasound, you have to use the color and pulse wave Doppler signals. Because it is low cost, non-invasive, non-irradiant, we can easily available, and it is used for accurate diagnosis of the infrainguinal diseases. But in case of disadvantages like suprainguinal arterial occlusions are not clearly visible, and with artifacts are present in case of arterial wall calcifications. This is an image showing absent common femoral artery Doppler signal. Coming to CT angiography, it has a high sensitivity and specificity like 96 to 98%. It is a non-invasive procedure, but it gives an accurate analysis of the location and extent of the obstruction. It also visualizes calcifications and bypasses, etc. But the main disadvantages are ionizing radiation and ionated contents because it worsens the renal failure and it is contraindicated in case of GFR less than 60 ml per minute. This is an CT image showing right external iliac artery thrombosis. Coming to MR angiography, it also has the high sensitivity and specificity like 93 to 100%. The main advantage is non-irradiation and also can be used in case of moderate renal failure. But the main disadvantage is it is high cost and time consuming. It is contraindicated in case of severe renal failure because it may cause nephrogenic systemic fibrosis and in cases with the in situ pacemaker and metal implants, and category 2B. This is an MR angiography image. Showing the first image shows both lower limb angiography. The second one depicts the complete occlusion of the left anterior tibial artery. Invasive angiogram, it is gold standard invasive procedure because it is both. It has an advantage like it is both diagnostic and therapeutic. You can timely intervene in the case. The disadvantages are invasive and expensive, and a lack of incidence of contrast nephrotoxicity is there. This is an invasive angiogram image showing the thrombus present in the right common iliac artery. Management, the main target is the rapid restoration of the arterial flow with least risk to the patient. In any case, in suspecting acute limb ischemia, we can give unfractionated heparin with a dosage of 80 units per kg bolus followed by 18 units per kg per hour infusion, and we have to maintain the APTT ratio of 2 to 3. These are the revascularization techniques like endovascular techniques and surgical methods are there. In case of endovascularization techniques, catheter-directed thrombolysis, percutaneous thromboaspiration and mechanical thrombectomy is there. In case of surgical methods, balloon catheter thrombectomy and bypass surgery is present. This is according to Rutherford classification. We can after the categorizing the image, this is an approach for the acute limb ischemia patient. In case of category 1, we have to do the first imaging studies, and depending upon the level of lesions, we can either decide upon whether anticoagulants is enough or revascularization is needed. In case of category 2A, marginally threatened, first we do angiography to determine the appropriate treatment like catheter-directed thrombolysis, thrombectomy or thromboaspiration. In case of severe injury, we can directly go for emergency embolectomy. In case of treatment failure with initial endovascular procedures, we can directly go for emergency embolectomy. In category 2B, it is immediately threatened limb. Directly we have to do the surgical treatment like emergency embolectomy. After these procedures, finally we have to do again angiography and to decide upon the successful removal of thrombosis done or not. If it is a failure, we have to go for a surgical bypass. If it is successful, we have to identify the peripheral artery disease lesions if there is any. If there is no, we can directly give anticoagulants. If it is any lesions are present, we have to assess for either localized or diffuse. Depending upon that, we can go for either again endovascular treatment or surgical bypass. This is catheter-directed thrombolysis. It is a less invasive minimal procedure, especially benefited in case of graft thrombosis. The main disadvantage is bleeding, and it takes longer time to reperfusion, like 24 to 48 hours. But it is also contraindicated in case of category 2B and graft infection, and contraindications for thrombolysis. These are the thrombolytic agents with doses and regimen used in case of acute limb ischemia. This is an image, first image showing a thrombotic occlusion of the right external iliac artery. After the infusion for 48 hours, due to thrombolyzed clot, we can see the flow of the blood. Percutaneous thromboaspiration, it is a low-cost rapid technique. It has a success rate of around 30%, but when combined with thrombolysis, it is increased to 90%. It is effective, especially in case of iatrogenic distal embolization. This percutaneous mechanical thrombectomy is recently used nowadays. It has a shorter time to reperfusion, especially benefited in cases who are unfit for catheter-directed thrombolysis and surgery. Is used as an adjunct in case of incomplete thrombolysis, but main disadvantages are vessel perforation and dissection. Balloon catheter thrombectomy, the main advantages is rapid revascularization, especially preferred in cases of category 2B, but the risk of vessel injury and chances of reperfusion injury may occur. Angioplasty and stenting, in cases of chronic severe thrombotic vessels, after the initial procedures, it needs dilatation and stenting because it prolongs the patency and prevents the recurrence of the thrombosis. At last resort, we have to go for bypass surgery because any person who has diffuse peripheral vascular disease, we need to do bypass only. And also, in case of any failed intravascular recanalization procedures, bypass surgery can be done. Hybrid methods, in hybrid methods, thromboembolectomy with both endovascular and surgical methods are done in combination to reduce the revascularization time. Thank you.
Any questions?
It's not a question, just a comment actually. You have a lot of material,
yes.
So you could have cut it short a little bit and focused more on the important aspects on each slide, okay, rather than trying to go through everything.
Okay.
Hi Satish, thank you for your presentation.
Thank you, sir. Thanks.
I just wanted you to give me a take-home message as to why you chose this topic and what are the take-home points from an emergency physician's perspective, not going into the details of the management as a vascular surgeon, okay, but what do you want to do in ED? And the second thing is, do you have any protocol in place in your department as once these patients have been diagnosed with an ALI, how do you then transfer and what is the time frame?
According to the time of presentation, we will assess the duration of injury and with the ABG and according to the severity, we will assess for the rapid creatinine levels. With that, we have to either directly go for CT angiography or if it is in a direct emergency and the limb is threatening, we will directly go for a mechanical thrombectomy in our institute.
Any more questions? Thank you.
Thank you.
Okay. The previous speaker, Dr. Soumya, are you here? Okay. No, they had a few questions to be answered. At the end of this session, we'll take it, yeah. So we move on to the next presenter, Dr. Santosh. He's not given, okay. Dr. Mario.
A very warm welcome to one and all respected judges, senior faculty members, and my dear colleagues. I'm Dr. Mario Anthony from Krishna Institute of Medical Sciences, senior resident in Department of Emergency Medicine. Today's topic of discussion will be transmission disasters. We'll approach this topic based on scenarios, focusing on the clinical approach, management, prevention, and an emphasis on the hemovigilance program in India. Coming to introduction, transfusion reaction is any transfusion-related adverse event that occurs during or after transfusion of whole blood or blood components. They can range from benign to even life-threatening reactions, of which some can be prevented, whereas others cannot be. Now, let me draw your attention to an emergency medicine department where, as you all know, it is crowded, chaotic, and we have a young male presenting to our department. The senior consultant sees this patient and orders his resident to give a blood transfusion, along with another list of procedures and investigation to be sent. The resident who is worked up sees the patient, draws the blood, being very chaotic, goes to the nursing station, fills the forms, and starts the transfusion to our young patient. In a few hours, in 1 hour, the patient is now looking febrile. His temperature is 103 with your vitals being hypertensive. Now, what do you do next? The first thing, stop panicking. Next, stop the blood transfusion. That's the first, most important thing to be done. Call for help, go to see the airway, breathing, circulation, and if required resuscitation, perform your protocols. After resuscitation, if the patient has an IV, or if not, ensure that there is a patent IV in the patient and go ahead for the clinical examination. Along with that, check the blood component for evidence of contamination, discoloration. If platelets were transfused, make sure there are no bubbles in the platelet unit. Also ensure that the labels are correct, which was transfused, comparing with the patient's identification. And the very important step is calling the transfusion services at the blood bank on to what happened, why this happened, and when did this happen. Now, seeing the scenario, we'll come to a differential diagnosis of acute hemolytic transfusion reaction versus sepsis. Now, sepsis is beyond the scope of discussion, so I will focus more on the acute hemolytic transfusion reaction. This occurs during the transfusion or even up to 24 hours after the transfusion. It is a true medical emergency with an incidence in 1 in 38,000 to 1 in 70,000 with a very high mortality of 1 in 30. It is usually due to an EBO incompatibility, which can even lead to DIC, shock, acute renal failure, and even death. Coming to the symptoms, there's a classic triad of high-grade fever, flank pain, hematuria, and the patient is usually sick with the patient in shock. So a workup must be done to rule out the possibility of hemolytic transfusion reaction in every adverse event, starting from a very small fever to the most life-threatening ones. And the most important thing would be to inform and report it to the hemovigilance program of India, which I'll be talking about in a few minutes. The workup should be consisting of filling the reaction forms, sending the sample to the blood bank, laboratory testing, and to confirm hemolysis. So, filling of the reaction form should contain the vitals before the transfusion, the time of initiation, the time of completion, the time when the reaction was noticed, and the details of the symptoms and signs that was noticed. The samples being whatever remnant blood was remaining should be sent along with the IV fluids, bags, tubings for the possibility of blood culture and the gram staining to ensure that there is no sepsis and other tests. The samples that should be sent includes an EDTA sample for your blood group cross-matching, for your direct Coombs and your indirect Coombs test. Along with that, a CBC, a peripheral blood smear, LFT, RFT, your serum LDH, haptoglobin, all are sent for checking for hemolysis, urine routine microscopy for hemoglobinuria, and chest X-rays for chest infiltrates for other conditions, along with ECG and ABGs. The test to confirm hemolysis would be a direct Coombs test, in which you can see a pink plasma as shown. The treatment is supportive. Start checking the ABCs as mentioned earlier, starting with normal saline to increase the diuresis. Hyperkalemia, if present, should be treated. And coming to the precautions per se, what we saw in the clinical scenario earlier was a clerical error. There was no proper identification of patient. The samples were collected at the bedside but written in the nursing station as mentioned. So currently labeling the samples at the bedside is very important. Proper identification of the recipient of the blood pack, the observation of the patient during transfusion up to 24 hours, as acute hemolytic transfusion reaction can occur up to 24 hours as mentioned. And always be judicious and avoid unnecessary blood transfusions. The requisition form should contain 2 patient identifiers, ward number, diagnosis, sample collection time, date and personnel, the time of requirement, whether it is urgent or routine, the requirement of which blood component required in separate form should be ensured, the sign and the seal of the medical officer or the doctor. The particulars present in the demand form should be ensure that it matches the vacuum cleaner which we are sending, so that we don't land up in a wrong blood in tube, that is WBIT. So these are some samples which we should not send to a lab, that is hemolyzed sample, a lipemic sample, or a micropore covering the blood tubes. At the bedside, we should make sure that the labels are verified and signed by the medical and the nursing officer, and the blood product which is received should also be confirmed. Next, we'll have a scenario 2 where a young male, now coming again for a blood transfusion, is now appearing breathless. So differential diagnosis here would be a severe anaphylactic reaction versus the TRALI, that is transfusion-related acute lung injury, versus TACO, that is transfusion-associated circulatory overload. Anaphylactic reaction I have not been covering in this topic, but TRALI is a reaction that occurs up to 6 hours or during the transfusion. Incidence is 1 in 5,000 to 1 in 1,50,000, more common in female donors. The pathophysiology involves HLA antibodies, which react with the antigen on the recipient's granulocytes, and this initiates an inflammatory response in the pulmonary vasculature of the patient. The clinical features are non-cardiogenic pulmonary edema with tachypnea, tachycardia, hypertension, pink frothy sputum, and fever. The treatment is, again, stop transfusion, check the ABCs, supportive management, and what we have to stress here is there is no role for Lasix or furosemide. In TACO, that is transfusion-associated circulatory overload, this occurs during or even a few hours after the transfusion. Incidence is variable, but more seen in patients with circulatory overload, that is in congestive heart failure, CKD patients, and symptoms are very similar to TRALI, wherein you have symptoms of overload, that is raised JVP, raised BP, raised BNPs. The treatment here again is stop transfusion, ABCs, supportive management, and Lasix. A word on the Hemovigilance Program of India. It is for the safety and quality of transfusion, for the global forum for best practices and benchmarks on hemovigilance in India, and to give evidence-based recommendations in Indian healthcare system. Still, we have to depend on the US and UK systems as of now. So take-home message: the blood transfusion always carries potential risk of recipient, should be prescribed judiciously with all precautions, understanding type of reaction, rapid management to save the patient's life, timely reporting of the transfusion reaction to the blood bank and transfusion services, and as of the Hemovigilance Program of India is most important that all are reported, so we have our own recommendations and guidelines of practice. These are my references, and this should not prevent us from getting scared on blood transfusion or blood donation, so we always must promote blood donation and save lives. Thank you very much.
Any questions?
Well, thank you, Mario, for your presentation. I mean, it included most of the characters which I like from Big Bang Theory. So the quality of your slides and your time management was absolutely bang on. I think that really brought the attention of the audience and us as the judges to kind of look into what the topic was. Just a few questions is, why did you choose this topic, number one? And how many probably transfusion reactions, be it TRALI, TACO, or acute febrile illness post-transfusion, have you come across? And what is probably your compliance in this whole protocol in your department?
Thank you for the question, sir. Actually, this topic was one of the topics which I was asked to present, and this was an area which I also didn't have much exposure towards previously. I've only seen one case of Charlie during my residency, and not in my 1 year of senior residency as of now. Yes, we have started with our blood bank to inform even the smallest reaction, which is even fever, which, as I mentioned, could be acute hemolytic transfusion reaction as well. So it might be, which I did not mention actually, was because it was not a disaster per se, was a febrile non-hemolytic transfusion reaction, but it can vary from that benign to a very severe transfusion reaction. So we have to be very careful in that even the smallest sign and symptom is picked up, and that the patient is monitored from the transfusion up to 24 hours. Otherwise, we might even lose the patient if the patient is shifted to a ward or an ICU without proper monitoring.
Very well presentation, Congress. We have two scenarios. One, we are giving blood in ED, and second scenario, patient has given BT outside our hospital and some problem has occurred and then they were sent to our hospital. Have you encountered such patient during your residency or senior residency? Patient were given blood outside and then sent to our hospital.
Yes, ma'am, that is one.
Then how we will react with that blood reaction?
Thank you for the question, ma'am. Ma'am, as of now, I've not encountered such a problem in my residency or the practice I've been doing. But yes, that is a very significant problem that we can face. So what I feel we have to improve on the handover from the EMT, whoever is coming from the other hospital, or the doctor or the nurse who is coming and transporting the patient, onto complying. We should make sure that the blood which has been given outside, if at all, should be, which the documents have to be produced to us as well. Otherwise, we cannot be following up with what had been done.
Okay.
Because
also, if possible, that blood bag should be brought to our hospital. So again, we can work further on it.
Yes, ma'am.
Okay. And what are the absolute contraindications to give blood in ED?
Contraindications would be, ma'am, if...
Indication.
Sorry, madam?
Absolute indication. When the patients require blood in ED, really. Whenever patient requires blood in ED, it is more than one. Yes. So at that time, we cannot, which blood bag has encountered the later reactions. So at that time also, we cannot make sure which blood is reacted to our patient.
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Thank you.
Thank you.
We call upon our next speaker, Dr. Jishmi Shah.
Good afternoon, everyone. Myself, Dr. Jishmi, working as an assistant professor in the Department of Anesthesiology at Shri Krishna Hospital, Pramukh Swami Medical College, Anand, Gujarat. And I will be talking on regional analgesia in thoracic and abdominal trauma. For the next. So pain management in trauma patients in ED is usually very challenging because the patient not only presents with that particular injury but also presents with certain life-threatening conditions, and so life-saving measures will take a priority. Pain management usually in ED is in the form of systemic analgesics, and the most common form is systemic opioid. So there are certain barriers which stop us from using those opioids adequately for pain management of these patients. For the ease of remembering, we'll go in the sequence of A, B, C, D, and A. The most common barrier is the fear of airway compromise in trauma patients, fear of addiction, respiratory depression, which might increase the requirement of mechanical ventilation, circulatory compromise, delirium, other side effects of opioids Evaluation, frequent assessments are required in such patients which can be affected. Nausea, vomiting, constipation, immunosuppression might further deteriorate the patient's condition. Increased staff requirement for monitoring such patients and also increased length of stay in such patients. On the other hand, regional analgesia provides us with numerous benefits. Site-specific excellent pain relief which can help in assessment of the patients like x-rays. Side effects of opioids are avoided totally. Requirement of opioids can be reduced. Reduced stress response, reduced generation of systemic inflammatory mediators and thereby incidence of sepsis and multi-organ failure. Safer because of availability of multiple gadgets like USGs and nerve stimulators. Reduced infections, reduced sympathetic activation, improved cardiac pulmonary functions, GI functions, reduced chances of chronic pain and post-traumatic stress disorders, and reduced ED, ICU and hospital stay. Benefit is more evident when initiated in early phase, and that's why it plays a significant role in pre-hospital and ED settings. The question is when to start the pain relief management. As early as possible after initial stabilization, which can be termed as on-arrival block. Regional options for thoracic trauma are many: thoracic epidural, paravertebral, its variants, intercostal nerve block, and serratus anterior blocks. This is the nerve supply of thorax. Thoracic wall is supplied by the spinal nerve, which divides into dorsal rami and ventral ramus, and we block this rami at various locations. For example, in the midline, what we give is thoracic epidural, and we keep on moving laterally, so the blocks are named accordingly. Thoracic epidural is one of the gold standards, time-tested technique, one of the favorite for anesthesiologists, can be used as a bolus or continuous infusions. Benefit is it can be used for bilateral rib fractures. Failure rate is 13%. This is the position required for placing a thoracic epidural, which is sometimes not possible by the trauma victims. This red area is the block area where the pain relief can be achieved. What happens exactly is bilateral spinal nerves are blocked as they emerge from the spinal cord. It is contraindicated when the patient has raised ICP, bleeding diathesis, and patients who cannot report severe pain in order to avoid cord trauma. Hypotension cannot be avoided because of sympathetic blockade. Catheter can veer to one side, making the block unilateral. Urinary retention, pruritus, or other problems. Paravertebral block is also a variant of epidural given slightly lateral to the midline, can be used given with landmark technique or USG guided. Here, the blue mark or blue triangle is the area where we inject the local anesthetic agent. This is called the paravertebral space, which is bounded medially by the vertebral body, anteriorly by the pleura, posteriorly by the transverse process, and superior costotransverse ligament. This is the position required for paravertebral block. This red part is the area which is covered. This is the sonoanatomy of the paravertebral space, and the D portion, the blue in color, is the drug spread. What happens exactly is the local anesthetic, which is given in that space, covers the spinal nerves in the paravertebral space, prevertebral space, epidural and intercostal spaces as well. Effect is unilateral, but better than epidural because less chances to cord trauma, less incidence of hypotension, nausea, pruritus. Drawbacks are required in higher volume and concentration. Chances of pneumothorax are more. For bilateral block, we need to give bilateral injections. Now, because of the technical difficulties of thoracic epidural and paravertebral block, many variants have emerged in recent years. These are called thoracic interfacial plain blocks. They are way simpler, superficial, safer. Principle is local anesthetic agent is injected in the tissue planes between the muscles. Commonly can be used in ED setups. They are found to be effective and non-inferior to the standard methods. Risk of pneumothorax, spinal hematoma, theoretically though less, cannot be completely avoided. What happens here is the superior costotransverse ligament, which forms the posterior border of the paravertebral space, is found to be fenestrated. So whatever drug we inject there, it spreads around and blocks the target nerves indirectly. Problem is more volume of drug is required. Most common and new variant is erector spiny plain block. It is simple, increasingly popular. What happens here is drug is deposited between the erector spiny muscle and the transverse process. Needle placement is lateral to midline. This is the patient position. The drug spread is between the spiny, erectus spiny and transverse process. The yellow part is the blocked area. Blue colored is the spread of the drug, which we can see here. Next is retrolaminar block. It is also a variant of erectus spiny block. The only difference is the needle hits the laminae instead of the transverse process. This is the entry point for lateral laminar block. Next is midpoint transverse process to pleura. This block, in this the end point of the needle is midway, exactly midway between the pleura and the posterior border of transverse process. Problem is increased risk of pneumothorax. This is the entry point for MTP block. Paraspinal intercostal variant similar to other thoracic facial blocks. Here the drug is injected mainly between the erectus spiny muscle and the external oblique muscle. Excellent pain relief similar to paravertebral block. Subrhomboid intercostal variant, here we recommend use of USG always because the risk of pneumothorax is highest. Needle entry is at the medial border of scapulae between T3 to T6. Here the drug is injected beneath the rhomboid muscle. This is the entry point for rhomboid intercostal plain block. Intercostal block most commonly used for rib fractures. They are easy to execute. Problem is shorter duration of action, because of which repeated injections are required, making the patient more uncomfortable, increased risk of pneumothorax and LA toxicity. The drug can be injected anywhere between the mid-thoracic, mid-axillary line and paraspinal muscles. Repeated positioning of the patient also makes the patient uncomfortable. Increased chances of pneumothorax and local anesthetic systemic toxicity. This is the patient position required for intercostal block. This is the intercostal nerve area lying between the two muscle planes, and we usually block it between the mid-axillary line and the paraspinal muscles. Next is serratus anterior plane block. This is preferred for anterolateral rib fractures. Unilateral effect is found. Use of USG is recommended. Here the local anesthetic agents is deposited beneath the serratus anterior and above it. This is the patient position. The green area which we see is the spread of the drug. The blue area is the block area. Now, regional options for abdominal trauma. Again, there are many options available like thoracic epidural, paravertebral, transversus abdominis plane block, rectus sheath block, erectus spiny and quadratus lumborum. This is the anatomical structure of abdominal wall where the various muscles present different interfacial sheaths. Our aim is to inject the local anesthetic in between them. For example, if we give the drug beneath the rectus muscle, it becomes rectus sheath block. Between transversus abdominis and internal oblique muscle becomes tab block. Thoracic epidural, again gold standard, bilateral effect. It can be titrated as per the effect required. Complications, hypotension and motor blockade if used in higher concentration. It is contraindicated in coagulopathy, severe hypovolemia and unresponsive patients. This is the position required, which can be difficult in trauma victims. This is the area of the abdomen which is covered by thoracic epidural block. Paravertebral block, again an excellent unilateral option. Benefits as compared to epidural is less hypotension, safer in bleeding diastasis or unconscious patients. Even it can be titrated. Disadvantages are we have to use 2 catheters if we need a bilateral block. If single injection technique is being used, we need to give multiple injections to cover the desired dermatomes. For example, if we want to cover these 2 dermatomes, we have to give 2 injections. Next is transversus abdominis plane block. Again an excellent block which is being used nowadays more frequently for post-operative pain management, which can be applied in trauma as well. Equipments required are USG, provides mild to moderate pain relief. It is safer and can be used in unconscious patients without worrying about the risk of hypotension. It has various variants like given in the lateral area where it is injected between internal oblique and transversus abdominis, and second is beneath the subxiphoid area where it is injected between rectus abdominis and transversus abdominis muscle. This is the unilateral tab block, and the blue is the area which is covered by this block. In order to cover this entire band, we have to give 2 bilateral injections. Next is rectus sheath block. Again, this is used for periumbilical and midline incisions. Safer, only a small area is covered. We need not worry about hypotension and can be used in unconscious patients. This rectangle area is the band which can be covered using rectus sheath block. Next is quadratus lumborum block. This is also a novel technique which has come up these days. The drug is injected between quadratus lumborum and psoas, which is called QL1, and another is between quadratus lumborum and erector spinae, which is QL2. Here also it is said that local anesthetic spreads indirectly into the thoracic paravertebral space and thereby gives excellent pain relief. To conclude, our ability to save limb and life has definitely improved a lot, but our ability to manage acute pain, acute traumatic pain still lacks. What we can do here is understand trauma-specific concerns for such victims, give a tailor-made approach of analgesia to these patients, keeping in mind their specific injuries, which can provide not only an immediate comfort, but also a better long-term outcome to them. Thank you.
Good afternoon, doctor. Yes, so I understand you're a pain specialist working in the ED, is that right?
No, right now I'm not working with ED. I'm working in the anesthesia department,
Okay.
but I take care of pain services in the entire hospital.
Sure. So just out of curiosity, when you put these nerve blocks in the emergency department, how feasible is it in a busy ED to, because as an anesthesiologist myself, I can tell you that doing nerve blocks in the theater can be quite difficult to doing it in the ED because you need a separate block room, you need 2 or 3 people to give the blocks. How feasible is it to do all these various blocks in a busy emergency department with trauma patients just coming in like that?
Right now it is not very feasible because it requires a lot of training. I understand that emergency physicians are trained in certain way, but I think in collaboration with anesthesiologists and emergency physicians working together as a team, we can bring more feasibility into this thing and take care of it. It will require some time lag, some learning, but after that I think we can make it very much feasible and provide better relief for such patients.
So things like TAP blocks, rectus sheath blocks, all those things, those are mainly used for post-surgical anesthesia, right? I mean, in the ED, when someone comes with an acute abdomen, it's going to be a bit challenging for us to go in like that. Isn't that right?
Yes, but still we can use those blocks in ED. Once the initial stabilization part has been done, we can definitely provide these blocks and give pain management to those patients so that further assessments would be comfortable, like the patient would be comfortable for those assessments. These are not contraindicated. So if feasible, if possible, if we have people who are trained in that faculty, we can make use of them and provide better relief for such patients.
Okay, and you feel single shots are better, or can we put a catheter in the ED?
Actually, giving single shots with some additives like dexamethasone, we can
Bicarb, one of those
prolong
things,
the action for nearly 12 to 18 hours. I have been using myself such blocks where we use different additives like buprenorphine, dexamethasone, and the effect lasts for nearly 36 to 48 hours in some patients. So we can avoid using catheters because we can avoid the risk of infections by putting catheters in those cases. And if we have USG there and there itself, if the patient is having pain, again we can go and give a single shot block.
So that's what we are doing in our center also. Someone had actually asked us to put catheters, and I was in the same reasons you're giving. Yes. I've kind of gone against that. But I'm glad that this attention is coming in more. Regional anesthesia should come into the ED more, and I'm glad you brought that to the forefront. Thank you, doctor.
Thank you.
Oh, that was an excellent description of all the blocks which are supposed to give very good pain relief. But my one concern here would be the patient cooperation. See, a traumatized patient already in pain may not cooperate to that extent, is number one. And the next possibility is the adequate position which you require while performing a block is, again, not very optimal for you. So in anesthesia, yes, you have elective cases, you can give some counseling to the patient, and you can go ahead with the blocks. But in emergency, I feel it's my personal remarks on this is that the patient may not be all that cooperative. Then next is time consuming, and then in a busy ED, I think it is less feasible in performing all these blocks. Thank you.
Yes, ma'am. So right now it is definitely, but we can work on that.
Thank you.
Thank you.
I call upon our next speaker, Dr. Sabira Sethi.
Good afternoon, everyone. I am Dr. Siti Sabira, work in Manipal Hospital, Bangalore. I'm just going to talk about the role of whole body CT in trauma. In general, we call it as CT polytrauma. And the contents I'm going to talk about is some introduction, what is whole body CT and what are the indications, advantages and disadvantages, and let's review some literature as well, along with the radiation dose and its effect and few take-home points. So to start with, as we all know, more than 9 people die every minute from injuries or violence. This is as per WHO and CDC. 5.8 million people of all ages and economic group die every year from unintentional injuries and violence. The motor vehicle crashes causes more than 1 million deaths annually and an estimate of 20 million to 50 million significant injuries. And trauma is the leading cause of death in patients, like person aged between 1 to 44 years. More than 90% of motor vehicle crashes occur in developing world. This is as per ATLS 10th edition. So what is trimodal death distribution? So the death occurs in 3 peaks. The first peak happens between seconds to minutes of injury. It results from apnea due to severe brain or spinal cord injury, rupture of heart, aorta or other large blood vessels. Second peak, it happens between minutes to several hours. It results from subdural hematoma, epidural hematoma, hemopneumothorax, ruptured spleen, liver laceration, pelvic fracture or any other injuries with a significant blood loss. The third peak happened after several weeks, days to weeks. It is most commonly due to sepsis and multi-organ dysfunction. So what is whole body CT? Normally it covers the non-contrast CT of the head and the neck, and it's a contrast enhanced CT of the chest, abdomen and pelvis. But it depends on the institutional protocol, and we can also add additional protocol depending on the area of involvement. We can use arterial and delayed contrast images. So what are the indications? Any high-speed motor vehicle collision, non-trivial motor vehicle collision, death at the scene, or if there is any death occupant in the same vehicle, fall from height which is more than 2 meters, other concerning mechanism of injury, abnormal fast scan or any chest or pelvic X-ray, clinical signs which has involved more than one body region, or if there is any abnormal vital signs. Advantages. So it has got a diagnostic accuracy, reduces the time of imaging, reduced mortality. Disadvantages, radiation exposure and cancer risk, contrast allergy, and it's expensive. So let's review some literature. So does it identify occult injuries? There was a study conducted in 2015 which has compared a final whole body CT diagnosis with a clinical suspicion, and 4% of injuries in the whole body CT were not clinically suspected, and out of that 75% of those injuries were very severe, including C-spine injury, lung contusion, occult pneumothorax, brain contusion and etc. Can we do whole body CT in unstable patient? It's still a dilemma due to several reasons, because moving a patient from the trauma bay to the radiology, precious time is lost during workup, and very few studies have involved this. And if we compare the benefit with the risk, if the benefit is more, then definitely we should go ahead. And evidence base for this question is weak. And whole body CT is less time consuming. As per a study conducted which is in 2009 and 13, the whole body CT shortened the time from the admission to the CT by 10 minutes. So all duration, including the time from admission to the diagnosis of life-threatening injuries, were found to be lower in whole body CT group. And does it reduce mortality? I would say like in the Hubner-Weiner study conducted, where it has told that lower mortality is seen in whole body CT group. There was a trial conducted, REACT-2, which is the first randomized control trial conducted, which has compared the effect of whole body CT with a standardized CT on mortality. But as per the study, it has concluded that it is a statistically insignificant outcome. Evidence from the retrospective studies is insufficient to conclude whether there is mortality benefit with whole body CT or not. It's still a matter of debate. So coming to the radiation dose, the dose limits are recommended by International Commission on Radiological Protection. It is divided into two groups. One is for the public and one for the occupationally exposed worker. For the occupationally exposed worker, the effective dose is 20 millisievert a year. For the public, it is 1 millisievert a year. And the higher values are permitted if the average over the 5 years is not above 1 millisievert a year. And it varies from different organ or the tissue involvement. The cancer risk is more as the radiation dose is more. If it is more than 20, then the risk is more than 1 in every 1,000 people. So the radiation exposure, it depends on the type of CT scanner we use, either it's a single or multi-detector, depends on the operator and also the protocol used. So the newer 64, 128, 256 row multi-detector CT devices have lowered the dose of radiation when compared to a single or 4 row devices. And the mean effective dose ranges between 10 to 31.8 millisievert, but the actual radiation exposure varies at each medical center. So how do we reduce it? There is something called LRR principle, as low as reasonably achievable. So minimization of the radiation dose and limiting the release of radioactive material into the environment by 3 basic protection measures in the radiation safety. One is time, distance, and shielding. So reduce the time of exposure to the radiation, increase the distance between the patient and the radiation source, and by shielding. Adjusting a kilovoltage peak. It's a peak potential applied to the X-ray tube, which accelerates the electron from the cathode to the anode, more of physics, but it controls the image quality and patient dose. So KVP is inversely proportional. If the KVP is higher, then the radiation dose is lower. And also by avoiding unnecessary contrast use. Using a contrast is like doubling the dose of radiation. So let's discuss some case here. So there was a young male with a history of fall from the height who had presented with a lower limb injury. So initially we got a lower limb, whole body CT was done, along with the site of injury was covered, which has showed a calcaneal injury with intra-articular extension. But this patient also have involvement in the lumbar vertebra, where we can see there is a anterior wedge compression fracture involving up to the posterior part of the L1 vertebra. And also the brain coronal section had shown hyperdensity in the left frontal region along with the hyperdensity along the falx region, which is suggestive of subarachnoid and subdural hemorrhage. These were found incidentally in the whole body CT. And there was a second patient who had a history of road traffic accident where the patient presented with a blunt abdominal injury from a handlebar. And we got a CT polytrauma done. The first image the first image it is the arterial phase where there is nothing seen, but on the venous phase we can see there is a liver laceration involving the segment 7 and 8. And also in the C-spine bone window there was nothing seen, but on the soft tissue if you can see there is a hyperdensity noted posterior to the odontoid process. The corresponding axial section have shown anterior and the posterior arch fracture of C1 vertebra. Third patient, he had a history of road traffic accident who presented with facial injury and complained chest pain. So the CT as the facial injury was there, we can see there is a maxillary sinus fracture, both anterior and the posterior wall on the left side, along with the right side posterior wall fracture with a hemosinus. And in the lung coronal section of the chest, we can see there is a small undisplaced fracture in the rib, which is actually a 6th rib. Followed by the lung window where we can see there is a thin rim of pneumothorax noted, and this is the important image because this was found incidentally. On the angiography we could see there was a small dissection noted at the level of aortic isthmus. So the take home points here is whole body CT approach seemed to be superior to traditional CT in subjects of time of trauma related imaging, the diagnostic accuracy and mortality, but we believe that performing whole body CT for all patients is not favorable because of having serious additional radiation dose, and it is sensible to prefer whole body CT in seriously injured multi-trauma patients, but we need further study defining the seriously injured patient and strong rule out criteria for the decision. Thank you all. Any questions?
We didn't consider the mode of injury or nature of injury for epilepsy.
Thanks for the question, ma'am. And I didn't get you, sorry. Did they consider?
Mode of injury.
Mode of injury, yeah. Mode of injury is like high-speed motor vehicle collision if the speed is more than 60 kilometers per hour. All those are included, but there is no exact criteria as per the study conducted by Davis in 2016. These are the indication which was mentioned along with the radiopedia. This is the referral from radiopedia. Thank you. Anybody else? Thank you.
First of all, thank you, judges. Ma'am, I need, and Dr. Talha, I need your, how do you think about the topics? What do you think? How did it go? Please.
Yeah, the topics are really good. Most of them are very relevant to emergency medicine, and I think all the speakers have done justice and prepared accordingly. So, yeah. So let's, congratulate all of them for their good presentations. And all these attending conferences, presenting like this gives them good exposure and practice to improve teaching in their own departments. And, they should thank AEME for the opportunity.
Yeah, I congratulate all the speakers. I mean, they've done a really good job, especially with all these new platforms coming up, and they've got so many more platforms to do the young faculty presentations. So most of the topics were quite diverse. I mean, we are looking into something which is not just the core and crux of the emergency topics, but something outside that as well. I've been following up the topics since morning, so I think they've done a really good job. So congratulations, and may the best person win. So yes. Thank you.
So I just have one announcement to add. Thank you. We'll be collecting the results. Many of you have not entered your mobile numbers or your email addresses in the register outside. This is essential for getting the credit points from Tamil Nadu Medical Council. If you have not done it, please do it in whatever time, if after coming back from lunch or anything. Please do it. Otherwise, it will not come, if you have forgotten to enter any of your detail. Okay, number one. Number two is the fact that the winners almost are there with me. So, but what we'll do is we'll announce them towards the end of the session. Okay, and there's one thing which I wanted. It's half day, and I want Dr. David to tell me how did he find the day going. Please, sir, please. I want you to tell us and tell all of us.
First of all, I never thought you would throw a googly at me. But you don't know me, but those who know me know that I always say what I feel I want to say, whether it may be right or wrong in your perspective. I've actually spent a lot of time trying to run around the place, trying to figure out where to be, because there are so many things happening in so many different places. So, because all the topics seem to be very good. So, as Dr. Shakuntala was saying, we really don't know which one to miss and which one to hold. So, I wish, we had them all a little bit more compact so we could have attended as much as possible. But, but I think it's been very good, and I'm sure all of you will agree with me that it's been a learning experience. At least for me, it has been a very good learning experience. Thank you very much for organizing this.
So the reason, that's very correct, sir. Even I could not. There were some who were saying, so we are having here paper, ground, floor below poster presentations, and all of the topics are there as well, very good. So yes, we were missing them, but then we are recording those sessions, posters. Please go back, that YouTube link would be there. You may not be able to ask questions there, but at least you can listen to all what is happening out there. The pediatric emergency workshop is also being recorded, but as you can understand that there would be the hands-on sessions is not possible to record or to do. So we can tell you how to ride a bicycle, but till you don't ride it and fall, so it's not possible at that time. So thank you so much. We'll break for lunch. And we'll, so what is it? It is like 45 minutes of lunch, and I think so we'll be able to start back our next session where there we still have some paper presentations left. By the time the pediatric emergency medicine students will be back with us, and we will do the ABG, ECGs, and OSCEs. So yes, it would be a little longer a day, but then I'm sure to learn, everyone would be happy to sit back. Have your cup of, grab your lunch, then have your cup of tea a little later in the evening, and stay with us. Thank you so much.
So I'll be talking about 5 cases. Coming to first case, we had a 24-year-old male who came to our emergency medicine department with history of altered sensorium from 30 minutes. Upon detailed history, he told that he had, the attenders told that he had alleged history of snake bite. The site was at the right foot 2 hours prior to presentation. Primary survey showed that patient had a compromised airway, and this was the presentation of the patient. As we can see, patient has bilateral ptosis, partial ptosis with broken neck syndrome, what we call, that is because of the neck muscle weakness. Patient was immediately intubated and mechanically ventilated. His lab showed PT of 14.9, INR of 1.34. He was diagnosed to have neurotoxicity with coagulopathy. Immediately he was administered with 10 vials of ASV. 2 doses of neostigmine, 0.02 mg per kg IM was administered 1 hour apart with atropine prior. Further, 10 vials of ASV was administered after 6 hours in view of persisting coagulopathy. Patient had a complete neurological improvement and was extubated on day 2 and discharged on day 3. Second case was a pediatric patient, 13-year-old with history of snake bite, right foot. Complaints of severe pain, altered sensorium, en route to the hospital. Primary survey only showed that he had tachycardia with GCS of 9. He was also intubated and mechanically ventilated. But the problem with this child was he had bleeding from most of the orifices. He had oral cavity bleed from his oral cavity. He had rectal bleed, hematemesis. He had bleeding even from the IV cannula site. Also had hematuria. His lab showed PT of more than 2 minutes and INR was unrecordable. We got a CT since the patient had altered sensorium to rule out ICH. However, CT brain was normal. He was also diagnosed to have coagulopathy with query DIC. He also was administered with 10 vials of ASV, which was repeated after 6 hours. FFP was considered for him, 10 ml per kg. Coagulopathy improved and was extubated on day 2. Condition gradually improved and was discharged. Case 3, 36-year-old male with a history of snake bite. Again, he also presented within 30 minutes of presentation with bite to right foot. He only had mild pain. Primary survey did not have any problems. He was completely stable within first 1 hour. WBCT were all negative. However, after 1 hour, he had a gradual increase in the swelling of the bite site, and the swelling included the entire foot. Initial lab parameters were within normal limits. However, we considered local signs of envenomation since he had swelling of the entire foot, and went ahead and we gave 10 vials of ASV with antibiotics and was admitted to our ICU. Day 2, swelling progressively worsened, suspected impending compartment syndrome, and was taken up for emergency fasciotomy with additional doses of anti-snake venom. However, subsequently his renal function started worsening and was found to be completely anuric. His peripheral smear showed cystocytes. We suspected venom-induced atypical hemolytic uremic syndrome. Nephrology consultation was asked for this. Who advised plasmapheresis? We went ahead and we did 4 cycles of plasmapheresis and 5 cycles of sustained low efficiency dialysis, that is SLED, and additional doses of ASV as per the coagulation profile. Condition worsened progressive days. He was put on NIV and further intubated. Despite of our efforts, patient could not be revived and patient succumbed. We went ahead and did a postmortem renal biopsy which showed features of acute tubular necrosis and acute interstitial nephritis. Fourth case was a primary gravida, G2P1L1 with history of snake bite right foot. Complained again of severe pain and swelling. However, primary survey revealed no stable vital parameters. Local examination showed gradual worsening of swelling. Lab parameters showed she had thrombocytopenia. Hematoxicity with local signs of envenomation was diagnosed and was given 10 vials of ASV. Again went into compartment syndrome and we did emergency fasciotomy with surgery consultation. These were the initial presentation. Figure 3 shows that there is swelling of the right foot with gradual progression to a compartment syndrome and underwent fasciotomy. Fetal monitoring was done with OBGYN consultation. However, the outcome was safe. The mother and the child was safe while discharged. Fifth patient also came with a history of snake bite. 3 days back, he had bite to both the hands and had swelling up to the elbow. Received Ayurvedic treatment elsewhere and he was completely given fluid restriction. Completely anuric since 1 day and hence was referred to RED. Lab parameters showed acute kidney injury and coagulopathy. 10 vials of ASV, antibiotics, and hemodialysis was considered in view of anuria and metabolic acidosis. Anemia progressed, coagulopathy also progressed. He was diagnosed to have Viper-induced consumptive coagulopathy. Blood transfusion, hemodialysis, ASV transfusion according to INA was done with FFP transfusion. Patient condition improved and gradually discharged. What I would like to discuss in this case series is that even though we have so many case reports of snake bites, there are very few case series which tells the presentation to ER, hospital course, and management of complications in the literature. In our case series, we had 5 patients. 3 were male, one was primary gravida, one was pediatric patient, one had delayed presentation. And the culprit snake, according to WHO, was identified as to be Russell's viper. 4 patients had coagulopathy, 2 patients had DIC, 1 was diagnosed to have renal biopsy proven ATN, 2 patients had compartment syndrome and went into fasciotomy, 2 had respiratory failure, out of which 1 had neurotoxicity and 1 patient succumbed. So what I would like to conclude is that when a patient comes to our emergency department, not only identification of envenomation is important, but also to admit and have an eagle eye to see the progression and complications and to recognize and timely management of those complications. These were my references. Thank you.
Question from audience is must for judging the candidate. These are your topics.
Possibly feeling a bit shy. I asked the first question. So the guy who died. So I presume he died of his renal impairment.
Yes, sir.
So what was precluding you from, or the intensivists from giving him renal support for a few days? He had SLED, right?
Yes, sir.
Was he having hemodynamic compromise, high pressor need? What made it difficult for him to have renal support?
Sir, actually, he was hemodynamically stable, sir. Since the time he had his hemodialysis and SLED, he was hemodynamically stable. Only on one day, he suddenly went into a sudden onset of breathlessness. And following that, he had a very bad course in the hospital, sir. Like, till that time, patient was very much stable because I kept on following up the patient. But after that one night, he had a very erratic course of illness. And since we had already done hemodialysis, 4 cycles of hemodialysis was done till that time. So following that also, we went ahead and we did hemodialysis, sir. But still, patient could not be revived, actually.
All your 5 patients, which ones do you think were a bit atypical of Russell Viper envenomation?
Sir, I think this neural paralysis, because Russell's Viper, we don't see that many neuroparalysis, but there are cases which shows that Russell's Viper also can cause paralysis, sir. So I think it was that patient, because I thought it was more of Cobra, but Cobra will not, there is so many literature of coagulopathy with neuroparalysis have not been reported. So maybe that patient, so what I thought.
Initially had just local envenomation. Even that was a bit delayed in onset.
Sir,
right?
actually when he came, he was completely fine, sir. He was actually under the influence of alcohol. He came to our hospital. Even though he was under the influence of alcohol, we could tell everything. He was completely fine, sir, for 1 hour almost. Then we noticed that there was worsening of swelling, and we decided to give ASV. So, yeah, sir. So.
Which guidelines you followed for your presentation or
Ma'am,
your
WHO
patient management?
Ma'am, WHO guidelines for all the patients, except for pediatric patient, we used Indian
when it is updated?
WHO is 2020 guidelines, ma'am. But
is it mentioned that 10 vials in these such critical patients?
20, ma'am. 20. Up to
Why
20,
in all patients you mentioned 10
vials.
And then we are mentioning that patients became more critical. Initially, you have not given sufficient ASV, no?
Ma'am, but local hospital policy also.
Crores, no economical should be considered.
Yes.
And second, in first case, you have given injection neostigmine intramuscular.
Yes, ma'am. Because I am.
Why you have given intramuscular, na? In such critical patients, and again when we are suspecting some hematotoxicity or something like that, we should avoid as far as possible IM.
Yes, ma'am.
Except it, no injection should be given IM.
Okay.
Thank you.
Thank you, Vivek. Now we have a second speaker for the afternoon session. I would like to invite Dr. Avichal Rajpal, who would be talking about renal involvement in dengue patients.
A warm good afternoon to one and all present here. This is Avichal Rajpal, junior resident in the Department of Internal Medicine at PGI Chandigarh, and I am here to present this topic on renal involvement in dengue viral infection in patients admitted to our setup, a prospective observational study. So as we all know, dengue is one of the most common arthropod-borne viral illnesses worldwide, with approximately 400 million cases being reported, out of which at least 1/4 are clinical. AKI is one of the least studied complication of dengue, and the studies which have evaluated this aspect have found that there is a increased morbidity and mortality associated in patients of dengue who have renal involvement. Hence, early recognition of AKI is needed in these patients, is the background of this study. Objectives of our study were to assess the incidence of renal involvement. We have studied it in the form of asymptomatic urinary abnormalities and AKI. We have tried to correlate this involvement with morbidity and mortality in our patients, and to actually see how many of these progress to CKD by following them up. So this was a single center observational prospective study design with patients coming to our emergency at PGI being enrolled from July 2022 to December 2022. The study size was calculated to be 192, but then was cut down to 129 for operational reasons. Bias was likely Bergsonian because it was a single center study with a tertiary care setup. So let me take you through how the study went. So we had patients coming to emergency with symptomatology of tropical fever syndrome, patients who were more than 12 years of age and fitted the diagnostic criteria of dengue by WHO definition. Any patients who already had underlying CKD or any other chronic illness with underlying renal involvement were excluded. Patients who did not give consent were also excluded. Finally, patients underwent extensive clinical examination and data collection and were classified into patients with or without renal involvement. Patients with renal involvement were subclassified into patients with asymptomatic urinary abnormalities and AKI, and each of these groups were followed up at 4 and 12 weeks so as to see whether there was persistent involvement or not. Post this, analysis was done using SPSS 25. The categorical variables as standard were analyzed as proportion or percentage, while quantitative variables were analyzed as median or mean as applicable. Univariate, and in cases where applicable, multivariate analysis was also done. I will take you only through the most salient features of the results of our study. So this big table tries to consolidate the baseline characteristics in the form of demography and clinical presentation. So we found that on univariate analysis, patients coming from rural areas had higher propensity to undergo renal involvement in patients with dengue. Also among clinical parameters, hematuria, oliguria obviously involved the renal system, but altered sensorium was a finding which was positively associated with renal involvement. This is also depicted in this graph. Coming to the investigations comparing these two groups with and without renal involvement, we found that hyperphosphatemia, hyperkalemia, and hypocalcemia were associated with patients with renal involvement. More importantly, patients who died in our study were significantly associated with AKI. So we also did a multivariate analysis among these two groups and found that altered sensorium and higher lactate levels, which likely reflected shock and capillary leakage, was individually significantly associated with renal involvement. This slide just tries to depict the spectrum of urine abnormalities which we got. So we had patients with hematuria, proteinuria, and patients with urine active sediments with or without AKI in our spectrum. So this is a table depicting the non-survivorship versus survivorship in our patients. We tried to find out the significant variables which were associated with the non-survivorship in our patients. And post a multivariate analysis on this table, we found that oxygen requirement and AKI were individually and significantly associated with mortality with a p-value less than 0.001. Upfront in the discussion, I would like to list the key results that renal involvement was more common in patients coming from rural areas, though this was only seen on univariate analysis. Oliguria, altered sensorium, edema were each significantly associated with renal involvement in dengue viral infection. Hypercalcemia, hypocalcemia, and hyperphosphatemia were also associated. Most importantly, like I said, AKI group had higher mortality even on multivariate analysis. We've tried to compare various other studies which have studied similar findings and found that our study had higher proportion of AKI and renal involvement. This, I think, can be explained by the fact that our center receives slightly patients who are present towards the more severe side of the spectrum of dengue. Also, all of these were retrospective studies across 2 to 3 years, whilst R was a prospective study studying dengue over a single season. This leads me to further limitations of a study where I can say that only a single season was studied, Bergessonian bias was likely. Also, higher number of patients, if we could have done a histopathological examination, we could have better delineated the underlying etiopathogenesis of the renal involvement involved in dengue, which have been studied like immune-mediated damage, direct glomerular injury, HUS-related damage, in addition to the already known shock-related prerenal AKI. So to conclude, I would say that renal involvement is a underreported, under-identified complication of dengue, and as WHO has now termed this to be expanded dengue syndrome, with AKI being an independent factor of mortality in these patients, and hence early recognition of AKI might go a long way in reducing morbidity and mortality due to this very common tropical disease which affects our country. Thank you.
Yeah, so we are a good presentation, but can you tell me how many of your patients with AKI or renal involvement needed renal support, please? How many of them needed renal support?
Sir, out of my patients, we had 129 patients in our study, out of which 7 required hemodialysis, sir, and 11 expired out of them. So 10 out of 11 had, 11 patients expired. Out of that, 10 had AKI, and 6 of them required hemodialysis at some point during the illness. Only one patient who required dialysis could survive through the hospital course, and we are following her up. She's turned into CKD finally. Her biopsy turned out to be HB cast nephropathy finally. All of them, all the other 6 patients expired during the course of illness.
Okay. So did you look for other organ involvement? Is it a case of, why can't I see it as a case of dengue shock with multi-organ involvement?
So that is why we have studied factors like higher lactate and oxygen requirement into the multivariate analysis. So we could correlate whether are they confounding into our diagnosis. But we found that individually all of them are associated. So just like higher lactate or shock, or just like oxygen requirement or ARDS is associated with death, like that AKI is individually associated with death is the point we are trying to say. This does not undermine the importance of other organ involvements into dengue, but this just tries to bring up that there is another organ involvement which has yet been neglected.
Does your study say that? As a single predictor?
Yes, sir. So multivariate analysis pointed out that oxygen requirement, higher lactate levels, and AKI were individually associated with mortality. Sir. All of them were seen on univariate and then verified on multivariate. Sir.
Okay.
Thank you.
Just one question. Why is it that you restricted the age group to 12 years?
Sir, actually our hospital has a separate building for pediatrics in the form of less than 12 years. So patients coming to our emergency at PGI are shunted off at the gate itself to more than 12 years of age. So to enclose a larger population, we'll have to do a within campus double center study to enclose all category of patients. Though I should tell you that a similar study has been done in pediatric population also in our center itself, but the results are yet awaited.
The reason why I'm saying is, internationally, pediatric age group extends up till the age of 18.
Yes.
So therefore, if you want to send your paper for publication somewhere,
Yes.
people would like to know this as a first question because there is a selection bias.
That's a good idea. Yes, yes. Yes, sir. We have a comprehensive. Thank you.
Thank you, Vishal. It was a nice presentation. Next, I would like to invite Dr. Mani Rajendran. He would be speaking about the ophthalmological manifestations of scrub typhus.
Good afternoon to all. Today, myself, Dr. Mani Rajendran. Today, I am going to present ophthalmological manifestation of scrub typhus from a large tertiary care center. Scrub typhus, as we know, a vector-borne zoonotic infection caused by Orientia susugamusi, transmitted by a mite. Now, recent systematic review suggested scrub typhus re-emerged as a major cause of acute undifferentiated febrile illness with high morbidity and mortality. About 1/3 of scrub typhus patients will present as a multi-organ dysfunction syndrome with case fatality rate varied from 1.3% to 33%. Studies regarding ophthalmological manifestations in scrub typhus are very few in number and which are conducted in 1940s and 50s during the Second World War time. Our aim in this study to assess the incidence of ophthalmological manifestation and to assess its correlation with morbidity and mortality, and to follow up the patients who had presented with eye manifestation to see whether the changes are temporary, permanent, or worsening. Our study is prospective observational study done in between July 2021 to October 2022 in a tertiary care hospital in Chandigarh. All patients presented with age more than 12 years and diagnosed to have scrub typhus by using either IgM ELISA or polymerase chain reaction or serology-based rapid diagnostic kit. The exclusion criteria includes patients with past history of hypertension, diabetes mellitus, CKD, CLD, and CVA were ruled out because these patients can have eye manifestation because of basic disease itself. Bias which could not be avoided in our study is Bersonian bias and selection bias. All patients' clinical parameters, ophthalmological and laboratory parameters were recorded. We did ophthalmic examination in emergency department itself by using torch examination and Welch-Allyn panoptic ophthalmoscope. Actually, this ophthalmoscope is very easy to use because observer and patient's distance will be maintained with this panoptic ophthalmoscope. This is the photograph of the panoptic ophthalmoscope. Data was collected by using EpiCollect-Pi. Statistical analysis was done by using SPSS software 24 version, and we did univariate analysis and multivariate analysis. This is the flow chart of our study. Total patients diagnosed with scrub typhus were 106 patients. Among that, 17 were excluded because of co-infection. So finally, 89 patients were recruited. Among the 89 patients, 23 patients had eye manifestation, and 17 patients were discharged, 6 were succumbed to their illness. 13 out of 17 patients were followed up, and 4 patients were lost to follow-up because of logistical issues. This graph shows clinical features in our study. Almost all patients had fever in our study group, and most of the patients were presented with GI symptoms or respiratory symptoms. Bleeding manifestation only seen in 5 patients in our study group. This is the clinical photograph, showed scar in various parts of the body. 15% of our study population had scar. Eye manifestation in our study had subconjunctival hemorrhage in 3 patients, nystagmus in 3 patients, 6th cranial nerve palsy observed in 3 patients, and exposure keratitis observed in 3 patients. 6 patients had retinal hemorrhage and 5 patients had papilledema. This is the clinical photograph taken by using panoptic ophthalmoscope with eye examiner. First image shows 22 years old lady with scrub typhus, showed multiple retinal hemorrhage in supratemporal and infratemporal quadrant, and second image showed hard exudate. This is the baseline investigation, showed platelet count of 46,000 as a median range. Hepatosplenomegaly was observed in more than 60% of the patient. 14 patients PCR sample were sent from scar sample, and among the 14 patients, 10 patients were found to be positive. This is the baseline characters table in our study group. Younger age group had more eye manifestation in the scrub typhus group, and altered mental sensorium significantly associated with more eye manifestation, and mortality rate also significantly more in with eye manifestation group, around 26%. Without eye manifestation only had 9% of mortality rate. So in our study, incidence of ophthalmological manifestation in scrub typhus was 25%, and in comparison, patients with eye manifestation had 3.5 times increased mortality rate, and most of the ocular manifestations were spontaneously resolved in 3rd month follow-up. These are the similar studies conducted in scrub typhus. She et al. Studied 451 patients with scrub typhus in 1946 and observed these findings, which was similar to in our study group, except disc edema, which was observed in 36%, and retinal veins engorgement, which was observed in 67%. Another study conducted by Donegan et al. With 101 patients reported 4% mortality rate, but in our study group, 26% of the eye manifestations people were succumbed to their illness. McCaskill et al. Also observed 70 cases in scrub typhus in Assam, India, and found similar findings in our study. These 3 studies were conducted in 1946 to 1955 period. After that, there was only case reports are available. Limitation of our study is, one of the limitation is Bersonian bias, and our panoptic ophthalmoscopes only had 25 degree of field of view in our fundus. I would like to conclude with scrub typhus patients can have eye manifestation. In comparison, patients with ocular involvement had significantly increased mortality, and in scrub typhus, ophthalmic evaluation should be a part of the examination. Thank you.
So, well done. Almost all of your findings in the eye are either related to the thrombocytopenia or the raised ICP encephalopathy. Am I right in saying that, or am I oversimplifying it?
Sir, 6 nerve palsy is due to increased ICP, sir, because the CT findings also correlated with that. After among those patients, 1 patient succumbed to the illness, and 2 patients 6 nerve palsy was resolved during the discharge time. But thrombocytopenia, we did multivariate analysis also, and we categorized that to less than 30,000, less than 50,000, and less than 75,000, and less than 1 lakh. But any of that group was not significantly, statistically significant, sir, between the with eye manifestation and without eye manifestation group. So thrombocytopenia related eye changes is not significant in our study group, sir.
So what prompted you to do this study? Is it that you bought this fancy device?
Sir, because ophthalmological usually patients who reported to emergency department, they won't complain of ophthalmic complaints also, and 2 or 3 case reports also is there, sir, with vitreous hemorrhage, and patients underwent evisceration also. So some rare reports is there, but there are no prospective observational study how many patients had very more eye manifestations and which are not resolved. So we conducted these studies.
Thank you.
Where are you working, rural or urban area?
Sorry, ma'am?
Where you are working? Where you have done your study?
Ma'am, I am working in PGMR, ma'am.
So
most
is
of the
it
patients,
rural area or urban area?
ma'am, most of the patients got referred from Himachal Pradesh, Punjab, and sometimes from Uttar Pradesh also. So we cannot conclude
So is
it,
it that much common?
Yes, ma'am.
106
Himachal Pradesh had more scrub typhus patients,
So what is
ma'am.
the reason behind that? We are finding such more patients over there only.
Because in Himachal Pradesh, usually hilly areas, and patients used to live with bushes, ma'am.
Then we may find in Uti also.
Ma'am, in Tamil Nadu, after Himachal Pradesh, Tamil Nadu also reported more scrub typhus patients, and most of the studies from scrub typhus were reported from Tamil Nadu also conducted in CMC, ma'am, because of the caseload only. Thank you. Yes, sir.
See, the eyes are referred to as the windows to the soul.
Yes, sir.
To us as clinicians, the eyes do give us certain vital information, especially in disease conditions like diabetes, hypertension. So we are also able to grade the severity. We are also able to prognosticate many things.
Yes,
similarly, what I want to know from you is, now that you have this equipment and you have done this, have you looked at the possibility, have you looked at any correlational studies between the severity of the disease and the outcome and the eye manifestations?
Yes, sir. Which was I showed, sir. About
Sorry,
3.5.
I did not focus on that. Sorry.
3.5.
Just repeat just one thing for me. There is a significant correlation between the eye findings and the disease status and its outcome. Is that true?
Yes, sir. Is it true?
Okay.
Sir, around 3.5 times more mortality risk compared to without eye manifestation group, sir. But
see.
however, duration of hospital stay was not significantly different, sir.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Mani. Next, I would be inviting Dr. Shruti. She would be talking about the ultrasound assessment of optic sheet diameter for evaluation of raised ICP in head injury patients.
Good afternoon, faculty and colleagues. I'll be talking about USG assessment of optic sheet nerve diameter for assess the raised ICP in emergency setup, especially in traumatic brain injury cases. Why is this important? Because in a prompt treatment in traumatic brain injuries, preventing secondary brain injury and mortality plays a vital role. Non-invasive approaches are constantly being approved and can provide reliable estimates. The use of point-of-care ultrasound for the assessment of raised ICP in emergency setup has been recently gained popularity, and there are many studies that have been shown that there is a good correlation between the raised ICP and raised optic nerve sheath diameter. So, traumatic brain injury is defined as a brain damage from the external mechanical forces leading to physical, cognitive, emotional, and behavioral disabilities. Symptoms and outcomes can range from complete recovery to there may be a permanent disability or death. So it is traumatic brain injury is a major cause of morbidity and mortality worldwide, mainly in young adults and children. The timely diagnosis of post-traumatic raised ICP can allow for early intervention for at least momentary procedures and a definitive treatment in neurologically compromised patient and is associated with improved outcomes. Usually, invasive ICP monitoring is the gold standard for demonstrating ICP raise, but this has a complication such as hemorrhage, infection, and malposition and device malfunction. Also, it is not readily available in many healthcare facilities. Hence, non-invasive methods have been developed for detection of elevated ICP. CT is considered as the non-invasive method of choice in this concern. Two main classifications based on the CT findings have been reported. One is Marshall CT classification and the other is Rotterdam CT classification score. However, Marshall CT classification does not acknowledge EDH or SDH in its classification. So, Rotterdam CT scoring system includes whatever the limitations that Marshall's classification has. And various studies have been validated that our CT score proved to be an independent predictor of outcome in TBI patients. So there are several limitations for CT scan as well because we cannot transport to CT critically ill patient to a CT, and excessive radiation exposures and time consuming and cost factors, which urged the researchers to find other alternatives. There are other non-invasive alternatives like fundoscopy and Doppler pulsarity index, but they cannot be readily done, or however it requires a lot of experience, which is most likely not can be done in the ER. So this led to a development of ultrasound guided optic sheet nerve diameter measurement for the to see raised ICP in traumatic brain injury patients. So the optic nerve is usually part of central nervous system. It is anatomically developed related to CNS because it develops from diencephalon. So all the three brain coverings that are present in the are also covering the optic nerve. So any raised pressure in the brain is transferred to this optic sheath. So we can measure via ultrasonography in the ER bedside to see if there is a raised ICP or not. This study is aimed to determine the agreement between the ultrasound and brain CT scan for the detection of raised ICP through ONSD measurement in patients with traumatic brain injury. We took 120 patients of traumatic brain injury in this study, and inclusion criteria were is the age group above 18 years, and exclusion criteria were age group less than 18, pregnant female, and patients with any ocular trauma, history of ocular pathology, and history of previous eye surgeries. Initially, ABCD approach was used for initial assessment and simultaneous resuscitation and stabilization of the patients. And after appropriate resuscitation and stabilizations, ONSD measurement was done with a Sonosite Edge 2 13 to 16 Hertz probe, and the diameter of the optic nerve sheath was measured in the both eyes for each patient, and the mean of the ONSD was obtained. Necessary radiological investigations, including CT brain, was done. Based on the CT scan findings, Rotterdam score was calculated, and the Rotterdam score uses 4 independent elements. One is the degree of basal cistern compression, a degree of the midline shift, epidural hematomas, and intraventricular or subarachnoid bleeds. And based on the findings, if there is a basal cistern compression, we point at 1, and if there is a midline shift, we score at 1, and if there is an epidural mass or lesion, 1, and intraventricular blood or traumatic SAH, we give 1. The total sum is added, and a plus is always added to the total sum score. The mortality in adult increases with the increase of RCTS scores, and the RCTS scores was calculated for the entire sample, and patients were categorized into two groups. One is with a score of less than 4, mild injury, and with a score of more than or equal to 4, moderate to severe injury. And so the mean of the optic nerve sheath diameter also noted. Yes. So we noted that in a group 1 patients with a mild injury, the optic nerve sheath diameter was, mean optic sheath nerve diameter was 4.28, and in the group 2 with a moderate to severe injury, ONSD diameter was 5.4, which relates that people with a moderate to severe injury have an increased optic nerve sheath diameter, which correlates with the increase in the ICP, raised ICP. These are graphs, and this is the AUC ROC curve showing. There are multiple studies done. Yes. So point of care measurement of optic sheath diameter to detect raised ICP in traumatic brain injury is the easiest and non-invasive and cost-effective technique, and that can be done in the emergency department. And the raise in the optic sheath diameter correlates well with the Rotterdam CT score of above 4 and above. We never done it, so we've never done it. We wanted to see, sir.
Though you are a gentleman, I am not. This is not a presentation. This is called a read aloud session. In fact, children, when they are in primary school, they are asked to go to the front of the classroom and read out from a book. What you have done is a read aloud. Okay? Yes. If this is what your department thinks, that you will do a study because it has not been done in your department, then you have no concept about research, and this is not the way you should be presenting. Which year of training are you in?
3rd year, sir. I apologize. This is the last minute PPT presentation.
No, I don't want to know that. Just answer my question. Which year of training are you in?
3rd year, sir.
3rd year.
Yes, sir.
You still have a few months.
Yes, sir.
Okay? So before you become faculty, make sure that you don't think all of us are idiots who sit here and listen to her read aloud. Yes. Okay? And I'm glad you
Good afternoon, one and all. I'm Dr. Aeme-Con. I'm third year postgraduate resident in the Department of Emergency Medicine, STM Medical College, Dharwad. So, why I chose this topic is because there is no single independent marker of mortality in patients who have come up with sepsis. There are multiple single markers which we can use, but then there is no independent marker which can detect mortality in patients presenting with sepsis. So, C-reactive protein to albumin ratio and NL. 1 minute. Sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response. Sepsis, including severe sepsis and septic shock, have remained the major cause of morbidity and mortality worldwide. C-reactive protein and procalcitonin are considered to be the best markers as of now in determining sepsis. So, C-reactive protein is a acute phase reactant protein which is produced by the liver. And as the level of CRP increases markedly in response to infection, the magnitude of the increase may correlate with the severity is what we know. Albumin is another protein which is produced by the liver, which makes up 40% to 60% of the total proteins in the blood, and the level of albumin keeps on decreasing in case of severe sepsis is what we know already. Many studies have demonstrated that the increased CRP and reduced albumin happening in case of inflammatory conditions. CRP to albumin is an index based on CRP to albumin level and is calculated using CRP by albumin formula. So our objective was to estimate the utility of CRP to albumin level as a predictor of outcome in the form of mortality or improvement in sepsis patients who are admitted to ICU. So all patients coming to SDM Medical College Hospital, Dharwad was enrolled during the study period. Study period was for 1 year, and it was a prospective observational study. So all patients matching the SIRS criteria were included under the study. They were aged more than 18 years, and the definition of sepsis was met. And exclusion criteria was to exclude patients less than 18 years who had CLD, nephrotic syndrome, immunocompromised patients, patients going DAMA or not giving consent were excluded. Sample size was 100. Patients methodology was patients who are diagnosed with sepsis between that period was taken. Detailed history and routine investigations were sent. CRP albumin were recorded. CRP was calculated using nephelometry technique, and serum albumin was estimated using bromocresol purple assay. Follow-up was done during the study period, and the outcome in the form of either mortality or improvement survival was recorded. So out of total 100 patients who were analyzed in the study, my study had patients between 61 to 70 as the major age group. So the average age was 60 plus or minus 11 years. And most of the patients were males, which was about 64, and females were about 36. So among the chief complaints that patients presented with, most of the patients had a fever and breathlessness as their complaints. So the most common diagnosis, most common focus of infection in patients who were under my study was LRTI with 45 being the number. Among the distribution of SIRS score, patients who had a score of 2 were 32, and patients who had a score of 3 were 49, and patients who had a score of 4 were 19. The different components of the SIRS score and their numbers have been mentioned, among which tachycardia was the most presenting SIRS score. Among the QSOFA score that the patients had, QSOFA score of 1 was noted in 46 patients, whereas 2 was noted in 39 patients. So among the distribution of laboratory parameters among SIRS score, we can note down that patients with elevated CRP alone had a value of 121 plus or minus 9.63 in SIRS with SIRS score of 4, whereas it was significantly low in SIRS score of 3 and 2 respectively. So the p-value was significant in this study. A serum albumin, however, was found out to be 2 plus or minus 0.28 with SIR score of 4, whereas it was 2.2 plus or minus 0.3 in SIR score of 3, and it was 2.8 plus or minus 1.3 in with SIR score of 2. CRP to albumin ratio was calculated, and with SIR score of 4, it was 51 plus or minus 4.8. So, another significant thing was neutrophil to lymphocyte ratio with 12.7 plus or minus 9.5 with SIR score of 4, whereas it was significant. It was 8.3 plus or minus 3.7 with SIR score of 2. So the average parameters of CRP and serum albumin levels are like this. So among the outcome analysis, patients who improved in my study were 75 and patients who died were 25. So among the patients who improved, the average C-reactive protein to albumin ratio was 10.32 plus or minus 5, whereas in patients who succumbed, it was 39.31 plus or minus 12.8, and it had a p-value of less than 0.0001, and it was statistically significant. So CRP to albumin ratio as well as NLR was significantly higher among the patients who died due to sepsis. The limitations in my study were it was a small sample size and it was carried out in a tertiary center, and we took SIRS as the screening criteria because it was probably simple, but however we should have used SOFA, which is a better score of screening as compared to that of SIRS. So thank you for giving me this.
Good. I have a question though. You know, in one of your slides,
yes.
The CRP for the SIRS 3 and 4, yes. Sorry, not the CRP, the albumin was pretty much the same. It was 0.3 and 0.28.
Yes, sir.
So the correlation of your ratio, the mortality prediction or the severity prediction,
okay, sir,
by the CRP independently and the CRP stroke albumin ratio are the same pretty much, because the denominator hasn't changed.
Yes, sir. So, but when we take either CRP or serum albumin separately, and if we use it to predict mortality, then it doesn't hold good as an independent predictor, sir. But when we use CRP divided by albumin, like it mostly can hold good is what we thought, and the study has proven that like it is significant. But the only problem with this study was that we did not follow up the patients to get to know follow-up albumin value, wherein we could have drawn an ROC to say that above what value the CRP by albumin ratio is like really significant to predict mortality. But as of now with this study, we know that like CRP to albumin ratio, if it is high, then like patients have a higher chance of mortality.
CRP, I mean, I agree that it's a good predictor, but is it a better predictor than CRP on its own? Leave the albumin out. We do know that significant hypoalbuminemia is a mortality predictor.
Yes.
But as per your data, so it seems as if it's no better than CRP alone on its own.
Did you exclude patients with the CKD and CLD? The half-life of albumin is just 18 days. Anyone who has a subacute illness will have a low albumin. So that will, interfere with the results of your study.
Actually, that's the second question that I had. Have you looked at the confounders? So you got a patient who's got SIRS. Okay, multiple reasons for causing SIRS. Yes. You looked at the manifestation yes. rather than the etiology. So when you're looking at manifestation, there can be a lot of confounders. Many things can cause a problem, both with CRP as well as hypoalbuminemia.
Yes, sir.
Okay, so you need to do what's called as a subset analysis. You need to really look at the disease conditions
yes,
which have given rise to SIRS. You already have the data with you. I'm sure you do. Because you would have known why the patient presented with SIRS.
Yes, sir.
So you look at the disease conditions and do a subset analysis, which will give you an idea.
Okay, sir.
And secondly, you know very well, you and I know very well, that CRP always goes up whenever there is any inflammatory response,
Yes.
which is there for any condition which is causing SIRS. As we said, SIRS is an outcome, a manifestation,
Okay, sir.
right? So therefore, by itself, CRP shows that higher the CRP, higher is the mortality, because higher, more profound is the inflammatory response.
Yes, sir.
So just make sure that we are looking at all these things. Two things. One is, as Daba was saying, whether really we need to go through the calculation of this ratio, because the numerator by itself may give you the be the outcome predictor, and secondly to look at the confounders.
Okay, sir.
Okay.
CKD, CLD.
You did, is it?
Yeah.
But how did you exclude CLD?
So because both the CRP.
No, how did you exclude CLD?
Sorry, sir. Patients.
Chronic liver disease patients, how did you exclude them?
Patients who are a known case of CLD were excluded.
Someone may have a NFLD and he may not have a decompensated cirrhosis. He may just have a compensated cirrhosis, and clinically he look fine. So did you do an ultrasound to look at the liver echo texture, or you do fibroscan or other things?
No, sir. I take it.
Can we have the questions later, sir? Yeah.
Thank you.
Thank you, Dr. Amoghh Varsha. Now I would like to invite the next speaker, Dr. Sangeeta. She would be talking about predicting post-intubation hypotension with shock indices.
A warm good afternoon to everyone. Myself, Dr. Sangeeta Sajeev, DNB resident of Pushpagiri Institute of Medical Science and Research Center. Okay, my topic for presentation today is it is a study on predicting post-intubation hypotension with age shock index, modified shock index, and shock index in the emergency department. So first of all, what is post-intubation hypotension? So the literature gives definition of post-intubation hypotension as decrease in systolic blood pressure to less than 90 millimeter mercury, or decrease in mean arterial pressure to less than 65 millimeter mercury, or decrease of systolic blood pressure of more than 20% from the baseline, or the initiation of vasopressor within the 60 minutes following intubation. So most of the studies have taken the definition as decrease in systolic blood pressure to less than 90 millimeter mercury, or mean arterial pressure to less than 65 millimeter mercury, and this is the definition that we also taken for our study. So the post-intubation hypotension is one of the major complications of endotracheal intubation, and it is associated with increased ICU and hospital stay, and also increased morbidity and mortality. So there are different studies to evaluate what are the factors that are causing this post-intubation hypotension, and shock index is one of the variable that has found significant association also. But there are now newer modifications to shock index, like modified shock index and age shock index, and there is only a few studies comparing these things. So our study was to compare the age shock index, modified shock index, and shock index in predicting post-intubation hypotension, and that was our primary objective. And secondary objective included to assess the frequency of post-intubation hypotension in emergency department, and also to identify other factors that are associated with the development of post-intubation hypertension, like age, comorbidities, cause of illness, reason for intubation, and ventilator parameters. So this was a longitudinal study which was done from 1st April 2020 to 15th July 2022, and we done consecutive sampling, and the study was done in adult patients presenting to the emergency department who required rapid sequence intubation, and study was done in emergency department of Pushpagiri Institute of Medical Science and Research Center, Tiruvalla, Kerala. And the inclusion criteria was the patients of age above 18 years who needed rapid sequence intubation in emergency department. And the exclusion criteria included all the patients who had pre-intubation systolic blood pressure of less than 90 millimeter mercury, or pre-intubation MAP less than 65 millimeter mercury, and the patients who are in cardiac arrest, or the patients who received antihypertensive during the procedure, and those who have severe traumatic brain injury, and those patients whose bystanders didn't give consent. So the study tools include a structured performer, then ABG, cardiac monitor, NIBP monitor, shock index, modified shock index, and age shock index. And the sample size calculated was 80. And we done the study in 85 patients, adult patients who required rapid sequence intubation and who met the inclusion criteria and also not met the exclusion criteria. So out of the 85 patients who were intubated, 3 patients had post-intubation cardiac arrest. So that comes about 3.5%. And in the rest 82 patients, 9 patients developed post-intubation hypertension. So it is around 11%. And the mean systolic blood pressure of these hypertensive patients was 77.78 millimeter mercury, and usually they developed this hypertension within this mean of 17.78 minutes. So we compared the different variables. So first we we compared the shock index, modified shock index, and age shock index. So the p-value less than 0.05 was taken as significant, and while comparing this, age shock index was found to have significant association with a p-value of less than 0.05. And the receiver operative characteristics curve was also plotted. Here also age shock index was the one that was found to be associated, and an age shock index with value above 49 had a sensitivity of 77.8 and specificity of 67.1 for predicting post-intubation hypotension. We also compared other variables. The variables which got significance were age, cerebral cause of intubation, pulmonary cause, and diastolic blood pressure, mean arterial pressure, and tidal volume. In this, the cerebral cause of intubation showed less chance of developing post-intubation hypertension. The others, like increasing in age, then pulmonary cause, low tidal volume, low mean arterial pressure, low diastolic blood pressure, all cause more chance of developing post-intubation hypertension. So in conclusion, age shock index better predicts post-intubation hypertension than shock index and modified shock index, and the frequency of development of post-intubation hypertension in our ED was 11%. And the factors like age, pulmonary cause of intubation, low diastolic blood pressure, low MAP, low tidal volume were associated with development of post-intubation hypertension, but cerebral cause showed a significant less chance of developing post-intubation hypertension. But this was a single center study, and also our sample size was small, so the associations was having a less validity as it was a small sample size. So the recommendation is that before intubating a patient, it is better we have to calculate the shock index, age shock index, and if the age shock index is above 49, we have to anticipate post-intubation hypertension, and we have to prepare for that, and we can start IV fluids or vasopressors if needed. And also we required multi-center studies to confirm the results of this study. Thank you.
So what were the indications of intubation in your study, 85 patients?
We included 85 patients. Indications
for intubation.
Mainly respiratory failure, then seizures, then trauma.
You didn't mention that in your study. So how we can exclude that these are the conditions which might lead to intubation, hypotension after intubation?
How we can predict?
How we can exclude that these are the conditions which may not cause hypotension after intubation? Also the ventilatory parameters, whether it is volume control mode or pressure control mode.
We kept volume control mode for all patients, but only tidal volume was
respiratory failure also? In respiratory failure also you maintain a volume control mode?
First, initially we used to keep at volume control mode.
No, not initially. You mentioned 60 minutes duration for considering hypotension.
60, not clear.
You have mentioned that after intubation up to 60 minutes if hypotension has occurred, you have considered that case as post-intubation hypotension.
Yes, ma'am.
The ventilator parameter itself may cause hypotension.
Yes.
How you have excluded that causes?
We included the ventilator parameters also for comparing. In our study, we kept as volume control ventilation for all patients, and we compared all the tidal volume, FiO2, PEEP for all patients.
Okay, I have 2 questions for you. Did you do a subset analysis of any particular group of patients? Say if you are intubating for tiring out sepsis patients versus organ dysfunction, intubation for worsening acidosis and organ dysfunction, or a head injury, physiologically normal versus the physiologically abnormal. So that is my question number 1, because he'll time my questioning. The second one is I've forgotten the question now.
The first question whether...
I don't think you understood. See, this paper is a very good paper, and if you do a little bit of analysis on this and improve on it, it is worthy of publication. Okay? But there are certain things which you need to get it very clear and out of the way of confusion. The first question that was asked was, have you ever done an epidemiological profile of the patients on whom the intubation was done?
Yes, sir.
It has been done.
Yes.
So that has to be included in a presentation like this, because we'd like to see what is the profile of the patients who came in. Secondly, you need to also show on a table that all the patients underwent a similar kind of a background, or was the ventilatory setting set differently, because any patient who shows signs of post-intubation hypotension occurring over a period of, say, 60 minutes, 60 I presume.
Yes, sir.
Okay, it's not 16.
Not 16, 1 hour.
So, when you have a patient who is intubated, who is connected to a ventilator, and over 60 minutes, you're looking at the patient if he or she is developing post-intubation hypotension. There are ventilatory reasons, there are pulmonary reasons, which means the machine can give rise to the hypotension. The patient's pulmonary system may have some innate problems within it, which can predispose the patient for hypotension. That has to be brought out very clearly. That's what both of them were trying to show you. You understood?
Okay, sir. I understood.
I just want to make one announcement, please. The internet facility has started for the virtual posters, requesting the judges of that session to please come. And those students who were waiting for the posters from their places to be presented, please join us in that hall. The hall is the same where we had our lunch.
Thank you, Dr. Sangeeta. Now we have an additional speaker for the session. This is Dr. Abhishek Kumar. He would be talking about the performance of sepsis screening tools in DKE.
And the judges are Dr. Brenda and Dr. Sandeep. So, Brenda and Dr. Sandeep, kindly help me.
Good afternoon. Good afternoon, everyone. I'm Dr. Abhishek. The topic of my presentation today is performance of sepsis screening tools in identifying infection triggers and predicting outcomes in diabetic ketoacidosis, that is DKA. DKA is the most common hyperglycemic emergency associated with diabetes mellitus. Prompt recognition and early treatment of the basic disease that precipitates DKA remains the cornerstone of DKA management. And as we all know, that infections and non-compliance to therapy are the leading two precipitating cause of DKA, as seen in many studies. But early prediction of infection is challenging in DKA, which leads to overexploitation of empirical antibiotics in the emergency department. Through this study, we tried to see the performance of various sepsis screening tools like SOFA, Quick SOFA, News, Quick News, and SIRS, whether they can predict infection or not in DKA per se. The aim was to study the usefulness of sepsis screening tools in identifying infections and prognosis in DKA at baseline. It was a prospective cohort study which was conducted in PGIMR Chandigarh for a duration of 1.5 years from July 2021 to December 2022. The inclusion criteria was kept simple. All patients with age more than or equal to 13 years of age who was diagnosed with DKA according to the ADA criteria was included in the study after due consent was taken. This is a flowchart depicting the enrollment process for the study. Once the patient was recruited, they were divided into two cohorts, that is DKA with infection and DKA without infection. Further analysis were done on various parameters like clinical features. Sepsis tools were calculated in each and every patient. They were also analyzed on the basis of baseline laboratory parameters, and serum biomarkers of inflammation and infection like ProCal, CRP, ESR was also calculated. The statistical analysis was done using SPSS version 25. The sepsis tools were evaluated for their diagnostic performance by calculating sensitivity, specificity, positive likelihood ratio, negative likelihood ratio, and diagnostic odds ratio. A total of 141 cases were recruited in the study.
out of which 51% were males. The mean age of the study population was 37 years. The patients with infections were comparatively older to patients without infection, and they also frequently had altered sensorium at presentation. As we can see, the most common precipitating factor in decay in our study population was infection, which was seen in a total of 62 patients. The other two more common precipitating causes were non-adherence to the therapy and non-infectious disorders like CVA, MI, etc. This is the table which gives all the infections which were seen in our patients. Out of the total 62 infections seen, 32 were microbiologically confirmed, and pneumonia and UTI were the two most common infections seen in the study population. When we compared the baseline sepsis screening tools for prediction of infection, we saw that SOFA and SIRS were statistically significant in predicting infections. A SOFA median score of 3 was statistically significant, and SIRS positivity of score 2 or more than 2 was statistically significant. But on multivariate analysis, only SOFA was statistically significant alongside age. So therefore, we did ROC curve analysis for SOFA score, and area under curve of 0.657 and Jordan's index of 0.2905 was found out, which yielded an optimal cutoff score of 3.5. Therefore, the cutoff of 4 or more than 4 for SOFA had specificity of 82.28% with a positive likelihood ratio of 2.6394. We also analyzed the patient cases for in-hospital survival, and the survival was 79.4%, which was comparatively lower to seen in studies done from the West, which says that the survival in DK is comparatively more than 95%. And in survival also, SOFA remained the strongest predictor of survival with p-value of 0.002. So we did univariate analysis of the various scores for survival, and we saw that quick SOFA, quick news and news were statistically significant. But again, on multivariate analysis, only SOFA score was statistically significant with p-value of 0.002. To discuss, sepsis screening tools vary widely in diagnostic and prognostic accuracy in different study populations, as seen in our study as well. As abnormal vital signs and altered sensorium are commonly seen in patients with DK, the screening tools principally based on these parameters, like SOFA, quick SOFA news, were unreliable in differentiating patients with infections. However, SOFA was the only tool that predicted infections and in-hospital survival in DK. An explanation to this might be that SOFA measures baseline organ dysfunction across 6 domains, with grading, which also consists of extreme ends of the organ failure. So a SOFA score, we suggest that a SOFA score of more than 4 can be used as bedside tool for clinical decision making and starting empirical antibiotics in the emergency department. Our study had some limitations. It was a prospective study which was conducted in Apex Referral Institute. Therefore, we cannot generalize the results to general population. And as the patients were referred from peripheral healthcare centers, they might have received antibiotics in the peripheral healthcare centers, which might have led to reduced yield of the blood cultures. We did not include euglycemic decay in our study, and the patients were only followed during a hospital stay. To conclude, the prospective study evaluated the clinical utility of baseline sepsis screening tools to identify infections and decay. Infections and non-adherence with antibiotic treatment was the 2 most common scores, and SOFA was independently a good predictor of poor outcomes in decay. Thank you.
Amongst the other predicting scores like QSOFA and News Muse, whatever, it's given knowledge that those are likely to be less sensitive than SOFA itself, because SOFA is more robust and looks at multiple organs, as you say. Keeping that in mind, what prompted you to do this study?
Sir, actually, this was a subset of my thesis which we were going to do. The main topic was whether we can start empirical antibiotics in DK or not, because there are no studies in literature which specifically sees that empirical antibiotics have a role in that or not. So we did a subset analysis. A subset of my thesis was whether these tools can predict sepsis in DK or not, because DK per se comes with shock or altered sensorium or tachypnea. So we wanted to see whether these sepsis tools can accurately predict sepsis or not.
It's more to discredit the fickle QSOFA and other than to reinforce SOFA. Is that why you prompted to do the study?
We calculated every score, that's why, to see which score is the best to predict infection.
Okay. The second thing which you didn't put up, or you might have done it. So the degree of acidosis in your DKA, was it more in infectious patients? Because there could be other reasons, if you see what I mean.
So the severity?
Yeah.
So the decay was...
DKA due to infections versus DKA due to other causes, the degree of acidosis.
Yes, sir. Surprisingly, severity was more in patients without infection. Sir, we did think about that, and a possible explanation that severe decay is more seen in young population. So we did think of that, and we are explaining that decay with younger age group had more severe cases, and infection is seen in more people with more age.
So your point well taken. My question is, since I agree SOFA predicts severe sepsis, so would you really still not give an antibiotic to someone whose SOFA score is normal, and but he has a high grade fever? Because most of the times in DK you get occult infections. So UTI is one of the most commonest infections. So would you withhold antibiotics?
So this is the dilemma which we are trying to prove. We are doing an RCT whether to give antibiotic or not. But as we can see that specificity of SOFA in our study was good, it was more than 80%, but sensitivity was around 40 to 46%, so which is low. So we will not withhold the antibiotic. The clinician judgment is the best in that case scenario. Thank you.
Thank you. Thank you, Dr. Abhishek. And I also thank the judges for judging this session. Now we have a next session where we have 6 case reports to be presented, and this session would be judged by Professor Navneet Sharma and Dr. Mandeep Bhatia. I would also like to invite the first speaker for this session, Dr. Ijaz Ahmed, who would be talking about a case of spontaneous spinal epidural hematoma. Judges, बुला लें.
Good afternoon and welcome to a brief case discussion with the title Look Before You Leap. In the next 6 minutes, I would like to discuss my case under these headings. That means these are my objectives of my presentation. Starting with background, next is case report, primary assessment and secondary assessment, investigations of choice and diagnosis, discussion and the last take-home points. Is every acute hemiparesis a stroke, either hemorrhagic or ischemic? Does it need more clinical examination before a thrombolysis? Obviously, yes. Detailed evaluation of the neurological deficit and detailed history taking are important tools for early diagnosis of a stroke, and magnetic resonance imaging is the current diagnostic method of choice. Presenting a case of spontaneous spinal epidural hematoma presented with a left arm drift to a rural emergency medicine department. Spinal epidural hematoma is a rare occurrence accounting for less than 1% of all spinal canal space occupying lesions. And spontaneous spinal epidural hematoma is the blood within the epidural space without known traumatic or iatrogenic causes. And its incidence is 0.1 in 1 lakh per year. And the source of bleeding is considered to be the internal rupture of the Batson vertebral venous plexus. Moving to the case report, that was a case of 65-year-old female. She was a known case of systemic hypertension and dyslipidemia on homeo medication, presented with a sudden onset of neck pain and weakness of the left upper limb since 1 hour. On the initial 10-second assessment, she was conscious and oriented. Moving to the primary assessment, the main issues was in the circulatory and the disability part. And the BP was 200 by 80 millimeter of mercury, and in the disability part, there is a left arm drift. Moving to secondary assessment, the symptoms was sudden onset of neck pain and weakness of the left upper limb. There was no history of any allergies and no case of systemic hypertension and dyslipidemia on homeo medication. And last meal around 3 hours back. The events are like sudden onset of neck pain during drying her hair after a bath 1 hour before, associated with sudden onset of weakness of left upper limb. She was taken to the nearby local hospital initially and referred to our center, probable chance of an acute stroke. In the head-to-toe examination, the positive findings were left arm drift and the power of bilateral upper and lower limbs were 4/5 and the left upper limb sensations and reflexes were normal and bilateral plantar was flexor. At this point, we have some differentials, that is acute stroke, either hemorrhagic or ischemic, spinal epidural hematoma, spinal epidural abscess, cervical spondylosis, and if a subarachnoid hemorrhage. Moving to the investigation of choice, that is MRI brain screen and MRI C-spine with whole spine screening. And we shifted the patient to the MRI room within 15 minutes of the ED arrival. And we have the image, the MRI brain was supposed to be normal and MRI C-spine with the whole spine screening. There is a well-defined signal intensity lesion in the epidural space at the level of C3 and C4. So that we have a diagnosis, that is acute spontaneous spinal epidural hematoma at the level of C3 and C4. So that we discussed this case with a neurosurgery consultant in a quaternary center, that's our parent center, and referred the patient in a mobile ICU accompanied by a junior doctor. And the patient posted for emergency C3, C4 laminectomy and evacuation of hematoma under GA in that center. And her had uneventful postoperative period and she was managed with IV antibiotic, IV analgesics and other supportive measure in her postoperative period. And at the time of discharge, she was conscious, alert, ambulant, continent and on oral feeds. There was no neurological sequelae. Moving to discussion part, spontaneous spinal epidural hematoma is a collection of blood of unknown origin in the epidural space and accounts for 40% of the spinal epidural hematoma. And the valvulus epidural venous plexus is considered to be the origin of bleeding. And the cause of rupture in the venous plexus is presumed to be the fluctuation in intrathoracic and intra-abdominal pressure. In adult, the most common location is the cervicothoracic or thoracolumbar junction. And the common clinical syndrome including sudden onset of neck or back syndromes and dermatomal radiculopathy, urinary dysfunction and progressive paraplegia. Acute hemiparesis is an extremely rare presentation of spontaneous spinal epidural hematoma which may be misdiagnosed as acute ischemic stroke and improperly treated with an intravenous thrombolytic agent. A correct diagnosis of acute ischemic stroke must be made within 4.5 hours from the onset of symptoms, a relatively shorter window period. And a spinal epidural hematoma is potentially important stroke mimic. The take-home points, the spinal epidural hematoma should be considered in the differential diagnosis of patient with the acute hemiparesis when associated with neck pain. Neck pain is an important red flag sign of spinal epidural hematoma that can be missed due to the predominance of the weakness. Hence, clinical suspicion and detailed examination is important in diagnosing spinal epidural hematoma. In a rural center, a case of acute hemiparesis with no cranial nerve deficit, considering intravenous thrombolysis with recombinant tissue plasminogen activator after taking a CT brain is not at all safe. If we consider such case as ischemic stroke and treated with an intravenous thrombolytic agent, that will worsen her neurological deficit, progressive tetraparesis and even death. As Dalai Lama told, help others if you can. If you can't do that, at least don't harm them. The point of attention of my point of attention is that a case of acute hemiparesis within window period, taking a CT brain and ruling out hemorrhagic stroke, moving forward with the intravenous thrombolysis is not at all safe, especially in a rural center, especially you have a neurology or neurosurgery backup. That I mean by look before you leap. Look into the symptoms, especially the neck pain, before you leap into the thrombolysis. I hope you understood. Thank you.
Nice illuminating case. I would be interested to know, do you know the post-surgical finding and how do you explain the arm drift, the neurodeficit? What is the, how do you explain what was happening there? And I think in hemiparesis you are fine to consider stroke, but in monoparesis of any sort, it would be very, very, very fraught with a lot of issues because monoparesis individually virtually never happens until there's a space occupying lesion pressing on a very specific area. So how do you explain this particular arm? Is it C3, C4?
Yeah.
Am I right?
This is left side, especially in the posterior side of the C3 and C4 level.
the epidural space. There was a hematoma.
What tract was getting involved? How? I am still not clear about the etiology, the mechanism of arm drift. What do you propose that was happening there anatomically?
Spinocortical tract.
Maybe, I don't know. Anyway, Mandeep, you want to?
So this patient didn't have quadriparesis.
No.
He has just monoplegia.
Yeah.
He just had monoplegia, and he was otherwise conscious oriented.
Yeah, fully conscious.
So that was a clue enough. That was the initial clue that it was not brain. Something was wrong with the cord. So I think anyone who's a bit sensible, patient who presents with monoplegia and is otherwise conscious oriented, obeying to commands, will mean the brain is fine. My question is, are you sure about this etiology? Are you sure that there is no aneurysm sitting that ruptured, her blood pressure was high? Did you work up her for her etiology, why this happened?
The exact cause of the bleeding is not at all worked out.
What he probably means is, did you investigate for a coagulopathy?
Yeah.
Or platelet counts and all, or a totem?
Yeah.
So they were normal.
Done all the normal investigation. That are normal.
Because it won't spoke. Any bleeding you have to investigate the blood. At least not at fault. And no whiplash or any sort of injury over there.
No.
Thank you, Ijas. It was an interesting case. Now I would like to invite the second speaker, Dr. Shamna Mole. She would be telling about take your probe before taking your phone, a case of peripartum cardiomyopathy.
Good afternoon all. I am Dr. Shamna discussing a case under the title Take Your Probe Before Your Phone, a case of peripartum cardiomyopathy. Peripartum cardiomyopathy is a life-threatening pregnancy-associated disease marked by left ventricular dysfunction and heart failure. It is a type of dilated cardiomyopathy. The disease is relatively uncommon, but its incidence is rising. The women often recover cardiac function, but long-standing mortality and morbidity are not frequent. It is a case of 24-year-old female with no known comorbs presented to the peripheral hospital with acute onset of dyspnea associated with orthopnea and palpitation on post-LSES day 2. Her echocardiogram revealed LV dysfunction. The patient was further referred to our hospital for further management and evaluation on post-op day 6. After initial assessment, the positive findings are there is crepitations bilaterally, tachypneic, saturation was 89 in room air and 98 in 10-liter O2 via face mask, heart rate was 116. Her head-to-toe examination shows JVP elevated and bilateral pedal edema. After the primary and secondary assessment, we came into differential diagnosis like pneumonia, pulmonary edema, pulmonary embolism, myocardial infarction, Takotsubo cardiomyopathy, peripartum cardiomyopathy. Primary adjuncts like ECG shows sinus tachycardia with no STT segment changes, and X-ray shows features of pulmonary edema and cardiomegaly. 2D echo shows dilated LV, global hypokinesia, severe LV systolic dysfunction, normal RV function, left ventricular ejection fraction of 25%, severe mitral regurgitation, mild tricuspid regurgitation, and IVC was plethoric. Laboratory investigation shows elevated liver enzyme, TROPI was positive and pro-BNP is elevated. From the clinical features, primary and secondary assessment, primary adjuncts and echo, we came into diagnosis of peripartum cardiomyopathy. Our course in our hospital was, we have started with IV furosemide and IV NTG, and a cardiology consultation was sorted out, and our patient was admitted in ICCU and treated with low molecular weight heparin, IV antibiotic, beta blocker, spironolactone, ivabradine, bromocriptine. Patient responded for the treatment and symptomatically improved. Her pre-discharge echo shows improvement in LV function. Discharge in a stable state in day 4. Discussion. Majority of the patient present in peripartum cardiomyopathy present in postpartum, mostly in a week after delivery, whereas a small subset occurs in the second and third trimester. These symptoms can be confused with those of normal pregnancy, especially of late gestation. This can be lead to missed or delayed diagnosis of peripartum cardiomyopathy and to underestimate the incidence of this condition. Echo will show ejection fraction less than 45%, LV dilatation, LV systolic dysfunction, mitral and tricuspid regurgitation, pulmonary hypertension, increased systolic and diastolic end volume. We have to look for the signs of heart failure like tachycardia, elevated JVP, hollow systolic murmur, pulmonary rales, peripheral edema. There will be signs of LV dilatation like third heart failure and displaced apical impulse. ECG mostly shows sinus tachycardia with no significant changes. Chest X-ray shows cardiac enlargement and pulmonary venous congestion. Research has suggested that peripartum cardiomyopathy is caused by vascular dysfunction triggered by late gestational maternal hormones. No specific diagnostic markers are available. Levels of brain natriuretic peptide and troponin do not normally rise in pregnancy, are typically elevated in peripartum cardiomyopathy. Management is limited to the same neurohormonal antagonists that are used in other forms of cardiomyopathy. There is no proven disease-specific therapies exist yet. Severe peripartum cardiomyopathy not improving on medical management need left ventricular assist device while awaiting cardiac transplantation or as a destination therapy. Take-home points. Point of care ultrasound is generally sufficient to differentiate peripartum cardiomyopathy from other differential diagnoses. Clinical examination reveals features of heart failure and echocardiography is sufficient to confirm the peripartum cardiomyopathy. Take your probe before your phone. Thank you.
Well, Dr. Shamna, that's a nice case that you presented. I would be very interested to see the ECG because you ran over it quite rapidly. There was a QT interval prolongation on the ECG. That was some clue that there is something going on. What are the calcium levels like in this patient?
Normal.
So they were normal. Ionized calcium?
Normal.
That was normal. There's something accounting for that QT prolongation. In that context, I just raised this. Yeah, so I raised this issue from the point of view that did you calculate the pulmonary artery pressures on echo? No.
No.
Because, the echo that you showed, even the RA looked to me to be large. And if you said there's tricuspid regurgitation and a mitral regurgitation, both.
Mild pulmonary hypertension.
Tricuspid was also there?
Yes.
They didn't report?
Yes.
Because if a rapidly done echo, you have to differentiate between something which may be pre-existing but has turned the corner because of a pregnancy state and the rigors of post-pregnancy and the volume overload, the physiological state reversing following delivery. A lot of volume is dumped down and then borderline state might get precipitated from an acute state. And did you use ACE inhibitors or were you afraid of the breastfeeding part? ACE inhibitors, AC, angiotensin converting enzyme inhibitors, no. Or you just sorted it out with NTG and diuretics and any thoughts about using NIV when such is present very acutely? No, okay.
Thank you.
I just have one comment to make. Though it looks a clear case of postpartum cardiomyopathy, since she is a young female, to get MI at this age is unlikely. And she was fine, and this thing worsened after her delivery, after her LS section.
After LS.
Yeah, but in one of your slides, you said that you rule out Takotsubo. For that, you need to do an angio. Did you did an angio? How did you rule that out?
I think that was a consideration because the ECG is not like Takotsubo. It's very specific ECG. You can spot it out.
Thank you. Now I would like to invite the third speaker of this session, Dr. Sabrina Hanifa. She would be talking about warming up to Raynaud's.
So good afternoon all. Myself, Dr. Sabrina Hanifa, emergency medicine resident, Aeme-Con, Calicut. So today my topic of presentation is warming up to Raynaud's, an unusual presentation of secondary Raynaud's in emergency room. Coming to the introduction part, Raynaud's phenomenon is an episodic vasospastic disorder typically characterized by digital vascular compromise following exposure to cold or emotional stresses. It can be categorized as either primary or secondary. Then coming to the epidemiology, Raynaud's phenomenon occur more frequently in women, particularly in younger age population. The female to male ratio is 9:1. Then coming to the background, the estimated to affect 5 to 10% of the general population, and prevalence in the emergency room is about 3 to 5%. Then coming to the case report. A 20 years old female presented with no known comorbidities presented to our ED with complaints of pain and bluish discoloration of the toes. She had history of traveling to hilly station, Ooty, 4 days back and had exposure to cold climate and cold water there. She had fever on and off for the past few days. She had pain, swelling and discoloration of hands in the past after cold exposure. No associated oral ulcers and malar rashes. No recent trauma. Then coming to the primary survey, airway was patent and breathing was also normal. Coming to the circulation part, her peripheries were cold. Coming to the disability part, her pain score was around 7 out of 10. However, her core temperature is maintained at around 97 degrees Fahrenheit. Coming to the secondary survey, ample history, nil significant other than similar episodes in the past after exposure to cold, but not evaluated. Then head to foot examination. There is bluish and purplish discoloration of toes and sole of foot, blackish discoloration of left toe. Saturation of around 85% in the toes, and left lower limb distal pulses were feeble. This is the picture during initial stages. The bluish discoloration is spreading downwards. This was the presentation at the time of hospital admission. Then after seeing this, our differential diagnoses were acrocyanosis and Raynaud's disease. Then coming to the initial workup from the emergency department, CBC was normal and ESR was 126 mm/h. DVT screening done were normal, POCUS were normal, point of care ultrasound were normal, renal function tests were normal. Then emergency room management include IV analgesics, warm blankets and IV fluids. Then sequence of events. Patient got admitted under general medicine department, blood investigation sent, 2D echo were normal, cross consultation done was rheumatology. Workup continued, direct comb tests were positive, ANA positive, serum complements were very low, and rheumatoid factor was positive. Bilateral, lower limbs, arterial and venous Doppler were normal. So the diagnosis is like Raynaud's phenomenon secondary to mixed connective tissue disorder, SLE. Managed with nifedipine, sildenafil, topical nitroglycerin, IV steroids, HCQ, ecosprin and silastazole. The outcome was the gangrene. However, even after treatment, the gangrene of the left second toe worsened and amputation done at the level of the nail bed. And the blackish discoloration of all other toes improved and patient got discharged with rheumatology follow-up. This was the picture after the treatment. The second toe, the gangrene got worsened. All other toes improved. This was around 25th day of admission. After that, at the level of the nail bed, the second toe get amputated. So coming to the discussion part, for the emergency physician, the main challenges are to achieve adequate pain control, reverse vasospasm, and maintain viable tissue. Emergency treatment can also extend to patient education and arrangement of appropriate referrals and follow-up care. Patients with secondary Raynaud's will describe attacks that are more frequent, painful, often asymmetric, and may lead to digital ulceration. Mimickers of Raynaud's include other vascular disorders such as acrocyanosis, erythromelalgia, paroxysmal finger hematoma, occlusive peripheral vascular disease, peripheral neuropathy, and excessive cold sensitivity. Coming to the take-home points, Raynaud's is a relatively common phenomenon and patients should be referred promptly to a rheumatologist to assist with differentiation between primary and secondary. The extent of the workup will be guided by a detailed history and physical examination. It is important to pursue as Raynaud's is often the earliest presentation of an underlying connective tissue disease. Patient education is a crucial part of the treatment. Avoiding sudden cold and rapid changes in the temperatures should be emphasized and should be advised smoking cessation also. Thank you. Yes, sir.
Okay. So this turned out to be a mixed connective tissue disease presenting as the first presentation. She was married or unmarried?
Unmarried girl.
Okay. Any advice you would like to do, any more investigation you would be interested to tell her? Because she turned out to be an SLE plus others. That is the mixed connective tissue disease part. Did you screen for APLA antibody, antiphospholipid?
APLA was negative, I think. Yeah, negative. We sent for the.
Okay. Because you have to do APLA at 2 separate occasions, 6 months apart. So the counsel that probably the rheumatology people will take over.
The patient, yeah.
Okay. And digital angiography was also carried out?
Yeah, done.
That failed to show any sort of thrombosis?
No thrombus and all.
Why am I saying this is because if thrombosis has been detected, then this would become APLA, antiphospholipid antibody. Even if you have a negative one, the thought here is that the antibody is so specific that all of it has been luted out in that area where thrombosis is happening. So you need to do that thing again to check it, and this has an implication as far as pregnancy is concerned later on. Should she get married?
Patient is on follow-up under rheumatology.
Yeah, exactly.
Yeah.
So that part also has to be taken care of. Emergency physicians must be aware that if not properly counseled, then she may come back.
Yeah.
So the digital angiography, did it commented on the vessel wall? Was there some kind of...
Normal only.
So if there was no thrombus and vessel wall was normal, then why there was gangrene? There must be some kind of vasculitis going on. How can it be normal? That it cannot be normal. And my second question is, did you look at his urine routine? She had SLE. Did you look for other possible complications of SLE, especially lupus nephritis?
Urine routine was also normal. Yeah, also normal.
Thank you. It was an interesting case for the emergency physician's perspective. Now I would like to invite Dr. Aishwarya K. Should be talking about acute flaccid paralysis induced by severe hypokalemia.
Good afternoon all. Myself Dr. Aishwarya and I'm an emergency medicine resident, Astromim Calicut. So I'm discussing a case of non-neurological paralysis in emergency room. So the background, muscle paralysis is an alarming symptom in emergency department. So there is always a confusion between a neurological and non-neurological paralysis that occurs mostly in rural centers. If the precipitating cause is treated, that paralysis can be completely cured. So I'm presenting a case of non-neurological paralysis which is referred from a rural center as a case of stroke. So the case report, a 40-year-old female, a non-case of hypothyroidism on medication and undifferentiated connective tissue disorder on irregular medications, and she presented with generalized tightness since 2 days, and it was followed by sudden onset of weakness of all the forelimbs since the morning of the day of presentation to the ED. So on initial 10 seconds assessment, she was very conscious and oriented. On primary assessment, the positive findings were her respiratory rate was 14 and the saturation was only 87 in room air. So we immediately started on oxygen 6 liter with face mask. And the BP was 190/80 mm mercury. And the disability part, she was not able to move all her forelimbs. On secondary assessment, 40-year-old female with generalized tiredness for 2 days, followed by acute onset of weakness of all the forelimbs. And she also had history of large quantity of loose stool since past 6 months. And there was history of grade 2 dyspnea, which was started on the day of presentation to our ED. Now non-allergies, and initially they went to a rural hospital and they misdiagnosed it as a case of stroke. And MRI brain was taken, it was normal, and then referred to our hospital. So head to foot examination, in motor system examination, the power grade was 0/5 in all the forelimbs and there was areflexia bilaterally. Sensations was intact. And we came to DDs like hypokalemic paralysis, hyperkalemic paralysis, then Guillain-Barré syndrome, and then botulism. So we done the investigations. First we took an ECG and it showed there are so many ventricular ectopics and T-wave flattening in the ECGs. And ABG was done and the pH was 7.2, the bicarb 16.8 and the anion gap was 20.8. So it's a high anion gap metabolic acidosis. So lab values, the potassium was only 1.1 and the magnesium was 1.5. And we rule out the urinary loss of potassium, it was normal only. So we came to a diagnosis that it was a hypokalemic paralysis which is secondary to a chronic diarrhea. So our ED management and disposal. Potassium correction and magnesium correction was initiated via external jugular vein, and physician consultation was given, and she was admitted in medical ICU for further management. So course in the hospital, day 1 in ICU, we continued IV and oral potassium correction, and the day 2, her power was improved. It became 4/5, and the potassium was 2.9, and then continued oral potassium. And as a part of physician's workup, they sent the serum cortisol, free T3, T4, and they were all normal. CCT abdomen was taken to rule out the cause of that diarrhea, and there was diverticulosis. And at the time of discharge, her power was 5/5, and the potassium was 4.5, and no further ECG or ABG changes, and loose stools were settled. So discussion. Hypokalemic paralysis, it's a clinical syndrome, and it is characterized by acute systemic weakness with a very low serum potassium level. And it is a rare, but it's a treatable cause of acute weakness. And during an acute attack, so measurement of serum potassium is required for both diagnosis as well as to guide the treatment. So potassium replacement is the mainstay of therapy. We can use KCl for administering. We have to avoid administering it in glucose solution, because it can induce insulin-induced potassium transfer into the cells. And 20 to 60 milliequivalents of KCl has to be infused in 4 to 6 hours in peripheral line. And for patients with severe hypokalemia due to GI loss or renal loss, the maximum rate of potassium administration is 10 to 20 milliequivalents per hour. So continuous ECG monitoring, careful monitoring of serum potassium is essential to know the response to therapy. And in most cases, hypokalemic patients are also hypomagnesiemic. So take-home points: the raising awareness about the non-neurologic paralysis in a rural setting, and thus preventing the misdiagnosis, and preventing unnecessary radiological exposure to rule out strokes in such cases, and also to save the health cost system of doing MRI for low-risk patients. Thank you.
You mentioned diverticulosis as a cause of chronic diarrhea this patient had?
Yeah, she had diarrhea for past 6 months.
That's a little unusual. Diverticulosis may cause GI bleed, lower GI, elderly people, but not chronic diarrhea. Chronic diarrhea should be having any other causes like a villous adenoma, which is excreting potassium constantly, or any other sprue, things like that. So, but the diarrhea settled. She must have received antibiotics, I'm pretty sure.
Yeah.
Something. So I think that diarrhea part is still not very clear what actually happened. And you administered central line. You gave the potassium correction, 10 milliequivalents per hour through a jugular venous line.
Through the external jugular venous, 20 milliequivalents per hour.
Okay, under monitoring, probably.
Yeah, under monitoring.
On a cardiac monitoring.
Yeah.
Okay.
Diverticulosis is diverticulitis happens in large gut, and if there is a large bowel diarrhea, that is a small volume diarrhea. That will never lead to so much of hypokalemia. So I agree with sir that this diagnosis is a bit doubtful about his chronic diarrhea. She also had acidosis. What was the reason of acidosis? Her pH was 7.2. So did you rule out renal tubular acidosis?
No, sir.
You mentioned an iron gap was normal or raised. High.
No, it was normal. Serum creatinine was normal.
No, anion gap.
Anion gap
Was
anion
raised.
gap was 20.8.
So that puts a little RTA on separately. It probably won't consider that particular issue. Any questions from the audience? Audience is pretty silent.
What is if someone has a very low potassium, let us say 1.5, and presents with quadriparesis and you've intubated because of respiratory involvement? What is the vehicle of choice in which you can give mannitol? I answered it. What do you use to replace potassium? Do you give it in normal saline? How you'll give it? You can use mannitol. You can give potassium in mannitol.
Thank you.
Thank you, Dr. Sangeeta. Now we have the next speaker, Dr. Akshata.
Good afternoon, everyone. I'm Dr. Akshata. So today we are going to discuss about Alport syndrome. Can't see, can't pee, cannot hear a bee. Alport syndrome is a heterogeneous basement membrane disease due to mutation in type 4 collagen alpha 345. The basement membrane is made up of type 4 collagen alpha 1 to 6, but due to mutation in alpha 345 leads to Alport syndrome. The major triad of Alport syndrome is hematuria, progressive nephritis with proteinuria leading to end-stage renal disease, also sensorineural hearing loss and ocular abnormalities. Alport syndrome is a rare disease where 1 in 50,000 people are affected, and it is seen in all ethnicities and races. Alport syndrome accounts for approximately 0.5% of adults and 1.7% of children with end-stage renal disease. So here we are going to discuss about a case scenario where a 30-year-old male with known case of worsening albuminuria and recently diagnosed with systemic hypertension presented with complaints of generalized tiredness and exertional dyspnea since 1 week. He also gives history of weight loss since 1 month. On initial assessment, patient was conscious oriented. Primary assessment was pretty normal, where on circulation part BP was around 140/90 mmHg. Disability part, GCS was E4, V5, M6. Pupils were bilaterally equal to light, and GRBS was 100 mg per dl, and on exposure, he was febrile. On secondary assessment, he mainly came with complaints of generalized tiredness and exertional dyspnea since 1 week. There is no history of any allergies. He was recently diagnosed with systemic hypertension on medication. He also gives a history. At the age of 12, he had complaints of hematuria, for which he had consulted renal biopsy, and other investigations were under normal limits. He also had multiple visits due to worsening of albuminuria over the last decade. His last meal was 4 hours back. He also gives a family history of CKD in grandmother and maternal cousins. On head-to-toe examination, pallor was present and bilateral pedal edema was there. We sent some investigations where his initial report showed proteinuria with microscopic hematuria, anemia of HB 5.5, elevated serum creatine, hyperphosphatemia, hypocalcemia. In the course of the hospital, where we got a renal biopsy done, which showed one viable crescent with severe interstitial fibrosis and tubular atrophy, severe glomerulosclerosis with no immune complex deposits. On electron microscope, it was suggestive of Alport syndrome as there was mutation in collagen 4 alpha 5 chain. Later, in the course of the hospital, we got an ophthal consultation and ENT consultation done. In ophthal evaluation, to see for any evidence of lenticonus, which was not there, and he was advised to do oculotomography later. On audiological evaluation, he was found to have moderate sensorineural hearing loss. Further genetic studies were conducted where he was diagnosed with X-linked Alport syndrome. Treatment, he was treated with blood transfusion, phosphate binders, antihypertensives, erythropoietin supplementation. Later, due to worsening of the renal parameters, he was initiated with hemodialysis, and later, due to worsening of the renal parameters, he was planned for renal transplantation. So, Alport syndrome is a rare disease where it has 3 forms. One is X-linked Alport syndrome, and autosomal recessive Alport syndrome, and autosomal dominant Alport syndrome. X-linked alpha 5 mutations are most commonly present with early hematuria. Male sex is the most common presentation. Autosomal recessive and dominant are equally present in both the sex, where the mutation happens in collagen 4 A3 and A4. At childhood, there will be normal glomerular basement membrane. Over the years, due to mutation in collagen 4, which leads to thinning of the glomerular basement membrane, leading to hematuria, proteinuria, and then leading to end-stage renal disease. Also, anterior lenticonus is a common ocular presentation. In some cases, both anterior and posterior lenticonus is present, for which he will be treated with refractive correction, later cataract surgery. Other presentations are corneal opacity, corneal protrusion, lenticular myopia, and retinal flex. Sensorineural hearing loss, which is not present at birth, may develop in childhood or adolescent because in the inner ear, organ of Corti is made up of basement membrane and hair cells, where due to mutation in the collagen 4, the hair cells cannot generate the nerve signals, hence leading to sensorineural hearing loss. So, my conclusion is, Alport syndrome should be one of the DDs in young patients presenting with hematuria, proteinuria, and worsening renal functions. Patients with hematuria without structural abnormality needs periodic superspecialty evaluation like ophthal and ENT evaluation. Childhood and early stage negative biopsy cannot rule out Alport syndrome. Young individuals with progressive renal failure or end-stage renal disease may often have a genetic etiology, hence genetic study should be considered. These are my references. Thank you.
So it's a nice presentation that you showed, and I'm happy to see that you followed up with the nephrology. What was the core event that made you think about Alport's or the genetically inherited disease in the first place?
Main thing is the family history, sir. We have a genetical study where we have to consider the family history. If
it was there in this particular family?
His grandmother was affected with CKD. Also, his maternal side cousins had
okay,
CKD.
so that's a very strong clue, very strong clue.
He had a childhood history of hematuria, for which he was evaluated, but he was never diagnosed. So in a local hospital, they told there might be some structural abnormality due to which he might be having the hematuria, for which he doesn't have the proper reports.
So that's what I want to reiterate for the previous speakers also. Once you've gone to the point of presenting this case at a conference, bringing it out here to different people, you have to interact with the people from other specialties also, and that's a learning objective. You need to know what actually is it that prompted your attention to bring it here and what actually turned out to be. Because you'll be surprised along the way, a lot of other things may have been picked up by people, and that's how knowledge enhances. So don't let it go just one individual case, you saw thrombosis and you referred turned out to be SLE. Find out how you have the patient contact details, you can get in touch with them. I'm sure they'll be happy to share.
I just want to make a comment. Since he had a very strong family history of his relatives having CKD, and if he was having proteinuria, I wonder why kidney biopsy was done so late. And was he started on ACE inhibitors and ARB?
Sir, actually in the childhood also he got a kidney biopsy done where it was normal in the outside local hospital. So later he they told structural abnormality. Again he was followed up in one of the hospital nearby our this thing. There also as it is which is not seen in the childhood, but later on in the adult stage the thinning of the basement membrane is seen, sir. Yes, sir.
Or it was done just
previously also.
Then there was no indication. Biopsy should have been done once he started having proteinuria.
Yes, sir. Repeated kidney biopsies were done, which never diagnosed with Alport syndrome, because the thinning of the basement membrane it starts in the adult, more in the adolescent than in the childhood. Thank you.
Thank you, Dr. Akshata. That was an excellent case with a good follow-up. Now I would like to invite Dr. Silpa S. A case, scape and snakebite patient.
Good afternoon, everyone. I'm Dr. Shilpa, Junior Resident Emergency Medicine. I'm going to discuss a case regarding sympathetic crushing acute pulmonary edema and neuroparalysis, which is an atypical syndrome overlap in snakebite. Coming to case description, a 40-year-old male patient, farmer by occupation, presented to ED with complaints of sudden onset of breathlessness since last 2 hours while waking up, associated with palpitation and sweating. Patient also noticed weakness of both upper limbs and lower limbs. Patient was apparently normal previous night before the presentation. On primary survey, patient was restless and in respiratory distress. Airway was patent. Breathing, respiratory rate was 40 per minute with a saturation of 62% on room air with bilateral crepitations. Circulation, pulse rate 130 per minute with a BP of 200 by 108 mm of Hg with a capillary refill time of less than 3 seconds. And disability shows GCS E4V4M6 with RBS 178 mg per deciliter and pupils bilateral, normally sized and normally reactive. Exposure shows hypothermia prevented and 2 fang marks separated about 0.5 mm on the dorsal aspect of the right wrist joint. Adjuncts to primary survey include ECG, it shows only sinus tachycardia, POCUS, bilateral diffuse B lines with preserved ejection fraction, ABG shows hypoxemia. After the primary assessment, we come to know that the patient is in severe respiratory distress and is in restless. So we proceeded with invasive positive pressure ventilation with definitive airway management. Along with, we started the patient on NTG, 1000 microgram bolus over 2 minutes for BP management, followed by infusion of 100 microgram per minute. The target BP we kept was systolic of 140 mm of Hg. Secondary survey, there is no history and examination suggestive of any cardiac disease, no history of snake bite. Local examination revealed 2 fang marks 0.5 mm apart above the dorsal aspect of the right wrist joint, and there is no swelling, blister or any regional lymphadenopathy. Systemic examination, respiratory system bilateral crepitations was present with CNS power of 4/5 all 4 limbs, ptosis was present, deep tendon reflexes were diminished with sensory examination was normal. Other systemic examination was also found to be normal. After primary survey and secondary survey, we get to know that the patient had a snake bite. So we had done one whole blood bedside clotting time. The clot was retrieved within 20 minutes. After assessing the primary survey, clinical examination, we combined the diagnosis as sympathetic crashing acute pulmonary edema and neuroparalysis, which is secondary to snake bite. Treatment, the positive pressure ventilation continued along with injection NTG as dose mentioned earlier. Along with patient was started on anti-snake venom, 10 vials IV stat as an infusion over 30 minutes, and we wait for 1 hour after ASV. There is no improvement after 1 hour, so we repeated the second dose of ASV. And considering the neuroparalytic snake venom, we started the patient on injection atropine 0.6 mg along with neostigmine 1.5 mg IV stat, followed by 5 doses every 30 minutes, then at 1 hour, 2 hours, 6 hours and 12 hours. Monitoring include BP monitoring every 5 minutes and recovery of neuroparalysis as the patient is intubated. We monitor the patient by hand grip and ptosis, which was done every 30 minutes, and WBCT monitoring was done every 1 hour for first 3 hours, then 6 hourly for 24 hours. Coming to disposition, this patient was admitted in emergency ICU after 3 hours of ED stay. Patient got extubated after 3 days of intubation and was shifted to ward after 4 days of ICU stay, and patient was discharged on day 8 of hospital stay. In WHO, clinical syndromes of snake envenomation include neuroparalytic, vasculotoxic, myotoxic and progressive painful swelling. The autonomic dysfunction following snake envenomation is not included in the WHO clinical syndrome. The mechanism behind autonomic dysfunction is still not clear. The possible mechanisms are neuromuscular blockade at bulbar level. It may be due to elapid neurotoxin, which inhibits the presynaptic alpha-2 adrenoreceptor, which results in blockage of inhibition of release of norepinephrine, results in sympathetic overactivity and parasympathetic decreased stimulation. What literature states? Severe hypertension, tachycardia and abdominal pain following neurotoxic snake envenomation was reported in various literatures, but SCAPE following neuroparalytic snake envenomation was not reported yet. So still to be continued, SCAPE subsequent to dysautonomia in snake envenomation and ASV in SCAPE secondary to snake envenomation is also doubtful. What are the take-home messages? We should follow stepwise approach. That means in this case, there is no history of any snake bite. So after proper primary assessment and after proper exposure, we get to know that patient had a snake bite, and clinically significant and striking dysautonomia can rarely occur in elapid neuroparalytic snake bites. So maintain a high degree of suspicion in cases of presentation with breathing difficulty following snake bite. Always look for combination of syndromes, like in this case, SCAPE secondary to dysautonomia with neuroparalysis. Early recognition may influence the overall morbidity, mortality, and altering the treatment decision. Thank you.
Did you do an echo on this patient? Echocardiography?
Yes, sir.
What were the echo findings?
Echo shows preserved ejection fraction with bilateral diffuse B lines on lung focus examination.
Okay, so you found 2 fang marks, but there were no local signs. There was
local signs are
so
seen.
it looks more like a crate bite.
Crate bite, sir.
Okay.
Thank you. Thank you, Dr. Shilpa. We have the last speaker for the session, Dr. Selva Amina. She would be talking about an interesting topic for the emergency physicians, very less seen in this part of the country, regarding high altitude illness.
Good evening, everyone. My topic is high altitude illness, the insight into pathophysiology and treatment. Here is my case description. There is a 72-year-old female came to ED who is a known case of type 2 diabetes with complaint of shortness of breath since 2 days and chest tightness for 2 days. Primary survey showed there is tachypnea and saturation was 85% on room air and bilateral coarse crepitation which is improved to saturation of 97% with NRBM with 10 liter per minute. Other than that, primary survey was unremarkable. History of presenting illness, the patient is a resident of Gujarat, came to Uttarakhand for Chardham Yatra, which is a pilgrimage yatra to Kedarnath, which is situated at 3,581 meter upper. There is a history of rapid ascent to an altitude of 3,133 meter in a single day by road. Then patient developed complaint of shortness of breath, chest tightness and increased tiredness. Then patient was shifted to the base camp next day morning and given oxygen. As the symptoms was not improving, patient was referred to Ames Rishikesh. On the POCUS, lungs showed bilateral group B lines with minimal shedding and cardiac ejection fraction was adequate, no RRV dilatation noted. ABG was showing hypoxemia and lactic acidosis and ECG was showing sinus tachycardia. Bedside chest X-ray showed bilateral patchy fluffy infiltrate and after stabilization we got an HRCT thorax done which was showing bilateral symmetric alveolar interstitial opacities with relative sparing of apex and peripheries, which is suggestive of non-cardiogenic pulmonary edema. The course and treatment, a provisional diagnosis of high altitude pulmonary edema was made in ED and patient was treated with MOIS-O2 supplementation along with NAV support for tachypnea and tabnifedipine 30 mg extended release BD was given along with IV antibiotic. Serial chest radiograph showed clearance of infiltrate and patient discharged in stable condition on day 7. There is another patient who is a 58-year-old gentleman came to emergency with increased tiredness for 4 days, difficulty in breathing for 3 days and altered sensorium since 2 days. This patient, airway was threatened and there was tachypnea and low saturation. Then the patient was intubated with 8 mm of ET tube for airway protection, and GCS was E3V2M5. On system examination, respiratory system showed bilateral coarse crepitation, and patient was moving all 4 limbs in response to pain equally. This patient is also came for Chardham Yatra, and there was a history of ascent to Yamunotri, that is 3,235 meters via airlift. Then patient developed headache, increased tiredness, difficulty in breathing, which was progressed to altered sensorium in view of irrelevant talk and not recognizing family members. Then the patient was taken to base camp next day morning and taken to AIMS Rishikesh via airlift. In the same patient also, POCUS was showing B profile and cardiac ejection fraction was adequate. ABG was showing hypoxemia and lactic acidosis. A provisional, we got an NCCT head and HRCT thorax for this patient. NCCT head was showing diffuse cerebral edema and HRCT thorax was showing bilateral ground glass opacities. There is a provisional diagnosis of high altitude sickness with high altitude cerebral edema and high altitude pulmonary edema was made, and patient was treated with ventilatory support, IV dexamethasone 8 mg stat followed by TDS and tab nifedipine 30 mg extended release. And patient improved with treatment, and serial chest radiograph showed clearing of the infiltrate and extubated on day 4 and discharged by day 7. To know why this happened, we have to know what is a high altitude physiology. There is a term called hypobaric hypoxia, that is PO2 is, we all know that PO2 is the driving force for the diffusion of oxygen. So as the height increases, barometric pressure decreases and oxygenation diminishes, as we can show in this figure. So body tried to acclimatize to this by increasing ventilation. As ventilation rises in response to hypoxia, PaCO2 falls and pH rises, causing respiratory alkalosis. So the partial renal compensation occur by this by excreting bicarbonates. So the respiratory alkalosis reduced and patient can ventilation can continue. Pathophysiology of HAPE, there will be hypoxia which will cause hypoxemia, which cause increased cerebral blood flow, which is causing increased capillary blood pressure in the brain. Along with that, there will be increased cerebral blood volume and increased permeability of blood-brain barrier, which is causing brain swelling, which will cause inadequate buffering of CSF, which will cause acute mountain sickness. If it is not prevented or adequately treated, it will progress to high altitude cerebral edema. Going to pathophysiology of HAPE, there will be alveolar hypoxia, which will cause rise pulmonary hypertension, and increased capillary pressure, which will cause endothelial stress and capillary leakage, causing high altitude pulmonary edema. The treatment for the acute mountain sickness, we will suspect when there is headache along with loss of appetite, nausea, vomiting, lethargy, sleep disturbances and dizziness. At this condition, simple pain medication along with stop of further ascent can decrease the symptoms. If the symptom worsen or no improvement, descent is advised and patient should be treated with oxygen, which is low flow oxygen, and 8 mg IV dexamethasone. If the patient is not able to take orally, other than we can give oral dexamethasone if the patient is conscious. HACE is diagnosed when there is severe headache, incoordination, behavioral change, hallucination, ataxia, confusion and lower consciousness is there. Descent is advised at this stage. Patient should be supplemented with oxygen and dexamethasone. If the patient is not able to descend at this point, we can provide Gamma bag, which is a portable hyperbaric bag which can simulate a descent of around 2,500 meters. And HAPE is diagnosed when the patient came with breathing difficulty, reduced exercise intolerance, cough and sometimes sputum production. At this point, descent and high flow oxygen supplementation should be given, and patient should be keep warm, and 20 mg nifedipine sustained release should be given. Increase in number of people traveling to high altitude either for work, pleasure and religious purposes increasing nowadays, and residents of low altitude are susceptible if acutely exposed to high altitude. Differentiating HAPE from other elements such as acute decompensated heart failure or pneumonia is difficult, and in such condition usually HAPE will be patient will be more severe and more hypoxemic compared to these patients. This will worsen without treatment, and severe dyspnea and frank pulmonary edema are obvious with coma and death following. So timely recognition and treatment is critical, and early signs and symptoms should not be missed. Thank you.
Well, that was quite a crash course you gave us on both this thing. My point here is that normally these the yatras and all are undertaken with fitness which is just in a resting state. Am I right? This is what they did for the other Amarnath Yatra also. And very unfit people also tend to go up on this yatra for whatever reasons that they in their mind that, and that is something, the fitness part is something that could be looked at people undertaking this particular, stress. The second question I have for you is the first patient. Did you screen them for COVID, influenza?
Yes, sir.
Because he
COVID
improved.
RT-PCR was taken for
And influenza?
It was negative, sir.
So both, they didn't have any viral infection. So that would be paramount to exclude, because that first patient did look like could be having some sort of a virus induced. Anyway, a good presentation nevertheless.
I have 3 questions for you. First question is, for how long did that patient stay at high altitude? Did he stayed overnight?
So the first patient stayed overnight and the second patient 2
Okay.
days. Initially that patient had increased tiredness only.
Okay, my second question is, at what altitude, what altitude all this starts, and what will you advise to someone who's going to high altitude? And what you like, Shimla is 2,000 meters above sea level. People go up and down, especially for North Indians like us. So at what altitude you should warn someone?
So usually high altitude cerebral edema mostly seen at about 2000 meters and high altitude pulmonary edema at a height of 2500 meters. But this 2 patients developed the symptoms after 3000 meters only. And both of the scenario there was history of rapid ascent. First patient there was a ascent to 3132 meter in single day, and the second patient was ascended by airlift. Both are like rapid ascent. So the patient is getting rapid ascent are more susceptible to these symptoms. So taking breaks in between will be effective in this condition. And
Any medications?
yes, sir, acetazolamide 125 mg BD can be given this patient, which will help to alleviate the symptoms.
Thank you, Amina. Now we have ended this session. We'll have a short break of 5 minutes where you can go have some chai samosa. And we'll okay, we have the ABG labs by Dr. Atul Saroj after 5 minutes. Okay, everyone can have a short break and come back.
last slide. So starting off, how is pH calculated and acid-base balance is maintained? So if we see a Hasselbalch equation, pH is equal to pK of log of bicarbonate divided by PCO2. So if you see here, the pH is directly proportional to bicarbonate value and inversely proportional to PCO2 value. And how this balance is maintained by equation of CO2 plus water, that is bicarbonate, and it dissociate into hydrogen ion and bicarbonate ion. So if we remember our basic chemistry that we have learned in 11th and 12th classes, the bases will be started with bicarbonate and acid will start with CO2. And this balance is maintained by normal bicarbonate balance, that is called metabolic component, is maintained by kidney by retaining bicarbonate, and lungs maintain mainly respiratory balance by excreting PCO2 in exchange of oxygen. So this is a basic mechanism which helps to keep the pH within normal range. So if we, before analyzing any abnormality, we should know exactly what is the normal. So here I have comparatively given both the values of arterial as well as venous blood. So pH, arterial venous blood has high CO2 around 41 to 51 and low PO2, and bicarbonate is roughly equal in the both the terms. This will help you identify whether your sample is equally good or it is arterial sample or BVJ sample, sometimes when there is mismatch between patient condition and your blood gas values. So normal pH is 7.35 to 4.5. More you go away from 7.45, it will land into alkalemia, and lesser than 7.35 acidemia. So basically I will discuss just basis of for simple acid-base disorder, metabolic acidosis, where there is decrease in pH value, increase in hydrogen ions, and the compensation is by decreasing PCO2, that is respiratory component, and metabolic alkalosis by increasing pH value and increasing bicarbonate and increasing PCO2 is a compensatory response. So that will be learned in the next slides. So my plan of action is, first of all, we should identify what is the primary disorder, how is compensatory response, anion gap calculation and disease responsible for that, and what is the treatment. So starting with what is a primary disorder, we should compare pH, bicarbonate and PCO2 value. Now I start to learn by example. Suppose patient has pH of 7.5, bicarbonate is 17 and PCO2 is 24. So if we see the predominant change is there is increase in pH value, that indicates toward alkalosis, and there is decrease in bicarbonate value, that indicates toward the acidosis component. And if we see respiratory, there is decrease in PCO2, that indicate alkalosis. So what is the predominant change, which the change in which the pH value is reflected is increased pH, that lands to alkalosis, and decreased PCO2, that land to alkalosis. So it is a mainly respiratory alkalosis. Just in ABGA, if you learn that CO2 indicates toward acidic component and bicarbonate indicates toward the alkaline component. Increase in bicarbonate means alkaline, pH is turned toward alkaline, and increase in CO2 means there is acidosis component. So these are, we have to check pH and then see which component has a trend toward the pH. But if both parameters, that PCO2 as well as bicarbonate, are both contributing in same direction, see in this patient, this example, pH is 7.52, means pH is indicating towards the alkalosis side. Is it clear? Bicarbonate is, increase in bicarbonate is 36. Okay. Normal I have shown you, it is 22 to 24. Okay. So it increases towards the, indicate toward the alkalosis, and PCO2 is dropping down from 40 to 32. So it indicates toward the alkalosis. So how you know, you will decide what is the primary disorder. So you will see the change from baseline to our values. which component has bigger change is main contributing factor. So if we see the bicarbonate value that has changed from 24 to 36 and PCO2 value is from 40 to 32. So if we see the change of bicarbonate is more as compared to the change in carbon dioxide component. So it will be a primary bicarbonate indicate toward the metabolic component, so it is a metabolic alkalosis. Okay, so everybody is clear with this. If the pH as well as CO2 and bicarbonate are indicating toward the same side, then the component which is making big difference is primary disorder. But if situation is like this, similar example, decreased pH, decreased bicarbonate, increased PCO2. So all are in same direction. So we have to see what is the biggest difference from the baseline. So here the biggest difference is carbon dioxide more than bicarbonate, so it will be a primary respiratory acidosis. So up till now you will clear how to identify primary disorder. Then the prediction of compensatory response of acid-base disorder. So this is just a slide to show that how component of one side will try to compensate metabolic acidosis by decreasing PCO2, metabolic alkalosis by increasing PCO2. If you are not able to remember this also, then you can keep this in your app and you can calculate from app itself. This is just a theoretical how the compensation are done. Why there is, if you see the respiratory component, there is two components, acute and chronic. Because respiratory pattern will be changed immediately whenever there is metabolic acidosis or metabolic alkalosis. But metabolic component takes time to change. So whenever there is respiratory disturbances, metabolic component will be turned into either acute or chronic. So learn by example, if metabolic acidosis, then the compensatory response according to PCO2 should be 1.5 into bicarbonate plus 8 plus minus 2. So if our bicarbonate value is 12, means patient has roughly metabolic acidosis. So how much PSC2 should be? It should be 1.5 into 12 plus 8. So it should be around 26 plus minus 2. Means if our bicarbonate is decreasing, then our body respiratory system try to hyperventilate to remove the CO2 from the body, and that will come to around 26. Now if our bicarbonate is 7, it is again severe type, and then what the expected PCO2 is? 1.5 into 7 plus 8, simple mathematics, it is around 18.5 plus minus 2. So this is simple compensatory response for metabolic acidosis. And metabolic alkalosis, the PCO2 will, in metabolic alkalosis what happens? There will be increase in pH value and bicarbonate will be try to increase. So our body will start to retain the PCO2 to compensate for that metabolic alkalosis component. So PCO2 will be increased by 0.7 millimeter mercury per 1 milliequivalent increase in bicarbonate. Yeah. So if we see the patient has bicarbonate around 35. So it is indicating toward the increased bicarbonate means metabolic alkalosis. So if we see the increase in bicarbonate from baseline is around 11. Okay, 35 minus 24 baseline value. So how much PCO2 should be increased? Okay, so expected increase in PCO2 is around 11 into 0.75, means PCO2 will increase by 0.75 millimeter mercury per milliequivalent increase. So equivalent increase is around 11. So if we multiply by 0.75, then it is 8.25. Then expected total PCO2, because this is just an increase, then the baseline is 40, then expected PCO2 is around 48. Another example, if bicarbonate is 40, still metabolic alkalosis, so increase in bicarbonate from baseline is around 16, Then expected increase in PCO2 is around 16 into 0.75 is equal to 12. So expected total PCO2 is around 52. So this is simple mathematics calculation. Just you need to understand the line that the PCO2 will increase by 0.75 millimeter mercury per 1 milliequivalent increase in bicarbonate value. So this is a, if you have this statement with you, then you will able to easily calculate your expected carbon dioxide value. Now we give other example of acute respiratory acidosis. Okay? Likely we see in worsening of COPD patients, okay? Patient who is on sedatives with decreased respiratory drive. So here the bicarbonate will increase by 1 milliequivalent per 10 millimeter increase in PCO2 value. So if PCO2 is 55, so increase in PCO2 is around from baseline to is 15. So per 10 millimeter increase in PCO2 will increase the bicarbonate around 1. So how 15 millimeter increase in PCO2, the increase in bicarbonate is around 1.5. So this is a simple mathematics. Just you have to mug up either this statement, or you have to keep this pasted in your emergency, or you can keep this in your mobile as in the form of app also. Okay? So you will easily able to calculate expected bicarbonate should be around 25.5. So if PCO2 is 80, so increase in PCO2 from baseline is around 40, and per 10 millimeter increase in PCO2 will increase bicarbonate around 1. So here that 40 millimeter should increase bicarbonate around 4. So expected bicarbonate should be around 28. Similarly, in chronic respiratory acidosis, there should be increase in bicarbonate 4 milliequivalent per 10 millimeter increase in PCO2. So if PCO2 is 55, increase in PCO2 is around 15, and for 10 millimeter there should be 4 increase in bicarbonate of 4 milliequivalent. So if in 15 millimeter there should be around 6 milliequivalent increase. So expected bicarbonate is around 30. So this is simply mathematical calculation. So what if PCO2 is around 80? Anyone can guess? Is everyone alert or just sleeping? I expect answer from some audience. Huh? 32. So increase in PCO2, how much increase should be there? 40. So for 10 millimeter increase, there should be increase in 4. For 40, there should be increase around 16. So we will 24 plus 16, it should be 40. So expected bicarbonate should be around 40. And acute respiratory alkalosis, bicarbonate should decrease by 2 milliequivalent per 10 millimeter decrease in PCO2 value. Okay, so if PCO2 is 25, decrease in PCO2 from baseline is around 15. So for per 10 millimeter decrease in PCO2, there should be decrease of bicarbonate around 2 milliequivalent. Okay, so how much decrease we have? We have decrease of around 15. So for 15 millimeter increase in PCO2, decrease bicarbonate should be around 3. So expected bicarbonate should be around 21. Okay. So what if PCO2 is around 20? Answer someone. If it is 20, then there should decrease in PCO2 is around 20. So per 10 millimeter decrease in PCO2, bicarbonate should be decreased around 2. For 20, it should be decreased around 4. So we should have bicarbonate around 20. Okay? So it is a simple mathematics, just to be afraid of that how it is compensated. Okay? Now next slide should be of anion gap. Okay? The anion gap we consider as sodium plus potassium minus chloride plus bicarbonate. Why there should be an anion gap? Is someone able to understand? In our body, the balance is maintained between positive ions and anions. Okay? Because we are neutral. If there is any anion gap in reality, then we should be charged. Someone touching us, we should be current. They should be current. So why then it should not be equal? Because some part of our body has a protein, phosphate, citrate and sulfate. This is negative component which is not reflected in actual values. So what is anion gap is just showing this value, some protein, phosphate, sulfate and citrate. Okay. This small, that is normally equivalent to 10 to 18 millimole per liter. Okay. That is normal anion gap. But if there is some disturbance in our body or someone has taken toxin where there is accumulation of more negative anion, then by this anion gap try to increase. Means if this if you see if this gap try to increase, slide change करना उसमें ना one side back पीछे हाँ this anion gap if someone has taken formaldehyde or ethylene glycol or there is septic shock with lactic acidosis, then more negative ion will try to increase in this component, yellow component, and then it means our anion gap will increase with this. So we have differentials of anion gap, raised anion gap with normal anion gap. Raised anion gap is seen in lactic acidosis, ketoacidosis, renal failure. There are mnemonic also for this that you can, and normal anion gap is renal tubular acidosis, diarrhea, adrenal insufficiency and ammonium chloride ingestion. So start with the case that I have told in first slide. The patient of 46-year male admitted with pain abdomen, vomiting and vision loss, ABJ of severe metabolic acidosis with normal blood sugar level. So patient has anion gap around 24. So it is a high anion gap metabolic acidosis with hint of vision loss. So it indicates toward that patient has, thank you ma'am. Yeah. So patient has anion gap is around 24. So high anion gap metabolic acidosis with indication in the form of vision loss, then it is likely poisoning with formaldehyde, or in North India we call that as desi daru. They locally made wine that can lead to this. So next small component around arterial A minus A gradient. So what is this A minus A gradient? If you see that the A is alveolar PO2, means it is the average value of oxygen around all alveoli, and PO2 is in the arterial blood. Okay? So PO2 value we have measured with the arterial blood gas value. But how PO2 is measured? PO2 is measured by the formula FiO2 into 7.13 minus PuCO2 into 1.2. This A minus A gradient is helpful in condition where there is diffusion and perfusion mismatch, where there is any etiologies in alveoli component, lung pathologies, especially hampering the diffusion of carbon dioxide from through alveolar spaces, then this alveolar A minus A gradient will be low. Normal A minus A gradient is less than 20 millimeter of mercury. The high gradient is seen in pulmonary embolism, ARDS patients and all these components. So now the basic ABG sampling and technique. So before sampling we should need what are the contraindications, why there is the need of arterial blood gas. Contraindication, whether there is any local inflammation or whether there is any circulatory insufficiency in that arm. For that we have to check the ulnar artery and see the circulation. Then detailed therapy and respiratory support on which the patient is in should be written on the lab request form, so that we will able to and explain the procedure to patient and suitable sites. This is just a component how to do the arterial blood gas. Then perform a modified Allen test to know the circulatory sufficiency, position the patient hand as shown in this slide, then identify the radial artery, remove the heparin if you have taken for this anticoagulation, steady hand, okay? And if the blood is coming automatically, then it is likely to be arterial. But if you have to you have to take a force to draw your blood, then it's likely to be a venous blood. This is just a hint to separate that whether you have taken arterial or venous blood gas sample. After sampling, remove the needle and apply firm direct pressure to the sample site for at least 5 minutes. Remove all the sharp and discontinued. So, what are the clinical application of this ABGA are in suspected case of hypercapnia where patient has COPD with respiratory failure. You have to decide whether you should give oxygen support or you should give NIV support for these patients. That should be depend upon your pH and PCO2 value. If your patient is landing up in respiratory acidosis, then you have to start with BiPAP support. Patient drowsiness with flapping tremors, landing up into CO2 narcosis, there your NIV support will not help as patient sensorium is not okay. So you have to intubate the patient, hyperventilate, and then again start. Diabetic ketoacidosis, where you have to check the anion gap, see the adequacy of your insulin supply, check the potassium level. Toxicological emergency, just I have explained you, and in suspected case of severe hypoxia, where there is not able to draw blood sample, not able to record a saturation on your pulse oximetry and in carbomoxin level. Okay, so these are just clinical application of your ABGA. Okay, so now I will distribute cases among students, and after 10 minutes we will start to analyze and see the response of student, how they are able to identify. Okay, I will just this slide will be there so that you can check whether your for compensation, whether it is okay or not. Give 1 to 2%, I think. 30 cases are there, so you can. Write your answer, whatever your answer is. Huh? No, this is not an exam, yaar. You don't need to write your name. Just you write your impression. Okay? Just for hint that how much I am able to communicate my. तुम्हारे पास नहीं. You should share with someone because I have just made 30 cases. I don't know which. Is it okay? So should we start? Or if we... You can take photo of this if you want to retain. No, I will change the slide. If who has not done takes the snapshot. So starting with the first case, this is first case of 25-year young male who has a fever with respiratory symptoms. See, so clinically the impression is likely case of community acquired pneumonia. Saturation on room air is 89%. If we go by his ABGA, then pH is around 7.50 with PCO2 value is around 28.1 and PO2 value is around 57.8. Okay, so if we see the patient has decreased oxygen saturation level, decrease in PO2 value. Okay, the PO2 value is around 57.8 and saturation is 88.7% on room air. Okay, so if we see that it is likely type 1 respiratory failure. So what is his acid base status? Is it metabolic or respiratory? Respiratory alkalosis, good. Or is it compensated or non-compensated? I have put a formula here also. So it is compensated or non-compensated? It is not able to compensate because your bicarbonate is just around 23.9 and should be patient which should be shown supplemental oxygen. Yes, because his saturation is low and his pulse oximetry is suitable to ABGA for repeated monitoring. That is also okay because we just need to check a saturation level. So patient has type 1 respiratory impairment because there is decrease in PO2 value, respiratory alkalosis because pH is 7.5 with PSO2 decreasing to 28.1. Okay, so now will we go to the second case, 34-year-old morbid obese lady. You just get hint by looking morbid obese with ABGA done for just a pre-operative assessment. So pH is around 7.35 with PCO2 value around 54.8. So PSO2 is increasing trend with saturation around 72.2 and millimeter of mercury PO2 value and saturation is around 96%. So if we see the patient has raised PCO2 but pH is maintaining just a normal value around 7.35, just a acidotic component. So it is likely which type of failure? Type 2 respiratory failure. Okay, so it try to compensate by increasing the bicarbonate value because it increased from 24 to 29. So bicarbonate increase by should be 4 milliequivalent per 10 millimeter increase in PCO2. So PCO2 increase here is around 14. So bicarbonate should increase around 5 to 6. So it is compensated respiratory acidosis with type 2 respiratory impairment that is likely due to morbid obesity. Okay. Now the third case, this 24-year-old female nursing student, she just flew, she does air travel and now she has present with respiratory symptoms with tachypnea and maintaining saturation around 95. So this is her ABGA, pH is around 7.51 with PCO2 around 29 and PO2 is around 77. So what do you think? Is saturation and PO2 is normal? Saturation is less than normal and PO2 is also less. especially when patient has PCO2 value is around 29, means she is hyperventilating, but still her saturation is not above 95%. So it means something is missing. So she has just a, if we see ABGA, she has a type 1 respiratory impairment, but it is mild with marked hyperventilation. She is hyperventilating and uncompensated respiratory alkalosis because there is increase in decrease in bicarbonate is not appropriate as per the PCO2 value. But other component is patient has increase in A minus A gradient that I have shown you in the last slide. Okay? So there is difference between alveolar and arterial oxygen concentration, and it is around 38 millimeter of mercury. So this just a formula you have to just calculate, but I just indicate that this type of ABGA should not be missed in emergency. You have just one hint that your patient is hyperventilating, means has PCO2 has decreased to 29, but still she is not able to maintain normal saturation. So this is a one hint that if with such a PCO2 level she is not able to maintain normal saturation, it means something is abnormal is there in the lung. Okay. Then this is a gentleman of 78-year-old is admitted in surgical ward where he has given for pain repeated injection of morphine, and now he landed in respiratory failure. So if you see pH is around 7.18 and PCO2 is around 62 millimeter of mercury. So which type of respiratory impairment? Which type of? आंसर यार सिंपल है, टाइप 2 रेस्पिरेटरी इंपेयरमेंट हो गया, मॉर्फिन दिया, रेस्पिरेटरी सेंटर्स डिप्रेस हो गया, पेशेंट CO2 रिटेन करने लगा है. सो इट इज कंपनसेटेड और अनकंपनसेटेड? अनकंपनसेटेड. क्या बताया था मैंने तुम्हारे को कि मेटाबॉलिक कंपोनेंट विल टेक टाइम टू एडजस्ट. ऐसा नहीं, रेस्पिरेटरी कंपोनेंट विल एडजस्ट फास्ट. मेटाबॉलिक एसिडोसिस होने लगा डीके में, पेशेंट सडनली हाइपर वेंटिलेट करने लगता है. आपने क्लिनिकली भी देखा होगा, you have seen in clinically also. But in case of respiratory, if there is respiratory acidosis, metabolic component will try time to adjust. So if you see his bicarbonate value, instead of increasing, it is decreasing to 22.4. So patient has respiratory type 2 respiratory failure with uncompensated respiratory acidosis. So likely due to morphine that led to morphine toxicity. So what is the treatment for that? Opioid and antagonist, naloxone. So this is 75-year-old male, just a diagnosed case of COPD, as giving the history of COPD by patient's relative. Okay. If you see the impression wise also, he has a pursed lip and all these things. So if see his ABGA, pH is around 7.40, PCO2 is around 36. It is increased or decreased? Okay. And PO2 is around 44 millimeter of mercury and saturation is around 80%. So what is it, type 2 or type 1? It is type 1. Although he is COPD patient, but is not able to maintaining saturation and CO2 is less. So it is a type 1 respiratory failure. Whether it is compensated or uncompensated, or what is normal pH value is normal, pH value is normal, there is no acid base disturbances here, only there is type 1 respiratory impairment. So should we give oxygen to this patient or not? You should give oxygen. You should not taper the oxygen of all COPD patient. Sometimes but we try to taper the oxygen so that patient should not accumulate PCO2. But here if we see in ABGA, PCO2 is already low, and is not maintain the saturation, then you have to supplement oxygen. But what happens sometimes, you have given oxygen, you have started on steroid, antibiotic, but still patient is not improving, and now he has pH around 7.29 with PCO2 value is around 52. and bicarbonate is around 24. So what is happening now? What happens now? Which type of respiratory failure? Type 2 respiratory failure. Is it compensated or uncompensated? It is uncompensated because bicarbonate is normal 24 and pH is around toward the acidotic side. So it is type 2 respiratory failure with uncompensated respiratory acidosis. Okay? So should the oxygen now be stopped? What is the treatment now? What is treatment? Patient is exhausted, confused. Should we give NIV or intubate? Intubate. As his sensorium is not okay, he will not able to tolerate NIV. Okay. So this next case 7, similar patient, he is improved. You have intubated, you have removed his PCO2, extubated, and after 3 months, he is maintaining saturation around 87%. So this is his ABGA, pH around 7.42, PCO2 is now 5 kilopascal. I think they omitted the millimeter mercury. So it is in the normal range, okay, with saturation around 87%. So what is your take? Which type of respiratory failure now again? Type 1 or type 2? Type 1 respiratory failure, okay? And pH is maintaining between 7.35 to 7.45, so normal acid base, and he required long-term oxygen support because he is not able to maintain oxygen in his home. So the next case, this is 77-year-old woman admitted in stroke ward with right side weakness, and she is examination agitated, distressed. Her chest X-ray is showing infiltrate in the both the lungs, saturation around 92%. Okay, so this is her pH around 7.4, PCO2 around 33, and PO2 value 65. Which type of respiratory impairment? Type 1, and pH is within normal range. So it is type 1 respiratory impairment with normal range pH, but there is mild respiratory alkalosis due to hyperventilation, that is likely due to acidosis due to this lactate and increase. So this 68-year-old COPD patient, okay, suddenly worsened and landed in an emergency with ABGA SST of pH 7.36, PCO2 value around 54, saturation 75%, and PO2 around 40 millimeter of mercury. What type of respiratory failure? Type 2 respiratory failure, because PCO2 is increasing and its pH is around acidotic side. Okay. So this is type 2 respiratory impairment. So now I will just, because the time is already overshooted for 5 minutes, I will rush 1 or 2 important cases that I just want to show you. This lady, she is 21-year-old, diagnosed case of bronchial asthma, admitted in respiratory failure with polyphonic Bs, maintaining saturation 96% on room air, pH is around 7.38, PCO2 43, and saturation around 96%. She is able to maintain saturation, but her PCO2 is increasing. So if any bronchial asthma patient has increased in PCO2, it means her efforts are exhausted. So you need to immediately intervene in these type of patient. So she has a mild type of respiratory type 1 respiratory impairment, and the PCO2 is high, and that indicate toward the life-threatening attack. So if any bronchial asthma patient and you have done ABGA and this showing increased PCO2, then you rapidly start his respiratory support. So this 23-year-old, she has a fracture, she has a normal X-ray, she has a pain in the lower limb, and then after that she is crying, hyperventilating, and the pH is 7.53 with PCO2 is 24 and PO2 is around 108. So which type of respiratory failure is this? Is there any respiratory failure, or this is just a hyperventilatory response? And then this patient developed paresthesias around his perioral sensation, That is due to hypocalcemia. So ionized calcium is around 0.9. Okay, so this is due to hyperventilation. There is decrease in ionized calcium, and there is result to perioral numbness. Okay, so this is all from my side. Some cases are left that we can discuss if required. Okay.
Good evening, everybody. Myself, Dr. Ashok Kumar Bannu, Associate Professor from PGI Chandigarh. In this last session, we will be trying to learn some basic fundamentals of clinical ECG, which we use in day-to-day clinical practice. So, ECG is a graphical representation of cardiac electrical activity. It is an immediately available, inexpensive and non-invasive investigation which remains a key component of the diagnosis and treatment of many life-threatening disorders. However, mistaken false positive or false negative readings may have serious consequences in the management, in the patient management. So you all know that for a normal heartbeat, the stimulus begins at SA node, and after the depolarization of the both atria, it stimulates the AV junction, which is made up of AV node and bundle of His. Bundle of His is further divided into left and right bundle branch, which further depolarizes the ventricles through the Purkinje fibers. Remember that left bundle branch is further divided into left anterior and left posterior fascicles. So this is just an overview of cardiac conduction system. So now coming to the ECG graph. So ECG graph is divided into large and small boxes. Large box is equal to 5 into 5 millimeter square, and small box is of 1 mm. The horizontal axis is denoting the time intervals on an ECG graph. So if the usual recording speed of the ECG paper is 25 millimeter per second, then the large square is equal to 200 millisecond, 0.20 second, and a small square is equal to 0.04 second, that is 40 millisecond, and the vertical axis is denoting the voltage amplitude of the waveforms and the deflections of ECG. So with the standard calibrization, this 1 centimeter vertical height is equal to 1 millivolt. So it is important to see the calibration or standard calibration on the left side of the ECG paper, which is usually noted on the left side of each lead 1, lead 2 and lead 3. So these are the basic components of ECG: 5 waveforms, 4 intervals and 3 segments. 5 waves are P, QRS, ST, T and U. ST is also a segment. QRS is also considered as an interval. 4 intervals: PR, QRS, QT or corrected QT. Usually we correct QT for the heart rate. So it is called as rate corrected QT or QTC, and RR interval. And 3 segments: PR, ST and TP segment. So this 5-4-3 rule is important in determining the ECG abnormalities, in interpreting the ECG abnormalities. So so these are the 5 waves: P, QRS, ST, T and U. U wave is usually a small deflection only, less than 1 mm of amplitude, and in many ECGs you will not able to see U wave. And segments are PR segment, ST segment, and TP segment. TP segment is usually indicating the reference isoelectric baseline. So it is mainly for the use of determining the ST elevation, ST depression, PR elevation, or PR depression. And these are the four intervals. Four intervals, that means that PR interval, QRS interval, QTC interval, and RR interval. You can see that PR interval is starting from the onset of P wave and ending at the onset of Q wave, and QRS at the onset of Q wave and at the J point. J point is nothing but the initiation of the ST segment. When we determine or when we see the depression or elevation of the ST segment, this J point is very helpful. So the onset of P wave is noted by the atrial depolarization, and the onset of Q wave is noted by the ventricular depolarization. So that means that this PR interval is occurring between the atrial depolarization and the ventricular depolarization. And then ventricular repolarization is noted by the J point or initiation of the ST segments. So that means that this QRS interval or QRS wave is between the start of ventricular depolarization and the start of ventricular repolarization. That means any abnormality in the QRS interval or wave is an abnormality in the ventricular depolarization, and ventricular repolarization ends at the end of U wave. So any abnormality in the ventricular repolarization will be seen on ECG as ST segment and T segment abnormalities. So these are the normal reference ranges of the intervals. PR interval is usually 120 to 200 millisecond. That means that it is between 3 to 5 small squares. QRS is less than 100 to 110 millisecond. QT or accurately rate corrected QT is about 350 to 440 millisecond. And RR interval is mainly to determine the heart rate or and the rhythm of the ECG. So heart rate is calculated as 300 divided by the number of large squares between the two R peaks, or with the small squares 1500 upon number of the small squares between the RR peak. So a word about QTC. QTC is usually corrected for heart rate. There are many formulas for QTC, rate corrected QT. However, these two formulas, Framingham and Bazett square root formulas, are widely used. Bazett square root is a classical QTC formula. However, it may be inaccurate for slower and higher heart rate. So in the current practice, Framingham is more accurate. Just note that in Framingham formula, all intervals are in millisecond, and in Bazett square root formula, the intervals are in second. So Bazett square root is also a complex formula. You need to square root the RR. And the normal range, the upper limit of QTC is usually taken as for 40 millisecond for male and for 50 millisecond for female. However, in some texts, it is mentioned as for 50 for male and for 60 for female. Lower limit is further less well defined, and it is about 330 to 350. Usually we take 350 millisecond for defining the lower limit of QTC. QTC is increased in hypocalcemia and tricyclic antidepressant toxicity, and reduced in hypercalcemia and digoxin or digitalis toxicity. These are the basic ECG leads. These 6 chest electrodes will form 6 chest leads on ECG or precordial leads, and these 4 limb electrodes will be forming the 6 limb leads on the ECG. V1 to V3 leads are usually considered as right precordial lead, and V4, V5, V6 are considered as left precordial leads. So this is the normal ECG. Just look at this ECG paper, this ECG. you can see that P and T waves are negative in AVR, otherwise it is positive throughout the other leads. And ST segment is isoelectric, and you can also see that R wave is increasing in height when we travel through V1 to V4. R wave is increasing. In V1, R is lesser than S wave, but further in V3 you can see that R is more than S wave. So there, this when R is equal to S wave, it is called as transition point. It is important to note the transition point. So it is usually between V3 to V4. So this is the normal ECG. When you see multiple normal ECG, then only you can detect an abnormality quickly. So electrical axis and axis deviation, you need not to calculate the exact electrical axis for clinical purposes. That means you need not to calculate an electric axis in degrees like 108 degree, 120 degree, 90 degree. Just look at the lead 1 and lead 2 carefully. If the QRS is positive in lead 1 and lead 2, then more or less the axis is normal. And if the QRS is negative in lead 1 and positive in lead 2, then this is right axis deviation, which is seen in pulmonary conditions, many congenital heart disease, and left posterior fascicular block is also a rare cause of right axis deviation. And opposite for the left axis deviation, when QRS is positive in lead 1 and negative in lead 2, then the axis is left axis deviation is present, and it is seen in hypertension, coronary artery disease. Left anterior fascicular block is a common cause of left axis deviation. So you can also remember it like this, that if the QRS complexes are reaching towards each other, R for reaching R for RAD, and if they are leaving from each other, L for leaving L for LAD. So you can easily calculate easily see the axis deviation. In some texts it is written that we should take lead 1 and lead 3, in some text lead 1 and AVL, in some text lead 1 and AVF, but lead 1 and lead 2 are the best leads to determining the axis and axis deviation, of course. So these 5 abnormalities are best noted on an ECG. There will be many abnormalities which you can note on ECG. However, these 5 are the major ECG abnormalities, that is cardiac enlargement and hypertrophy, arrhythmia, myocardial ischemia and infarction, metabolic abnormalities like abnormalities in serum potassium, magnesium, calcium, hypothermia, pericardial diseases like pericarditis or tamponade. These are the major ECG abnormalities. So we will be discussing some of these major abnormalities. So coming to the atrial enlargement or overload. So first you need to know the normal P morphology. So you can see that the height of the P wave is normally less than 2.5 millimeter, and the width of the P wave is less than 120 millisecond, that is less than 3 small squares. Okay. So the first half of the P wave is made up of right atrium, and the second half of P wave is made up of left atrium. So P wave is upright positive in lead 2. In lead V1, P wave can be biphasic, but the positive deflection will be more than negative deflection. Okay. So in RA enlargement, right atrial enlargement, there will be tenting of P wave. P will be peak, that means more than 2.5 millimeter will be height to call it as a right atrial enlargement on ECG. So it is seen in the many pulmonary conditions and congenital heart disease. And for left atrial enlargement, or better to say left atrial abnormality, because there may be many conditions which can cause similar changes like left atrial enlargement without causing left atrial enlargement. So it is better to say left atrial abnormality rather than left atrial enlargement. So you can see that the width of the P wave is increased, and it can be notched in left atrial abnormality. And in V1, the P will be negative, or the negative deflection will be more than positive deflection to say it a left atrial abnormality. So left atrial abnormality is seen in left valve disease, hypertension, coronary artery disease, and many other myocardial ischemic conditions. Previously, left atrial abnormality is predominantly seen in mitral valve disease. So this P is usually it was usually called as P mitral, and right atrial enlargement is previously called as P pulmonale. So P mitral and P pulmonale were old terms. Coming to the ventricular hypertrophy, so you can see first you need to know the normal morphology of QRS and STT in lead V1 and V6. You can see that there is a small R and a deep S and positive T in V1, and in V6 there is a small Q, then a good R wave and a positive T wave. In RVH, this small r will be prominent. That means that there will be a prominent R in lead V1. So R will be more than S in lead V1, or there will be no S wave, or if there is a small Q wave, then the R wave will be more than Q wave. So these three morphologies of QRS in lead V1 will help you to detect the right ventricular hypertrophy. In left ventricular hypertrophy, there will be a long S wave in V1 and long R wave in V6. There are multiple criteria for left ventricular hypertrophy. This is the widely used criteria, that is S wave in lead V1 plus R wave in lead V5 or V6 should be more than 35 mm to call left ventricular hypertrophy in an ECG. Okay, there may also be associated repolarization abnormality. I told you that repolarization means that some defect in the STT part. So repolarization abnormality may be seen in the right precordial leads in a case of RVH, that means ST depression and T inversion you can find on ECG, that is also called as RV strand pattern. And similarly, in left ventricular hypertrophy, there may be associated repolarization abnormality in left precordial leads. Okay, that is called as left ventricular strand pattern. Similarly, in RVH, there may be associated RAD, and in LVH, there may be associated LAD. LAD means left axis deviation. So coming to the left and right bundle branch blocks. Bundle branch blocks are nothing but disturbances in the ventricular conduction. Ventricular conduction means ventricular depolarization, and you know that the ventricular depolarization abnormalities will be manifested as QRS abnormalities on an ECG. So QRS, the size and shape of the QRS will be altered. QRS will be widened if there is a complete bundle branch block, then QRS will be more than 120 millisecond, and if there is an incomplete block, then there may be a small, just a small prolongation of the QRS less than 120 millisecond, and there will be always secondary repolarization abnormality, STT abnormality will be there. So in right bundle branch block, there will be RSR pattern. Normally there will be RS pattern only, and in right bundle branch block there will be an additional an additional long R wave. So this is called as RSR pattern, and of course there will be secondary repolarization in the right precordial lead, so there will be T inversion. So RSR pattern, or also you can see that it looks like M letter of the English. So RSR or M pattern is seen in the lead V1 in right bundle branch block, and in V6 there will be a deep wide S, so there will be a QRS pattern in right bundle branch block. In left bundle branch block, there will be a wide QS, wide notched QS, and in V6 there will be a wide R with a notched top. So this M pattern is formed in V6 in left bundle branch block, and in right bundle branch block, M pattern will be seen in V1. Okay, you can also remember it as Mero and William. These two mnemonics are also good to remember. Mero means in right bundle branch block, M pattern will be seen in V1, and in V6 there will be W pattern, and in left bundle branch block, W pattern will be seen in V1, and M pattern will be seen in V6. So right bundle branch block is seen in many conditions, congenital conditions like atrial septal defect, valvular conditions, coronary artery disease, and it may occur in normal subjects also without any structural cardiac diseases. However, left bundle branch block is often a marker of one of these four cardiac conditions, that is coronary artery disease, hypertension, aortic valve disease, or cardiomyopathy. So whenever you see a left bundle branch block on ECG, there should be one of these four cardiac abnormality present in the patient. So looking at the ECG STT abnormalities in patients with myocardial infarction, you can detect that which wall is involved. Like in inferior wall MI, there will be STT abnormalities lead 2-3 AVF. That means that the 2-3 AVF is called as inferior leads in a case of MI. 1 AVL, V5, V6 are lateral leads. V1 and V2 are septal leads, and V3 and V4 are pure anterior leads. However, usually we also take V1 to V4 or even lateral leads. Usually we include in the anterior to define the anterior wall MI. Mainly anterior and inferior wall MI you can easily differentiate on looking at the STT abnormality on the ECG. So if a patient presents with chest pain, angina, or ischemic discomfort, and your likely diagnosis is acute coronary syndrome, then you need to see the electrocardiographies that whether there is an ST elevation or not. So if there is a complete occlusion, left image, if there is a complete occlusion, there will be ST elevation, and if there is an incomplete occlusion or partial obstruction, there will be ST depression rather than ST elevation. So no ST elevation, acute coronary syndrome are further divided into unstable angina and an ST elevation myocardial infarction based on the positive biomarkers. And most of the NSTEMI ECGs will not evolve into Q waves. However, most of the ST elevations will be evolving into Q waves in the successive hours or successive days. So around 85% cases of ST elevation in the initial leads will later go into Q wave formation, and 85% cases of an ST elevation MI will not have Q waves on successive ECGs. So like in this example, anterior wall MI, you can see that there is significant ST elevation in lead 1, AVL, V2 to V6, early ECG changes, and evolving ECG changes will show you that in the same leads, lead 1, AVL, V2 to V6, you can see that deep Q waves are coming. And similarly in the inferior ST elevation MI, V2, 3 AVF are showing significant ST changes, ST elevation, and then in the same leads you will see Q wave coming in the successive ECGs or successive days. You can also see ST depression in lead 1, AVL, and V2. So these are reciprocal changes which you see in patients with ST elevation MI. ST elevation is not only seen in myocardial ischemia or infarction, it can also be seen in Prinzmetal syndrome, Tokosubu syndrome, acute pericarditis, Acute pericarditis patients will have diffuse ST elevation. LVH and left bundle branch block can also cause ST elevation. So sometimes that is confusing in an ECG. And there are also uncommon causes of ST elevation. So coming to the tachycardia or tachyarrhythmias, so the major two classes of tachycardia or tachyarrhythmia are based on the QRS complex duration. So if the QRS complex is normal in duration, then it is called as narrow complex tachycardia, and when QRS complex is widened, that means more than 120 or more than 100 milliseconds, then it is called as wide complex tachycardia. Narrow complex tachycardias are sinus tachycardia, paroxysmal supraventricular tachycardia, which is actually a group of many narrow complex tachycardia, including one common example is AV-NRT, that means AV nodal re-enter tachycardia. Atrial fibrillation and atrial flutter are classical example of narrow complex tachycardia. For all practical purposes, when wide complex tachycardia are ventricular tachycardia or ventricular fibrillation until proven otherwise. There are some PSVTs also, like Wolff-Parkinson-White syndrome, which can cause wide QRS complex. So these are narrow complex tachycardia. Supraventricular, first example is supraventricular tachycardia. As an example of AV-NRT, you can see that the QRS complexes are coming at a regular rate of 170 per minute. There will be no P wave visible, but actually P waves are buried into the QRS. So you will not find any P waves. So it is, you can easily differentiate SVT from atrial fibrillation, that the rate is regular, but in atrial fibrillation the rate is irregular. And again, there will be no P waves. These waves which you can see in front of the QRS, these are actually fibrillary waves. So these are not P waves. Atrial flutter, it is easy to diagnose because it characteristically has sawtooth pattern, also known as F waves. So there will be no P waves. Atrial flutter may be regular or irregular. So sawtooth waves are, these negative sawtooth waves are classical for atrial flutter. Okay, ventricular tachyarrhythmias, wide complex tachycardia are ventricular tachycardia until proven otherwise. So these are examples of ventricular tachycardia. If the QRS shape and rate is similar in a given lead, then this is called as monomorphic ventricular tachycardia. When the QRS, in the second example, you see that the QRS shapes and directions and even rates are varying beat to beat. So this is polymorphic tachycardia, polymorphic ventricular tachycardia. And the third example is ventricular fibrillation, which is nothing but very rapid monomorphic VT. So these QRS are similar to the sinusoidal waves. So you can, in the middle, you can also see coarse and fine waves also. So these are life-threatening arrhythmias which you can easily detect on ECG. Bradyarrhythmias, the classification is mainly based on these two pathophysiology, whether there is an SA node dysfunction or AV conduction disturbance. SA node dysfunction will cause sinus brady, sinus arrest, sinoatrial exit block, or tachybrady syndrome. Tachybrady syndrome we do commonly see in critically ill patient in the terminal stages. In AV conduction disturbances, this increasing in the degree means increasing in the severity, increase in the block. 1 degree, 2 degree, 2 degree AV block is further divided into Mobis type 1, 2 and high grade AV block. 3rd degree AV block is complete heart block. So these are some example ECGs of AV blocks, AV conduction disturbances. 1 degree AV block is nothing but prolongation of PR. That means more than 200 milliseconds. Otherwise, the ECG is normal. So every P is followed by a QRS. It is not ORS, it is QRS. Second example is 2nd degree AV block, Mobis type 1, where you can see that there is increasing PR interval. First is normal PR, then in successive lead there is an prolonged PR, and then the P is blocked. So in Mobis type 1, there will be progressive increase in PR interval and there will be a P wave which will be non-conducted. And Mobis type 2, there will be no progress in PR interval and intermittently P will be non-conducted. Okay, so there will be no, in Mobis 1 you can say that there is a warning that PR is progressing and then there will be a P wave will come which will be blocked, but in the Mobis type 2 there will be no progression of PR interval and there will be intermittent blocking of P. In high grade 2 degree AV block, there will be 2 or more P block which will be successively not conducted. Like in the middle you can see that there are 2 P wave which are not conducting, and then there is a third wave which is conducting, that means having its own QRS. So when this conduction ratio, that is P QRS ratio, is 3:1 or more, then you can say that this is high grade AV block. These high grade blocks are practically in clinically for clinical purposes, these all high grade blocks are requiring the pacemaker or external pacing. In third degree AV block, there will be no association between P and QRS. So you can see that some P's are coming between QRS and T waves, and some P's are not conducting, some P is just in front of the QRS. So there will be a complete dissociation of the atrial and ventricular activity. So some example of metabolic abnormalities detected on ECG. So hyperkalemia is a common abnormality which you can easily detect, life-threatening also, which you can easily detect on ECG. So with increase in the serum potassium level, there will be increase in the changes on ECG also. With mild to moderate hyperkalemia, there will be peak or tall T waves which are usually narrow-based. You can also see tall T waves in patients with myocardial infarction, which are called as hyperacute T wave, but they are usually wide-based T wave. In hyperkalemia, there will be narrow-based T waves. So again, if the hyperkalemia is moderate to severe, then there will be a reduction in the amplitude of P wave, or there will be disappearance of P wave, and in very severe cases, there will be widening of QRS. So you can see that the last example is of sine wave pattern. So it is also, you can say that this is also similar to ventricular tachyarrhythmia. So P is prolonging in mild to moderate, T is prolonging in mild to moderate, then P is reducing in moderate to severe, and very severe there is increase in QRS duration. Hypokalemia, the initial changes of hypokalemia will be flattening of T and prominence of U wave. U wave you can also normally detect on ECG, but the deflection will be less than 1 mm, but in hypokalemia there will be prominence of U wave. U wave is typically seen in V2, V3 lead. So these leads are better leads to see the U waves. And if the severity of hypokalemia increases, then there will be ST depression and T inversion. Hypocalcemia and hypercalcemia, you know that causes QTC prolongation and QTC shortening respectively. So this is my last slide of this presentation before going to the questions and your test. So when you interpret a clinical ECG, you should remember this 5-4-3 rules. That means there are 5 waves, P, QRS, ST, T and U, and if there are any other abnormal wave like Q wave, like Osborne J wave, delta wave in WPW. So any other abnormal wave is also need to be detected. Intervals, 4 intervals, PR, QRS, QT, QTC, QT or QTC, and RR. RR interval is mainly for heart rate and rhythm of the heart, and 3 segments, PR, ST, and TP. TP is mainly acting as a baseline isoelectric reference. So this 5-4-3 rule is important to interpret the clinical ECG. Plus you also have to look at the technical features like lead placement, like any artifacts which we usually see in patients who are critically ill in ICUs, and standardization, calibration is also important. So calibration signal need to be checked need to be checked on the left side of ECG. Okay, these are my references and further readings, recommended further readings. And thank you. We can take one or two questions, and after that, you sir, please distribute these ECGs. There are 20 ECGs which I am distributing among you. So you just look at those ECGs. If you have any question, you can ask. Okay, so this is case 1. This is a 25-year-old male, comes with palpitations and dizziness. So what is your diagnosis? What is your interpretation? SVT, supraventricular tachycardia. So you can see that the heart rate is around 200 to 250 millisecond, and there are narrow complexes. So this is narrow complex tachycardia, and there are no P waves, but these QRS rate, this QRS rate is regular. So this is not atrial fibrillation. So this is supraventricular tachycardia only. Okay, so P wave is difficult to discern because it is usually embedded into the QRS. So this is supraventricular tachycardia. This is again a 25-year-old male, palpitation and dizziness. This is also a supraventricular tachycardia. So why I put this ECG? Because I wanted to show you that in lead V1 you can see some pseudo R waves, and in lead 1 and lead 2 and lead 3 there are pseudo S waves. So these pseudo S waves are nothing but P waves, which are which are just after the coming after the QRS. So pseudo S and pseudo R waves are P waves only. So these can be seen in ECGs of supraventricular tachycardia. Okay, so this is a QRS rate is 300, rate is 300 per minute, and narrow QRS, this rate is regular. P can be seen at the end of QRS as pseudo R or pseudo S waves. So this is supraventricular tachycardia. This is a 45-year-old male with dyspnea on exertion. Okay, so this is not LBBB because QRS complex is narrow. This is not widened. Okay, this is not DCMP because DCMP means there will be low QRS complexes, low voltage QRS complexes. So what is the definition of low QRS voltage complexes? So there will be less than 1 large square QRS in limb leads and less than 2 large square QRS voltage in the chest leads. So this is left ventricular hypertrophy, which you can easily detect with SV1 plus RV5 or RV6 is more than 35. That means 7 large square. This SV1 plus RV5 or RV6 is equal to more than 7 large square. So this is left ventricular hypertrophy according to the QRS voltage criteria. You can also see that the left precordial leads are showing LV strand pattern or repolarization abnormality. It is T inversion. In V5 and V6 you can see the T inversion, which you can also see in lead 1 and AVL also. Okay, the axis is normal. You can also see the calibration on the left side. This calibration signal is important to note, and it is covering, it is comprising the 2 large square, that means 10 millimeter. It is important to note. Okay, and PR interval is less than 5 small squares. So otherwise it is okay. This is left ventricular hypertrophy. Okay, so T inversion you can see. Okay, what is this? Is this hyperkalemia, LVH or something else? Yes? Hyperacute T. Okay. So you did not see the calibration signal. See, the calibration signal is large, is double of the normal. So this is not LVH. This is these T waves are not tall. So calibration signal causes a deflection of 2 centimeter, which usually causes 1 centimeter deflection. Okay, this is over calibration. Okay, this is the case we encountered in our emergency during COVID time. 41-year-old female which was admitted with acute dyspnea with fever after hysterectomy. So can you diagnose this case, this acute dyspnea, based on ECG? So this is classical characteristic abnormality for pulmonary embolism. You can see that S is present in lead 1. In lead 3 there is Q wave, and in lead 3 there is T wave. And there is also sinus tachycardia. So S1, Q3, T3 plus sinus tachycardia in a given situation is most likely pulmonary embolism. This patient was also having Pallad's sign, and there was left pulmonary artery blockage. Okay. So this 32-year-old male with progressive dyspnea for 2 months. Pericardial effusion, electrical alternance. So you can see that the QRS complexes are, the changes in height and even in the axis, beat to beat variation is present. So this is seen in the cardiac tamponade or large pericardial effusion, because the actually heart is pounding in a fluid sac. So when it comes near to the chest wall, then it produces a good amplitude of QRS, and when it is away from the chest wall, then it causes a low QRS voltage. So tachycardia is also there. The RR peaks are coming in less than 3 large squares. So tachycardia is also there. Electrical alternance is present. QRS complexes are small most of the time, but alternatively they are large. So if suppose they are throughout low voltage, so this will be forming the triad of electrical alternance. That means low QRS voltages, sinus tachycardia, and electrical alternance. Okay, so triads are always important in clinical medicine. 76-year-old male with congestive heart failure. Okay, again this is narrow complex tachycardia. and the rate is not regular, there is no P wave. So this is atrial fibrillation. Okay. 68-year-old male with history of smoking and palpitation on rest. So characteristic F waves or flutter waves, you can see negative sawtooth waves. So these are characteristic of atrial flutter. Okay. There is a ratio of 4:1, 4 F wave to 1 QRS. 70-year-old male with severe chest pain. So you can see that the significant ST elevation in lead 1 AVL, V2, V3, V4 and even in V5. So this is anterolateral ST elevation, myocardial infarction. So Q waves are not seen. You can also see that left axis deviation is also present. In lead 1 QRS is positive, in lead 2 QRS is negative. So left axis deviation is also there. Tachycardia is there. You can also see that R waves are not coming till V4 or V5, so there is also a poor progression of R waves. However, the main important finding is ST elevation MI, anterolateral. Okay. So this 45-year-old male, current smoker with dyspnea on exertion. Okay, left axis deviation you can easily note because QRS is positive in lead 1 and negative leaving. QRS are leaving from each other. So LAD is definitely there. And there are poor progression of R waves also. You can see PR is prolonged, yes. So first degree heart block is also there. So there are 3 abnormalities. One is LAD, second is poor progression of R waves, and one degree heart block. Poor progression of R waves are seen in many conditions, even chronic lung disease, ischemic heart disease, many other conditions also. So this patient might have underlying coronary artery disease because of LAD and this PR prolongation, 1 degree heart block and poor progression of R. Okay, 68-year-old male with chest pain for 1 day. So these are typical valence T waves. So deep T waves in V2 in chest leads basically, especially in the V2, V3, V4. These are the leads when where you need to see for valence T wave. So valence T waves are characteristic for significant obstruction in the left anterior descending artery. So LAD obstruction is the diagnosis if you do coronary angio in this patient. So left anterior descending artery obstruction will definitely be present. 45-year-old male with chest pain 2 days back. So you can see the significant prominent Q waves in lead 2, 3 AVF. So that means that this patient was having ST elevation MI in the inferior wall, and now the Q wave formation has established. This is normal sinus rhythm, normal PR and old inferior wall MI. 56-year-old male, current smoker with chest pain. So in V1 to V5 you see ST depression. So this is non-ST elevation myocardial infarction. Okay. We cannot say myocardial infarction until we have cardiac biomarkers actually. 65-year-old male with dyspnea or palpitation on exertion. So you can see that in the lead V1 or in many leads, QRS is prolonged, QRS is more than 100 millisecond. So in lead V6, you can see notched R wave, which is better seen in actually lead V4, where you can also see an M pattern. So M pattern is forming in the left precordial leads, and there is also T inversion in left precordial leads V5 and V6, and also in V1, in lead 1 also. So this is left bundle branch block. Okay, PR is normal, axis is normal. Okay, this is 65-year-old male with dyspnea on exertion. Okay, right bundle branch block can easily be detected in lead V1. So you can see an M pattern, that is R as R dash pattern, T inversion in the right precordial lead. In lead V1 and V2, you can see T inversion also. So that means that repolarization abnormality, STT abnormalities, T inversion. So this is right bundle branch block. And you can also see left axis deviation. Lead 1, QRS positive, lead 2, QRS negative. So QRS is leaving from each other. So left axis deviation is also present, and you know that one of the common cause of left axis deviation is left anterior fascicular block. So right bundle branch block plus LAFB is equal to bifascicular block. So this is bifascicular block. So these blocks can be seen in ischemic heart disease. Okay, 55-year-old female obese with dyspnea and pedal edema. So there are prominent R waves in lead V1. Prominent R waves means right ventricular hypertrophy. This is an obese patient, so likely she is having obstructive sleep apnea, and because of that she is having dyspnea and pedal edema. So right ventricular hypertrophy is quite obvious in this patient. You can also see right axis deviation also. So right axis deviation means in lead 1 QRS is negative and lead 2 QRS is positive. So right ventricular hypertrophy plus right axis deviation, and there is significant T inversion in right side precordial leads. Even you can also see in the left precordial leads also. So this is a triad of severe pulmonary hypertension. So that means that prominent R in lead V1, RV strain pattern, and RAD. So this is an ECG triad of severe pulmonary hypertension. Okay, this is 82-year-old male with dyspnea, angina, and dizziness. Yes, complete heart block. You can see that QRS complex is wide in lead V4 or lead 3. You can see that P, lead AVF, you can see that P is not conducting, and there are some P waves in between also, and there is no association of P and QRS activity, so there is a complete dissociation. So this is complete heart block. You can also see that lead V1 is having M pattern, so right bundle branch block is also present, and axis deviation is also there. Right axis deviation is also there. So this is complete heart block. So this is wide complex tachycardia. Tachycardia you can easily see. So this is monomorphic VT. In one lead, the QRS morphology is similar, same. So this is monomorphic VT. So no P waves, regular QRS rate 200, broad QRS, abnormal shape is also there, and no identifiable T waves. So this is VT, monomorphic VT. So you can see that QRS complexes are also widened in this patient intermittently, and in multiple successive complexes are widened. So this is polymorphic VT actually, because the shape and rate of QRS, the direction of QRS are changing beat to beat, and you can also see ST elevation in lead 3 and lead AVF. Yes, AVF and lead 3 are showing ST elevation, so this is in the setting of inferior wall MI, this VT is happening. This is a 26-year-old male with no symptoms. Okay, so this is not VT because the subject was not relaxed during the ECG, so these are just sharp irregular waves which are more prominent on the limb leads. So sometimes these pattern can be misdiagnosed, especially in the critically ill patients in intensive care units, when you see monitor with these fibrillary waves and you, or sharp waves, and you can diagnose ventricular tachycardia or tachyarrhythmia. Thank you.
I just have 2 things to tell you before we go back and relax and prepare ourselves for the next day. So can I have my slides, please? So I have to stand like this, then only I can be visible. Can I have, please? So this is the results, most awaited part of whatever was done today for February 3rd. So let us go and see what all we got. Okay, should I move from here? No, I'm not able to. Please give me the command. So this will include, right? Yeah. So the winner of the future EM competition. So we had some 5 faculties in the morning who are established assistant professors in various medical colleges, and they spoke on their favorite topic, and there was a tie of just 0.5 marks, 0.5 mark difference between 2 people, and that is when, okay, so this is where, you know, when you enter and your name is there. A big clap for Dr. Sandeep David. And with him, because as I said, it was just a 0.5 marks different, is Dr. Keyur Shah. Okay, I don't know Dr. Keyur is here or not. So coming next for the paper presentation, in which Dr. Sabha had done 2 papers, Dr. Himanshi, Harismita, Dr. Binu, and Dr. Shrikar Yadav has done. So the winner is Dr. Himanshi Bed from AIMS Rishikesh. I think so, she spoke on focus. Dr. Himanshi, are you there? Yes. So Dr. Himanshi is here. Next was a young faculty talk in which Dr. Kasturi, Dr. Himanshi, Dr. Anjala, Dr. Aditya, Dr. Divya, and Dr. Prashant has spoken. And the winner is Dr. Aditya. Dr. Aditya, are you there? Yeah, he's there. So what we have done is we have added the marks given by the 2 judges, and then we have divided it by 2, and that's all. It's been very fair. All these are in my bags. So then there was downstairs the first e-poster competition where Dr. Akhileshwari, Dr. Riya, Dr. Yashaswini, Dr. Jami, Dr. Shruti, and Dr. S.S. Kaushik did their poster. And the winner is Dr. Yashaswini. Is Yashaswini there? Hey, yes. Yashaswini, what was your topic? Super. So, and which college are you from? Sorry. Which place are you from? Great. Then was an e-poster competition where Dr. Tom, Dr. Anup, Dr. Mani, Dr. Rudra Rupesh, Dr. Binu, and Dr. Ankit had spoken. And the winner is Dr. Rudra Rupesh Reddy. Dr. Rudra is here? Okay. So his friends will convey it to him. Yeah. Then there was another e-poster where Dr. Dayashri, Dr. Divya, Dr. Tilak, Dr. Chinnadurai, Dr. Sivakumar, Dr. Manaswita, Dr. Rajavel, Dr. Naveen, and Dr. Manish Pranav was there. So one we are telling today. The second one, because there are more than 6, will be coming tomorrow. So their numbers are with me. So then there will be 2 in the list, because there are some 3 more who will be doing e-posters tomorrow. And the winner is Dr. Tilak. Dr. Tilak, are you there here? No? So please inform Dr. Tilak, your friends. And then there was an e-poster where Dr. Mahesh, Dr. Suman, Dr. Anjali, Dr. Janvi Kabala, Dr. Abhishek, and Dr. Binu had done. And the winner is Dr. Anjali PU. Dr. Anjali, you are here? No? So all of you have to inform. You must be knowing each other. You are students here. So then there was a young faculty talk which happened here only. Dr. Somya, Dr. Satish, Dr. Mario, Dr. Jishmi, and Dr. Sabira Sithi was there. And the winner is Dr. Mario. Mario is there. Big round up. Yes. And there were paper presentations. Dr. Vivek, Dr. Avichal, Dr. Mani, Dr. Shruti, Dr. Amoga Varsha, Dr. Sangeeta, and Dr. Abhishek Kumar has done this. And the winner is Dr. Abhishek Kumar. Abhishek is here? No? Yeah. PGI guy, no? Yeah. So please inform. Then there was another session of paper presentations. Dr. Izaz, Dr. Shamna, Dr. Sabrina, Dr. Aishwarya, Dr. Akshata, Dr. Silpa, and Dr. Salva Amina had done that. And Dr. Akshata won this round. She's here. Akshata, what was your topic, please? Alport syndrome. Yes, yes. So there were virtual paper presentations also happening down. We have done for 5 today. We'll be doing for 6 more tomorrow. And Dr. Vishaka, Dr. Shraddha, Dr. Malika, Dr. Pranjul, and Dr. Bhumi have done. And the winner is Dr. Bhumi Motwani. So we'll inform her, whosoever knows her, otherwise I'll. So friends, see you all tomorrow. Thank you. Now when the medals would be given, at the time when the chief guest would be coming. So it would be better if you get through the hands of big people. So we know, I think so all of you know there are award of honor medals, but we decided that the chief guest is coming tomorrow, so we'll honor you at that time. If you are going away before that, please contact me. I'll hand your medal to you now itself. Yeah? Anyone of these names leaving for today? Yo, Himanshi is leaving. So Himanshi would come to you. So other than that, all of you, please wait for the medal ceremony, award ceremony. Yeah? Thank you. Thank you, sir.